Hello, 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 check 1 2. Hello, check mic test. Hello, check 1 2. Mic test. Hello, check, check.
कोरियन में चालू कर दिया। हेलो चेक चेक बराबर।
Hello, check, mic, check, 1, 2, 3, check. Hello, check, 1, 2, mic, check, hello.
हाँ अभी चालू है।
Hello, check, 1, 2, mic, check, hello.
ये वाला लाइट बंद कर देते हैं जब चालू रहता है तो एक बार दिखाना बंद कहाँ से होता है? नहीं अभी अभी बंद है मतलब। अच्छा बंद के बाद भी बहुत कम दिख रहा है और डार्क नहीं हो सकता यहाँ पे। इसका डिमर भी है क्या? लाइट को थोड़ा डिम कर सकते हैं तो, क्योंकि लाइट बहुत ज़्यादा है अभी भी हॉल में। हाँ और डिम कर लें। नहीं कोई बात नहीं, कैमरे में नहीं चाहिए, वो ऑडियंस को दिखना चाहिए, बहुत ज़्यादा ज़रूरी है। इतना डिम ही रखना पड़ेगा प्रेजेंटेशन के वक्त ना, क्योंकि नहीं नहीं वो प्रेजेंटेशन हमारा रेडियोलॉजी में सिर्फ इमेजेस ही देखने की होती है। हाँ कम कर दो, कम रखना, कम ही रखो। वो ठीक था बिल्कुल, एकदम इमेज दिखना चाहिए ना, वहाँ से समझ नहीं आएगा अदरवाइज। और इसका प्रोपोर्शन ठीक नहीं है, ये जो प्रेजेंट हो रहा है स्लाइड, इसका इसका जो रेशो है ना 16/9/16 डिस्प्ले नहीं है ठीक। ऐसा जैसा चेस्ट एक्सरे देखो कैसा आ रहा है, चेस्ट एक्सरे कैसे आ रहा है ना, डिस्प्ले इनकरेक्ट हो रहा है, लैपटॉप पे ठीक आ रहा है। हाँ नहीं वो देखा, वो जो 9/16 डिस्प्ले होता है ना, आपका ओल्ड वाला में चल रहा है, 14 वाला है, इसमें रेक्टेंगल टाइप डिस्प्ले है, इसमें स्क्वायर आ रहा है रेक्टेंगल। हाँ ऐसा ना, इससे समझ में आया टेस्ट एक्सरे कैसा नैरो हो गया ना इनको सब। हाँ नहीं वो यहाँ देखो ना, ये डिस्प्ले और प्रॉब्लम है। देख इस पे ठीक है, इधर देखो डिस्प्ले, इसका देखो डिस्प्ले, ये फर्क है। क्वालिटी का नहीं है, वो स्क्रीन रेशियो होना रहेगा, क्वालिटी थोड़ा टूटा है, ज़्यादा रहेगा थोड़ा ही। अभी ये लाइट चालू कर दिया ऊपर फर्स्ट वाला, ये हाँ नहीं पर ये लाइट तो बंद चाहिए ना, स्क्रीन पे लाइट आएगा तो दिखेगा ही नहीं वैसे कुछ भी। या तो आप पहला मिनट फोटो ले लेना एक आध, फिर ये बढ़ा दिया पीछे का। अच्छा चलो ये ठीक है फिर भी, मतलब अभी ठीक है वैसे ना डिस्प्ले। एक बार दोबारा करना डिस्प्ले। अच्छा ठीक करें। हाँ अब ठीक है, अभी बराबर हुआ, अभी बराबर है। ये 9/16 हो गया ना। हाँ पहले गलत, कल गलत चला दिया पूरा। है? नहीं 16/9 ही चलता है आजकल ना सब, लेटेस्ट तो 16/9 ही है हर जगह। नहीं 16/9 हो गया, क्योंकि वो बनाया भी उसी पे हुआ है ना, सबका 16/9 पे ही बना हुआ प्रेजेंटेशन। मॉर्निंग। थोड़ा इसको बड़ा कर सकता है स्क्रीन को और। अच्छा प्रोजेक्ट को पीछे करना पड़ेगा थोड़ा, प्रोजेक्ट को थोड़ा पीछे करना थोड़ा सा, कुछ पीछे होगा। तो इसको भी ना मतलब थोड़ा सा पीछे करके देखो, देखते हैं। नहीं नीचे हो रहा है, लेवल नीचे हो रहा है, वायर के ऊपर रखा हुआ है ताकि वो लेवल ऊपर रहे। हाइट देखिए ठीक लग रहा है, थोड़ा नीचे करें हल्का सा, हाइट ठीक है वैसे। हाँ हाँ ठीक है, बराबर है।
નીચેથી હા
हेलो माइक चेक
સાઈડ ની ચાલુ કરી દેતા, આ તો ચાલુ ના જ કરતા. વચ્ચેની બંધ થાય ને તોય બહુ છે. બધી દબાઈ ને સાઈડ
कर दिया सेट बराबर. हो गया.
हाँ ये मेरा मतलब
Good morning, everyone. Welcome to Hall C. We are starting with the first session, the ultrasound session. And our moderator today is Dr. Jatinder Pal Singh. Sir is Director of MSK Radiology Medanta Medicity Gurugram. And sir has special interest in sports imaging and interventions.
Thank you. Good morning, everybody. So we'll be starting with the first session of today, which is the second day. So I would like to invite the chairpersons on the stage, Dr. Sheetal Patel and Chaya Bhatt. And you can introduce the first speaker and then we can kick off.
Good morning, everyone. We introduce the first speaker, Dr. King Kenneth Cheng, and he is consultant radiologist and honorary professor, associate professor at North District and Prince of Wales Hospital, the Chinese University of Hong Kong. And he is at present AMS treasurer and president-elect.
Thank you. Thank you very much. Good morning, everyone. So I'm Ken from Hong Kong. It's very nice to see you here. And first of all, I'd like to extend my thanks to the organizing committee, Encore and Trishi, for doing such a fantastic job. It's my first time here in India. I'm just completely overwhelmed by the hospitality and the warmth. And it's really lovely to meet new friends and also see old friends here as well. And thank you for the kind introduction as well. So today I'm going to kick off with the ultrasound session, focusing on the finger and especially finger injuries. I think some of you might have been to the ultrasound workshop a few days ago and you pretty much learned all that you need to. I always think that ultrasound is best learned, practical when you're actually doing hands-on, but it's always tricky to learn hands-on of pathology. It's hard to get a whole array of different patients in one day. So this is just a bit more of a supplementary session focusing on looking at the injury and the imaging pattern of the more common finger injuries. And now I'm going to just go through a little bit of the pearls and pitfalls that I've learned throughout my years. And hopefully that will give you some ammunition to tackle your daily job as well when you come across some common finger injuries. So this is my content. I'm just going to spend a few minutes on just a general approach, so not injury-specific topics, but just things that you can tailor and to adjust and fiddle with your probes, your technique and your setting and patient factors to try to increase your diagnostic easiness and also confidence as well, so that you get pretty images and you're confident in your diagnosis, and that you can also show what you want to show to your surgeons, which is quite important, so they're well informed. Now I'm going to move on to the more injury-specific issues, and I've broken that down into 5 different sections. So we're going to go through the flexor compartment first, and then looking at the fuller plate, the pulley, and then we're going to go back to the extensor mechanism. And finally, because the thumb, we see that quite a lot as well, and it's a slightly different anatomy to the rest of the digits. So we're going to focus a little bit on the thumb as well. So probe, I think you're all aware, when we're looking at the fingers, we're looking at very superficial structures. So, there's a no-brainer that you should be picking an appropriate probe. And I see my trainees, they're always stuck with a 12 megahertz probe, and they don't move away from that. So I'm a big advocate of fiddling. So I believe that you should be adjusting your settings. Of course, you have your standard protocol setting in your ultrasound machine. But I think still, depending on the patient and the anatomy that you're looking at, you should be choosing your probe wisely, and also you should be just adjusting your depth, your time gain. And if you're doing Doppler, you should be adjusting your Doppler scale as well, just to be sure that you're picking those really low flow synovitis. So my go-to is 12 or even 18 big linear probe for the flat surface stuff. Okay, so if you're looking at the palm, at the flexor, you're trying to do dynamic study, there's really no need to use a hockey stick, because you can rest your linear probe quite nicely on the palm flat, and you get a very nice mapping, and also the surgeons quite like those pictures. Conversely, if you're actually looking at bendy or bony landmarks, for example, you're looking at the joints, then the big linear probe is not going to be very helpful, because you only got very limited contact. There are a few ways to go around that. So you can go to your hockey stick, put a nice gel gap, and so this is a technique that I like to use. So for stability, I like to just put my finger, just use part of my finger as a little gap, So you're resting your hockey stick onto the gap, and then you have a bit of gel as well. And that's particularly useful, not particularly for injury, but for looking at synovitis, for example. That could be quite subtle. And if you're actually floating your probe on top of the jelly, rather than having a very fixed base onto your finger, then your Doppler signal is not going to be very nice. It's going to be all over the place. So that's something that I found useful. There's been other techniques that's been reported by literature and also used by some of my colleagues. So probably less common. So in the emergency department, sometimes they fill up a glove, with water, and that gives you a very nice full contact when you're looking at non-flat surfaces. And this is something new to me when I was actually going through this talk. I wasn't aware of this, is that you can submerge your probe in a water bath. So therefore you get a lovely picture like this, so there's full contact. But again, this is not something that I tried. Personally, I find this mostly sufficient just by using a gel gap and just manipulating with your finger. But I think if you're producing a nice picture for a book, a publication, or if your surgeon love to see the pictures, then maybe that's something you can try. So, but make sure with your manufacturer that your probe is fully submergible. You don't want to be wasting a lot of money then breaking the probe when you're putting a probe in the water and then it kills it. Okay, so that's quite interesting, I thought. The other thing is we need to know anatomical landmarks. So you're probably aware that there are different zones for the flexor and also the extensor compartments. So in the flexor, on the hand up to the wrist, there are 5 zones. Okay. And on the back, on the extensor, there are 7. And just because the extensor mechanism is a little bit more complicated, so you have 2 additional zones at the joint. Okay. So for the extensor, it may seem a bit overwhelming. There's so many zones, but for the zones 1 to 5, if you think about it, it's like the reverse of your pulleys. Okay. So the pulleys, it will be MCP, will be A1, A3, and then A5. The zones are the opposite. So at the distal joint, the DIT in the dip, that's going to be zone 1. The PIPJ will be zone 3, and then MCPJ is zone 5. So that's how I remember it. And it's very useful to surgeons, so you don't have to muck about with measuring from the head of the metacarpal to try to give them landmark or distance. If you mention the zones and just give the nearest bony landmark, that's normally enough information for the surgeon to know quite precisely where the injury is. Of course, if you're very close friend with surgeons and they're seeing the patient straight away, you can always do a little permanent marker, and that will alleviate any uncertainty of where the location of the injury is. So going down to imaging settings, so I've mentioned a little bit before already. Again, we're looking at superficial stuff, so please make sure that you're not just using a lot of depth unnecessarily. Just reduce your depth, adjust your time gain. I'm a big advocate for comparison. So if we're looking at pathology on one side, it takes 5 seconds to just quickly scan on the other, and it gives you a very powerful, mental reference for what is normal and what's abnormal. And you can put it on the split screen. Again, if you have untrustworthy or not very trusting surgeons, you put it on the split screen and it shows them clearly that it's pathological. Okay. Panorama, I absolutely love. Again, I think for the flat surface stuff, a wide footprint linear is definitely better than panoramic. Sometimes if they have a fixed flexion deformity, for example, that might not be possible. So if you then have a hockey stick and then use a panoramic, that produces a very nice long axis view as well. I mentioned a little bit about Doppler already. My tip is that if you're looking for inflammation or synovitis, then make sure that you use the microflow if you have that setting in your ultrasound machine, because that's much more sensitive. If you don't, then just make sure that you turn the Doppler scale down. So I'm not talking about gain. The scale is quite important, because often I see my juniors, where I walk in checking on their case, the Doppler scale is up to like 18 or 10 centimeters per second. There's no chance to see any subtle synovitis if your scale is that high. Right, so let's move on to the actual, mechanism and injury itself. So before understanding the injury, we should know a little bit about the sonoanatomy and also how to approach the flexor mechanism. So I've stole this from a nice paper by Ariata, so from a book. Actually, it's a very nice book. So what they've done is they've taken different sections of the axial slices at different levels down the finger on the flexor compartment. So just very, very briefly, because I know this is not a sonoanatomy talk, but we've got the flexor digitorum superficialis and then the profundus. So they started out in the normal configuration, and when they pass it through the A1 pulley, they start to taper and thin, and it becomes snug to the bone when they go through the A2 pulley. And then when they get to the PIPJ, through what we know as the camber chiasm, that's when the superficialis split open, okay, and the profundus is now at the same level of the superficialis. Then the profundus then protrudes through the chiasm, through the hiatus, and then the relationship is then reversed when you get to the PIPJ and the middle phalanx. And then ultimately the superficialis will actually insert somewhere in the midsection of the middle phalanx, while the profundus then carry on to be the only tendon left, and then that goes on to insert to the base of the distal phalanx. So just a very brief reminder. So you can see that the injury can happen along anywhere through that flexor compartment. And so some of the perils that when you're assessing it, it's very useful to try to isolate one of the joint, because then you can see the differential sliding of the superficialis and the profundus. So what I do is, I just isolate the DITB, and then I flex that. Then you will see the profundus differentially gliding, and then if you're flexing the PIPJ, then both the superficialis and the profundus will be moving. And that's particularly useful if there's a lot of acute soft tissue edema and tissue disruption, and your view is not very, very clear. Then by doing that, you can very clearly see whether the injury is involving one or both the tendons. And here's just a little video to show that. So this is what I expect to see when you're flexing the PIPJ, so both tendons are gliding. So the first one is the tear, the laceration, and I'll just have a very brief bit on the post-repair. So it's normally quite easy to diagnose, okay? So here you can see that there's a big gap in between. There's loss of continuity of the fibular appearance, and there's a big gap here. And down here you can see there's the superficialis and then the profundus, and then the superficialis, you can see this very ill-defined and kind of retracted tendon with a bit of fluid surrounding it. So most of the time, flexor tendon doesn't pose a very big diagnostic challenge. And as I said, some of the imaging power is that you should do it dynamically. So by isolating the two joints and moving the tendons, then you can actually accentuate the gap of the tear and make it much easier to see. Sometimes, as I mentioned, if it's a very acute injury or if it's a laceration with a big gap, an open wound, it's very hard to put a probe on that patient, okay? So, so that could make ultrasound quite challenging in the acute phase in lacerations. And just a little bit on the post-op. So this patient actually had the tendon repair. You can see the linear structure here. That's the suture. And at first glance, you can see that the tendon is actually continuous. But you can see compared to the first video that I show you, where they show the normal gliding of the tendons, this one, even when I'm trying my best to flex it, it's not removing at all. So that's quite a common finding in post-op, is that there's a lot of adhesion. So the patient might have undergone a successful repair, but functionally they're still inadequate. So just something to be aware of. For jersey finger, that's quite common for rugby players, for example, or if you are fouling in football, not playing clean, so you're trying to pull people's shirt. So that's a fulsion injury, so force extension when you're trying to actively flex. And what happens is that then that tears the flexor tendon at zone 1, so just around the middle phalanx, proximal to the brevis, or the most distal vinculum. So in the flexor compartment, we've got it's been reported to be 3 vinculum that holds the profundus tendon in place. So what happens in jersey finger is that both the tendon is torn and plus or minus a various degree of vinculum injury. So you can appreciate that depending on the number of the vinculum tear, that dictates how far back the tendon gets retracted. So one of the common mistakes or pitfall is that you look at the bottom and you say, oh, I can't actually find the tendon, because you're expecting the tendon retraction not to be that significant because it's just a small tear here. But if all the vinculum are actually ripped, then you can see that sometimes the tendon retraction can be actually very, very marked. So you have to beware and look a bit further back proximally. Okay. And some pitfalls, as with any tendon tear, the tendon sheath sometimes, if it's a little bit chronic as well, there could be some tenosynovitis and some debris and that could actually mimic a tendon. So just again, dynamic assessment would be quite useful. Coming on to the pulley, so that's very common in rock climbers. So they're often putting their whole body load onto one or two fingers. Okay, and that's a very, very high load on the fingers. And what we see is that there's the abnormal bow stringing. So it's like you're stringing a bow. So the phalanx is the wooden part, and then the pulley is the string part. And that is the tendon is instead of its normal configuration, where it's snug to the bone, it's lifted off the volar aspect of the phalanx. So normally we look at the tendon to bone distance at around the distal edge of the A2, okay, and also at the midpoint of the proximal phalanx. That's normally quite a good place to look at the separation. If it's more than 2 millimeter, or you can see a lot of fluid swimming around there, then there's a high likelihood that there is a pulley injury. So the best way to accentuate that bone to tendon distance is by resistive flexion. So you put your hand or your finger onto the distal phalanx, and then you're asking the patient to resist and then to try to flex, and that really that lifts up the flexor tendon and accentuate the pulley injury. So if you don't do that, then if it's a very subtle pulley injury, then you might not see it, because if it's in complete extension or inadequate flexion, the tendon doesn't get lifted off the bone. I was told that I have a bit time, so I should carry on. So for the volar plate, so the volar plate, you can find it in the PIPJ and also the DIPJ. So very commonly, these are injured in ball sports. I personally had one, so I was trying to stupidly catch a rugby ball that was about 5 stories high, landed on my thumb, and then pulled back. So my volar plate was completely ripped. Glad to say it's all recovered now, so as you can see. So yeah, sometimes that can be associated with dislocation, and also plus or minus bony avulsion, and that's often a forced hyperextension injury of the finger. And again, that's normally quite easy to diagnose. So here you can see the normal volar plate here being held in place, just draping over the phalangeal head, and you can see the cartilage and then the fluid on this beautiful image. And here at the bottom, you can see this is abnormal. So the volar plate clearly now is not sitting and covering the phalangeal head anymore. Instead, now it's actually retracted and slipped back proximally. Okay. So most of the time, it doesn't pose a diagnostic challenge, but there's some pits and pearls people they should be aware of. So the image on the left here, you can see the volar plate here. It looks definitely less well defined compared to the normal, and there's a fluid cleft in the mid-distance substance of the volar plate, and that is highly specific for a tear. So they don't have to be retracted all the time. And you can also see the associated post-traumatic edema around here as well. One of the things that you should be aware of is this cleft here. So this, in the experience, or if you are not aware of this structure, then you might be tempted to call this a tear, because it looks like it's separated from the base of the phalanx. This is normal. Okay, it's a known recess. So you can actually see that quite nicely on MRI most of the time as well if you pay attention. So it's actually attached just by the thin attachment to the bone. So the volar plate is not attached to the base of the phalanx on its thickest part. Actually, it tapers, and there's an elongated thin fibers that attach with quite a wide attachment to the base of the middle phalanx. So please remember this and don't call this a tear. So I am a bit short of time, but I'll take another 5 minutes or 3 to 5 minutes just to go through the extensor and the rest. So for extensor mechanism, just a very brief recap of the extensor. So going from proximally, you have the common extensor tendon, and then you have the contribution from the interosseate and also the lumbrical muscles that forms the extensor hood, or what we call the surgical band. And as we approach the PIPJ, then the central slip then it goes down the midline and then insert to the base of the middle phalanx. Whereas in the lateral bands, they go on the side of the central slip, forming a distal or the terminal tendon, and then inserting at the base of the distal phalanx. So as you can imagine, if you're trying to put a probe in the center here along the middle phalanx, the midline, you're not actually going to be able to see any tendon. All right, so just be aware that here, if you put a probe here, this is what we expect to see. So you see that the central slip is actually attached to the base here of the middle phalanx. Whereas if you move the probe slightly to the side, okay, then that's how you visualize the lateral bands. Okay, and then you can see that there's no insertion to the middle phalanx, and it's moving and keeps going to the distal phalanx. So mallet finger, normally you don't need ultrasound to do that. It's quite obvious. You have a deformity, and that's a tear of the distal or the terminal tendon, and that's avulsed. Okay, that could be associated with also with ball injury as well. So again, a hyperflexion injury. So perhaps, yeah, if you dynamically flex the DIPJ, then you should be able to see that tear nicely. So here's just a nice video to show that if you have it on extension, you can appreciate the gap here. But as soon as you start doing the flexion, you can see this is just an empty tendon sheath, and then the tendon stum is actually retracted right there. Sometimes you can see the avulsion quite clearly as well, so that makes the diagnosis much easier. I think I'm going to skip this one. So this, I think, people are quite aware of this. Is quite a common injury. So the description of the central slip, and what happens is that the sagittal, the lateral bands then get subluxed, therefore causing a flexion deformity of the PIPJ. Sagittal band, very easy to diagnose clinically. So when you flex the MCPJ, you can see that the common tendon is subluxing over the knuckle, either radially or ulnally, depending on where the tear is. So here on the sagittal band, here you can see that the normal side on the ulnar side, and on the radial side, there's a big fluid gap and ill-defined tendons. And you can see when we flex the MCPJ, then you can see that the extended tendon here is no longer along the midline of the phalanx. So that's often quite easy to see. And yeah, if it's not obvious, then by flexing the MCPJ, then that makes it very obvious. Finally, we're going to just spend a minute on the thumb. So these were quite common for skiers. So there's a valgus injury, so abduction of the joint, therefore ripping the ulnar side of the collateral ligament. Okay. And just to be aware that most of these injuries, the UCL or the ulnar collateral ligament is torn at the distal attachment, so over 90%. And the mid portion and the proximal attachment are actually quite rare. Okay, and I think most of you will be aware of the Steiner lesion here. So this is what normal should look like. So here you can see the proximal end and the distal end. You can see this nice smooth ulnar collateral ligament. And some pearls, so it's not actually parallel to the long axis of the phalanges. Actually, it takes a bit of a 30-degree angle. So this is how you should be placing the probe, okay, like this. And then you should get a nice clear picture like that. And when you actually ask the patient to flex their IPJ, thumb IPJ, then you can see the aponeurosis on the top gliding over the intact UCL. So that's what's normal, and it's very useful when you're flexing the IPJ. And if there is a Steiner injury, or if there's a UCL injury, you can see that the UCL now here is no longer nice and defined, and it's kind of like it's all bored up. Okay. So out of the audience, just a final question: who would say that this is a simple UCL tear, or is this a Steiner lesion that we're seeing here? Hands up if you think this is a Steiner lesion. No? Or is it just a simple, non-complicated UCL tear that is going to heal by itself? So yeah, I mean, the UCL is definitely torn, but you can see that the aponeurosis here is still gliding very, very smoothly, all right? None of that is actually sliding underneath the UCL, so this is not a Steiner lesion. Whereas in compared to a Steiner lesion, which looks like this. Okay, so you can see that the UCL is completely curled up, retracted proximally, and some of the aponeurosis is actually getting into and deep to the UCL. So that's quite clearly a Steiner lesion. So just to wrap it up, so yeah, my top pearls is to make sure that your setting is adequate for your purpose. So think about the probe, the setting, and the patient. and that could increase your yield. And also patient positioning. Sometimes if you have the patient like leaning far forward, to scan the fingers, very uncomfortable. Then just simple things like that. Make sure that the patient is in a comfortable position for you, and then happy position, happy patient, and a comfortable position. Go bilateral and also dynamic. I think it goes without saying it offers a lot more diagnostic certainty when you do that. Pitfalls, beware of the mimics that I've suggested, especially when there's a chronicity. The tendon shift can have debris and tenosynovitis, mimicking an actual tendon. And then look at the blind spot as well, making sure that you look at far proximally enough, so you're not just looking at the finger, because the tendons can retract more proximally than might be co-current injury. Right, so sorry for overrunning. So thank you for being here so early in the morning, and I hope that you found this talk useful, and hopefully you can incorporate that into your daily practice. Thank you very much. Cheers, thanks.
Thank you, Dr. Chung, for the insightful presentation. Now I invite Dr. Rasmeet Kaur. She is a professor in the Department of Radiodiagnosis at Guru Gobind Singh Medical College and Hospital, Faridkot.
So good morning, everyone. So my talk is on today, forefoot pain on ultrasound. So basically, this is just a primer talk. Like I was very happy to see that most of the part which covers how to scan, what to do and what to not to do was covered by Dr. King. But what we have to realize is that like other joints, we are moving distally to the fingers as well as forefoot. And we have so many things that we can see on ultrasound. So this talk will be just going to touch about all those things, and definitely we can add to our practice and start doing these back at our home so that we can see all these pathologies primarily at ultrasound itself, and only in those cases where we need to see broader picture and global assessment of the joints we can do MRI. So this part was very well covered. So we'll go to the scanning technique. Sir has given very nice insight on how to scan. This is also a very small superficial part, and we can follow all those tips and tricks likewise, and we can proceed. So we have to scan the dorsal aspect, and we can do that when patient is either supine or sitting. We have to flex the knee at 90 degree, and we have to see the plantar side is flying flat on the bed. So on the plantar aspect, we can see the same for scanning. We need to keep the patient supine position, knee extended, and leg resting well on the examination bed. We can do prone scans also for eliciting some maneuvers, and we'll be discussing that later on. So the dynamic examination, as stressed earlier also, is very useful in these small areas, and we can do stress maneuvers, and we can use some techniques to expand the intermetatarsal spaces so we can well visualize pathologies in this region. So what to scan? This is as forefoot is small, as small it looks, has many things to which we can be assessed and be a cause of pain in this region. We can see tendons, the sesamoid pathologies, the capsuloligamentous structures at first MTP joint, the lesser metatarsal plantar plates, the intermetatarsal space, the joints, and many miscellaneous things like bursae, soft tissue masses can happen in this region. So we'll be discussing some common ones like the tendon pathologies, tears, and tenosynovitis. So capsuloligamentous injuries and sesamoid pathologies, some plantar plate tears, and intermetatarsal pathologies like motor neuroma and the intermetatarsal bursitis. Likewise, in elsewhere in body, the joints can be involved by various arthropathies, and we can see bursitis, soft tissue tumors, cyst, and ganglion in this region. So quickly going through the anatomy, all the extrinsic muscle on the tendons, intrinsic tendons of the leg and foot insert distally in the forefoot region. So we have to learn to appreciate all these tendons, know the anatomy, and that is how only we can eventually see the pathologies. So the extensor hallucis brevis and flexor hallucis brevis inserting proximally at the base, and the flexor hallucis brevis is has two slips, the medial and the lateral for each sesamoid at the greater toe. In this region, we have the tibialis anterior tendon, which will be seen inserting at the medial cuneiform and the first metatarsal dorsal side, and likewise on the plantar side, we have the peroneus longus. So we have to assess all these areas. This was for the great toe, and now for the digits also we have to look for the extensor and the flexor tendons. We have to know our anatomy well. The digit brevis tendons can be seen both in short axis and long axis. What we can see here is that the EDB lies lateral on short axis to the main tendon, can have a variable attachment to it, and the FTB lies superficial to the flexor tendon, longus tendon. So other smaller things have the peroneus brevis and inserting at the fifth metatarsal base, and the various muscles, the intrinsic muscles of the foot. So fascia I won't be covering, it's a big topic, and it can be discussed in some other talk or maybe later on. So the tendon pathologies, likewise in body, anywhere we can have all the inflammatory infection and mechanical irritation of the tendons leading to tenosynovitis. We can have tears. This is a short axis view showing the target sign, thickened tenosynovium with the tendon lying in it, and this is a long axis view, it was infective tenosynovitis. Here we can appreciate there is a gap in the tendon which was due to an old injury, and we can see a small hypoechoic scar even in the subcutaneous planes. Here again we can see an osteophyte irritating the tendon and causing tenosynovitis, and fluid is seen around the tendon sheath. The capsuloligamentous sesamoid complex at the first toe is has a very complex anatomy, and many pathologies are related and seen in this region. So what we see is a fibrocartilaginous pad which is lying deep, just planted to the metatarsal. Then we have the sesamoid bones which are embedded in it. Both of these are connected by an intersesamoid ligament. We have a tunnel created for flexor hallucis longus above it. This is what we see on the short axis. When we see laterally on long axis, we can see the proximal base of the proximal phalanx, and the sesamoid we can see connecting sesmophalangeal ligament, and the lies the plantar plate. So this is for these sesamoid bones are supported by various other muscles in this region, the flexor hallucis brevis, and on both sides, the abductors on the medial side, the adductors on the lateral side. We have metatarsophalangeal ligaments which are joining to the proximal metatarsal, from the metatarsal to the sesamoids. So all these structures provide support in this region, and many pathologies can happen here if injuries occur to these structures. So plantar plate elsewhere is relatively less complex, more stable, and has less movement at the other toes. So we can see the proximal attachment which is very firm, and we have loose fibrillar attachment at the neck region, in the metatarsal neck region, and that is why there is not much of tears seen in this region, where the attachment is very firm. We can see tears in this region. On ultrasound it is grainy, homogeneous in echo texture. So this is how it is. We have to scan from one side to the other side so that we can see the entirety of the plates, the ligaments, and on all scan on all views. So the plantar plate tear. So there are two main categories. Like one, first we can consider a chronic repetitive overload or degenerative tears, which are seen in middle-aged women, and the most common joint involved is second MTP joint. We can also see in some casual sports players who later on in the age come with this, had some earlier injuries, and now they are presenting late with the plantar plate tear. So we can have heterogeneous ecotexture of the plantar plate. We can have a partial tear, a full thickness defect. This is a normal for the reference. We can see a defect here, and what we can see is a big defect involving the plantar tendon. The flexor tendon is almost lying over the cartilage, and was a big defect in the plantar plate. So what is turf's toe? So this was entity was named for the capsuloligamentus sprains and traumatic tears occurring at the first MTP joint. So this used to happen when the football players had used to play on rigid artificial turfs. Nowadays these have been replaced by more pliant ones, but still football is one of the sports in which these injuries are very commonly seen. So sesamoid pathologies, there is an array to this picture, but the ultrasound is one screening modality, and we can correlate this with other things. The cortex should be very much smooth. There should be no fluid or hypoechogenicity around it. In this case, we can see some blurring of margin and some cortical disruption, which was correlated by via radiograph. So sesamoid pathologies, as a first line screening, if we suspect something, we can go back, when seen on ultrasound, we can go back and correlate with X-ray radiographs, and if still not found something and the pain is persistent in this area only, we can do an MR to see the edema patterns. Next, coming on to the intermetatarsal spaces. So, sorry. So as said, these are the spaces which lie between the metatarsal heads. So these are anatomical spaces, and these usually contain some neurovascular bundle and some bursa. This compartment is divided by a deep transverse metatarsal ligament into a superficial or the dorsal part which contains the bursa, and a plantar or deep part which contains the neurovascular bundle. So the superficial part, we don't see any bursa per se until it is pathologically enlarged, or sometimes minimal fluid can be seen, which is very common in asymptomatic, which is also asymptomatically seen in this region. So we have to correlate with the pain, which web space is involved, and where to see and what to see. So this is how it looks from the dorsal side, and from the plantar side. The skin being thick, we get a not very good window, but yes, it is also used to assess this space. Moreover, there are these pathologies more linked to second and third intermetatarsal spaces because of some anatomical changes in this region. The bursa in this region is extending across the anterior free edge of the transverse metatarsal ligament. So they commonly but the pathologies of the deeper compartment and can be seen together in this region. And also the plantar digital nerve, the common plantar digital nerve takes a dorsal turn at the anterior free edge of this ligament, where it is most commonly seen to be involved in Morton neuromas or perineural fibrosis. So the Morton's neuroma. So this term was coined to define a perineural fibrosis around the plantar digital nerve. As I've told, that these are irritated because of chronic repetitive movements by the ligament itself, and the most common then when it was named was Morton's by the third intermetatarsal space, because the third common plantar digital nerve receives a communicating branch from the lateral plantar nerve as well. Though it is a branch of medial plantar nerve, but it receives a branch from the lateral plantar nerve itself. So it becomes a quite a bit thicker in this region and more predisposed to get involved in this pathology. So we can see a fusiform hypoechoic mass beneath the intermetatarsal ligaments, and when seen on longitudinal scan, we can see a rat tail sign in this region. Here we can appreciate a hypoechoic mass and a hypoechoic mass on longitudinal scan. So this is not sufficient. We need to do some dynamic scanning to prove that this is Morton's neuroma. So there are 2-3 methods to approach for this dynamic scanning. From the dorsal approach, it means that we have kept our probe on the dorsal aspect. We can do a longitudinal scan. We are keeping the probe in the dorsal aspect between the metatarsals, and what we are doing is we are trying to I'm sorry. So what we are trying to do is push from the thumb, push with the help of thumb from the plantar side. And what we can see, the lesion is shifting upward towards the plantar side, towards the dorsal side. So this is how, and we can see a neuroma can be demonstrative. Also, we can see a small bursal component which gets compressed along with. All another method is that we can do a plantar Mulder's technique, which is very famous, and it is done. We are doing now the keeping the probe on the plantar aspect, and we are going to give a transverse squeeze at the level of metatarsal heads, so that we can uh, push out this motor neuroma towards the plantar side. So this is how it looks. We give a squeeze at the level of metatarsal head, the lesion pops out on the plantar side. Another technique is plantar approach, where we can do a scan just by pushing, keeping the probe on the plantar side and pushing the dorsal web space. We can see how the lesion behaves. So this lesion doesn't pop out and is compressible, and it turns out to be small intermetatarsal bursal cyst. So intermetatarsal bursitis, like I have told, that it is almost like ill-defined hypoechoic. The only difference we can do is by some dynamic scans, and sometimes we can see increased vascularity around them, and these are compressible, whereas neuromas are not. But they often coexist. And when they coexist, what we can do the best is we can try and localize which is the bursal component and which is the neuroma component, so that we can give accurate size, and so that further intervention into bursa and around the neuroma can be done. Now let us look at this case. So what we are seeing is some hypoechogenicity around the head of the metatarsal. So what is this? This is not bursitis. This is not a neuroma. Sorry, this is not a neuroma. So what is happening is, this is centered around the metatarsal head at the joint itself, and if we see carefully, we can see there is some dorsal subluxation of the phalanx. Basically, it is chronic scarring, the term labeled as pericapsular thickening and scarring, which can mimic when it is too much, and it can extend into the intermetatarsal space and can mimic intermetatarsal bursitis. So other structures which we have to evaluate in this region are the MTP joints. So 2 minutes. Thank you. So other things we have to evaluate are the MTP joints on the dorsal aspect, on the plantar aspect, like all the arthropathies, infective causes, and we can also very well appreciate the metatarsal bone cortex. So gout is very commonly seen affecting the first MTP joint. We can see a double contour sign. We can see some hyperechoic deposits. So if there are some erosions, we can even look at those: synovial effusion, hypertrophy, and everything can be very well assessed with the help of ultrasound only. Likewise, we can see changes of OA and RA involving these joint. It is tough to sometimes differentiate between them, but definitely classically osteoarthritis will have more of osteophytic picture and margin joint space narrowing, if we could appreciate, and rheumatoid arthritis will have more of synovitis. So stress fractures are also can be seen on ultrasounds. So what we have to see is, we have to see somewhat the blurring of the cortex. We can see some periosteal elevation. We can see some hypoechoic fluid, some increased vascularity in this region, and then further workup with radiographs if it was negative, or we can do a follow-up radiograph to see if there are changes which are sequelae to the fracture. Now coming on to the last few things, the adventitial bursitis. So foot is weight bearing area, forefoot is again a very high weight bearing area, so all the pressure is transmitted and we can have swellings in the various bursas. So this is actually submetatarsal region. We see a large hypoechoic mass like lesion, and when we try to do a compression maneuver, we can see it compresses and we can see the tendon slightly lying separately to it. So it turned out to be an adventitial bursitis rather than any mass. Another case, we can see some ill-defined hypoechogenicity in some fluid-like areas in submetatarsal region, and this can be labeled as diffuse submetatarsal alterations, and if a patient has pain and nothing else is found out, it can be a cause of pain as well. Likewise, other soft tissues tumors, we can see many tumors in this region, and glomus tumor we commonly seen in hands can also be seen in the foot region, and here in this case we can see a hypoechoic subungual mass showing increased vascularity and turns out to be a glomus tumor. Ganglion cyst, they are going to be anechoing and show no vascularity, lying in close proximity to the tendons or the joints, and if possible, if they're larger, and we can demonstrate a tail to these regions, and it's quite diagnostic of ganglion cyst. So concluding the slide, as I've said in the starting, that yes, it is now that we can see almost most of the soft tissues. The low cost, excellent patient's tolerance favors ultrasound as a very quick assessment guide. We can do a dynamic assessment and comparison with the deposit, as was highlighted earlier also. It is very important and advantage to ultrasound. And additionally, we can do many guided interventions in this region with the help of ultrasound. Thank you. This is my reference.
Thank you, Dr. Kaur, for very informative presentation. Now I invite Dr. Jatinder Pal Singh. He is a director of MSK radiologist at Medanta, the Medicity, Gurugram.
Thank you, ma'am, for the introduction, and good morning again. So I'm going to talk about unusual masses and mass-like lesions on ultrasound. What are the salient features and how to make a diagnosis? I have no disclosures. So MSK ultrasound, we know it's easily accessible and it's available everywhere, and it's becoming the first line of investigation. It is still user dependent, although our society is doing a lot of work, so many workshops are happening, but still we know that it is user dependent. It's, it's exceeds MRI in certain aspects, like it can help to differentiate between a solid versus a cystic lesion. You can utilize the dynamic aspects of the ultrasound, so you can also check the movements like Dr. Chung showed, and also you can compare with the opposite side, so that's very useful. A Doppler assessment can be done, so there is no need for intervention like contrast injection, and microvascular flow imaging is there where you can assess very slow vascularity. We are all familiar with the ultrasound patterns. We have anechoic appearance with posterior acoustic enhancement, hypoechoic structures. Hyperechoic is when the echogenicity is more. Then there can be homogeneously, isoechoic or hyperechoic, and then heterogeneous echogenicity. So what are unusual masses? These are the ones where ultrasound has a limited role and it fails to make a diagnosis. It may be because of the assessment is difficult, the lesion is a little bit tricky, you're not able to understand what's going on. If it's a large lesion or it's too deep, then sometimes the assessment can be difficult, or sometimes when there is intraosseous extension. And many times differentiating between the solid and the cystic lesion is not possible. So I'll go through the cases, and I'm not gonna just cover the ultrasound part. There will be spectrum of other imaging as well. So this is the first case, 36-year-old male with left thigh mass, painless, no trauma. So you can see on the axial sections, we have a slightly lobulated lesion which is located inside the muscle, and it's got mixed kind of echogenicity, hyper and hypoechoic, and there's a anechoic tubular structure is there inside the center of it. This is the long axis view, similar kind of appearance. So Doppler was done, and there's arterial flow is there, and there is vascularity in the superior and the inferior aspect of the lesion, lots of vessels. So ultrasound diagnosis was some kind of soft tissue sarcoma. We were not sure which one are MRI was done. MRI shows on the T1 it is slightly hyper intense to the muscles. T2 hyper, stir hyper intense, and there is heterogeneous contrast enhancement. Diffusion restriction was there in the lesion, and on the long axis there's some lot of vessels within the lesions, and especially in the the poles of the lesion there is tortuous vascularity, which is a very classic kind of appearance. And this is alveolar soft part sarcoma. So you should know the appearance, the classic kind of appearance on ultrasound. This is a solid malignancy. 1% of all soft tissue sarcomas presenting between 15 to 35 years of age. Usually they present with metastasis to the lung, brain, bones, into the lymph nodes. Most frequently you will see them in the lower extremities, especially in the thigh or the buttock. MRI, as we saw, they're large lesions which are highly vascular mass, iso to hyperintense on T1, and heterogeneous contrast enhancement is there. Vascular flow voids you would see, and a lot of peritubular blood vessels. So the diagnostic clue on ultrasound would be if you see a well circumscribed lobulated mass, which is heterogeneous or homogeneously hypoechoic, intramuscular. They describe these anechoic tubular structures as tubeless echoes, and you will see these intratubular and peritubular vessels, which are basically tortuous veins. My second case is a 28-year-old female who presented with a painless swelling in the left wrist. So this was associated with the atrophy of the hypothenar muscle, and she also had clawing of the fingers, which was basically representing there's some ulnar nerve abnormality. Card test is done for assessment of weakness of the ulnar nerve, so that was positive. So ultrasound short axis view showed a hypoechoic to anechoic lesion which had some solid areas within it. This is a long axis view, again looks hypoechoic to anechoic with solid area in the this is the video which shows that the lesion is located along the course of the ulnar nerve, and if you see the fibers are splitting to the sides, and very anechoic kind of appearance along the course of the ulnar nerve. So the diagnosis on the ultrasound was a complex kind of ganglion cyst or a cystic schwannoma. We're not sure, so we went for an MRI. MRI, T1 iso hyperintense on T2 and stir. There was some contrast enhancement in the septae basically and the surrounding area, and a lot of diffusion restriction was there. So long axis, it was located along the course of the ulnar nerve, and some septations and contrast enhancement. And the ADC values were quite low, 0.05, which is diffusion restriction was there. She ended up having a PET scan which was normal. Because there was so much diffusion restriction, the chances we were thinking of in the lines of some kind of malignant nerve sheath tumor, and that was the diagnosis on the MRI. Histopathology was done, and this showed spindle cell tumors, which they labeled it as a synovial sarcoma. Patient ended up having complete resection of the lesion and was advised chemoradiation therapy, but since she was taking care of a young child, she refused the treatment and she was lost to follow up. She presented 2 years later and complaining of fever, cough for 1 month duration. We did a chest x-ray. She had big lesions in the chest, which we did PET scan, and there were metastasis from the lesion, and she subsequently passed away. This was a case of synovial sarcoma of the ulnar nerve. So it's a very important thing to recognize, because synovial sarcoma can mimic benign pathologies, and you may easily get fooled. So it is exceedingly rare. It is not possible to differentiate between malignant nerve sheath tumor and a synovial sarcoma. The triple sign on MRI is a classical pattern. So you see iso, hypo, and hyperintense areas. This is because of the hemorrhage and fluid level, and you may have ball of grape kind of appearance. Now on ultrasound we have described a sign. We called it a tadpole tail sign. So if you see the long axis view, it resembles like a tail of the tadpole, and we published it recently last year. And if you see, the center part is a solid area and the periphery is hypoechoic. So it resembles the tail of a tadpole. And that's what you should be looking for, a hypoechoic intraneural lesion with solid component. So that's what you should be, alarm bell should go off that this could be a synovial sarcoma of the nerve. Next, go on to the case 3, which is a 56-year-old male with swelling in the thumb, moderately painful, slowly growing over 2 months. There was no fever, redness, no tenderness, and there was no history of injury. So this is the area of the swelling. So he came for an ultrasound first. So this is the long axis view. A lot of solid area right next to the metacarpal. And if you see just next to the cortex, you have some irregular periosteal reaction was there. Short axis, again, a lot of soft tissue, not a lot of Doppler flow inside the lesion, but there was peripheral calcification at the sides of the lesion. So we thought it was some kind of, there was no involvement of the flexor tendons in this. So we thought the differentials were BPOP, which is basically bizarre periosteal osteochondromatous proliferation, which is also called a Nora lesion, or periosteal osteosarcoma. But we were not sure, so we advised let's go for an MRI. But before that, this is the X-ray, which shows little bit of soft tissue ossification, and this is the soft tissue part of the lesion. There was no involvement of the cortex or the bone. MRI picture looked very aggressive kind, T2 hyperintense. There was bone marrow edema was there, although there was no osseous destruction, and gradient sequences showed some, calcification or ossification within the lesion. Same thing on the axial, very, a lot of edema around the lesion, and not much diffusion restriction. So we thought it could be periosteal osteosarcoma rather than a BPOP lesion. So we did a ultrasound guided biopsy. This is now 3 weeks post presentation. This was the histopathology done at our place. They said these are most consistent with the periosteal osteosarcoma, and the immunohistochemistry, they ruled out the possibility of a BPOP lesion. And patient was advised excision of the thumb, but the patient was not keen at getting the thumb excised. So he came back. I did the ultrasound and I said, let's get a review of your histopathology and let's get some more tests done. So we got an X-ray again in 3 weeks time, which was showing more increase in the calcification, the ossification within the lesion. So we got the FISH test done, which showed USP6 gene was positive. So basically that represents its myositis ossificans or fibroosseous pseudotumor of the digit, and not MDM2 was not amplified, which is suggestive that this is not an periosteal osteosarcoma. Patient was advised conservative treatment, and this is now 3 months down the line and the swelling has significantly reduced. So no surgery has been done. This is a case of periosteitis or myositis ossificans. This is basically heterotopic ossification, and they present with soft tissue swelling. Usually the history of trauma is not there in most of the cases. And this is a benign type of periosteal reaction, which with preservation of the internal cortex, and a typical kind of centripetal ossification compared to osteosarcoma, where you would see the ossification in the center of the lesion and progressing to the periphery. And the differentials are BPOP, osteomyelitis, and periosteal osteosarcoma. The diagnostic clue here is a cortical-based soft tissue lesion with peripheral calcification. There will be low vascularity, and always remember you should go for advanced kind of gene test, FISH test for these kind of cases. Next is my case 4, which is 25-year-old female with swelling in the wrist for 4 years, which was increasing in size, non-tender and soft. Clinical diagnosis was a ganglion cyst, so the clinician was just do an ultrasound and aspirate the cyst and do some, steroid injection. So I did ultrasound. It didn't look anechoic. It was some hypoechoic kind of lesion, and there was a little bit of low level echoes within it, and posterior acoustic enhancement is also, you can see that the lesion was not located in the continuity of any nerve, so there was no tail sign with that. um, so diagnosis was not very clear what exactly we are dealing with, because a lot of time you miss a synovial sarcomas. So we thought, let's again, Doppler was little bit of vascularity, venous flow mainly. Some kind of hyperechoic area within the lesion was there, which we thought could be a target sign. So MRI was still done, and this kind of ISO to hyperintense lesion. No nerve was there along the course of the lesion, and diffusion was not much restricted. So lesion, we did do a biopsy, and it came out as schwannoma. So schwannomas, we should know that schwannoma, neurofibroma, they're all nerve sheath tumor, and well-defined oval hypoechoic masses, and you can see the peripheral nerve sometimes in the eccentric area, and posterior acoustic enhancement is a peculiar feature, so you should look for that. And the tail sign is inconsistent. You may not always find a nerve identified along the course. Target sign has been described, basically the center hyperechoic area with hypoechoic periphery. And it's not possible to differentiate between schwannomas, neurofibromas, and malignant nerve sheath tumor on ultrasound. The diagnostic clue is pseudocyst appearance. If you get something that looks like a cyst, with some posterior acoustic enhancement, you may not get any flow in that. It simulates a ganglion cyst. Think about the possibility of a nerve sheath tumor, and don't just go straight for aspirating the procedure. So I've done that. So this is the last case given to me by Dr. Neha Nischal from Holy Family Hospital. A very interesting case. 32-year-old male presented with swelling in the left axilla and the arm. So it was a painless swelling. This is the arm area with some swelling. MRI was done outside the hospital, and these are the coronal sections, which shows lot of tubular areas of stir hyperintensity in the axillary region, and also extending in the arm, which were reported as a slow flow vascular malformation, and the patient was referred for ultrasound guided sclerotherapy. So the plan was to do a sclerotherapy. Ultrasound probe was put, and there was a lot of subcutaneous anechoic tubular cystic kind of areas which were not compressible, and there was no Doppler flow within these areas. Fortunately, she put a high resolution probe, which is 18 megahertz hockey stick, and there was this kind of peculiar movement, the tubular structure dancing within the cyst. So the surgeons, they operated on the patient. They took this worm. They basically found a worm inside, which is they took it out, and this is dirophilaria. So this is very important, that a lot of time you may be referred a patient for doing sclerotherapy, and you should be aware it's prevalent in Indian subcontinent. You find subcutaneous anechoic tubular channels, no Doppler flow, and you'll see that the filarial dance, that movement, which is inconsistent. You may not find it all the time. It's lucky that you find the worm inside. They usually come out in the night time, so you can't come in the night and do an ultrasound. Once you take the worm out, they say that the infection is cured. So this guy, the worm was taken out, all the swelling in the arm went away. The diagnostic clue here is, if you see multiple subcutaneous tubular channels which are not compressible, and the patient usually will come for a, getting sclerotherapy, as a slow flow vascular malformation. So take home message is, ultrasound alone may be enough to make a diagnosis many times. So you should know the salient features. What are the presentation? What are the usual presentation? Utilize the dynamic nature. Compare with the other side. Do some movements. Use ultrasound as a first line of investigation. If the diagnosis is not possible, then proceed with the next investigation. Consider ultrasound guided biopsy. And know that differentiating between a solid and cystic lesion may not always be possible, because sometimes myxoid lesions or nerve sheath lesions, they can demonstrate posterior acoustic enhancement. Thank you.
Thank you, Dr. Jatinder, for this interesting case-based presentation. Now I would like to invite Dr. Neeti Ajay Gupta. She is a senior consultant radiologist at Sant Parmanand Hospital, Delhi.
A very good morning to everyone. We have had excellent talks since morning, and everyone has highlighted the role of ultrasound in various pathologies. So my talk is also going to be highlighting the role of ultrasound, and in fact, ultrasound is the only modality that can prove to be useful in the cases that I'm going to discuss in this talk. Okay, so we are going to discuss a very interesting topic, the role of dynamic ultrasound in snapping syndromes pertaining to the hip, elbow, and the peroneal tendons in the ankle. So basically, snapping sensation it is a painful, or it could be asymptomatic. It is even sometimes audible and mostly palpable snap with certain joint movements. So dynamic ultrasound is the modality of choice when we are examining certain such conditions of snapping. Starting with the hip, so snapping sensations in the hip are usually painful, but they may be asymptomatic in a few cases. And they are most common in individuals who engage in sports or activities that demand repeated elevations and abduction of the hip over the horizontal line. Okay, especially in people who are professional dancers, weightlifters. In India, we can also say kabaddi players. Okay, so and it is mainly a clinical diagnosis, but it is confirmed and localized by ultrasound. And in the hip, when there is especially snapping of the iliopsoas tendon, it could be associated with distended iliopsoas bursa or iliopsoas tendinopathy. So hip snapping could be intra-articular or extra-articular. The intra-articular type is mainly a mechanical locking or a catching sensation rather than a snapping sensation. And it could be caused by intra-articular loose bodies, labral tears, plicae or chondral defects. Whereas the extra-articular snapping is the actual snapping sensation that we feel. And this is divided further into external snapping and internal snapping. So we'll be seeing each of these in detail. Now coming to the internal snapping first, which is mainly caused by the iliopsoas tendon snapping. And this is elicited by this particular maneuver. So your probe is placed in a transverse oblique position just above the hip joint, almost at the level of the inguinal ligament. And you ask the patient to undergo a Faber position, that is a flexion, abduction, and external rotation. You could position yourself in a better way so that you don't obstruct the patient's movement like I have done. And then you ask the patient to return in a neutral movement. So what will you see in this movement? Let's look at the anatomy. This is the superior pubic ramus. Somewhere here we'll get the iliopectineal eminence. It's not very prominent in this patient. And this is the iliopsoas tendon. It's mainly the psoas tendon, but there are a few fibers from the iliacus too, so we label it as the iliopsoas tendon. This is the iliopsoas tendon. Now what is happening? Are we all appreciating that the tendon is first rising off the bone, and then there are these muscle fibers which are interposed between the bone, and then suddenly, I'll just play it myself. Okay, so these are the muscle fibers that are interposed between the tendon and the bone, and then suddenly you have this tendon falling onto the cortex, bony cortex. So this is when the snap occurs, when the tendon falls upon the bony cortex. Okay, so let's look at this in more detail. So at rest, this is the anatomy. Here we have the lateral iliacus fibers, we have the medial iliacus fibers, the iliopsoas tendon. This is the superior pubic ramus. Here we'll have the iliopectineal eminence, and these are some fibers of the psoas muscle. So when the patient is at rest in a neutral position, your iliopsoas tendon will be in contact with the bony cortex. When he takes that frog-like position, okay, your tendon gets lifted up from the bony cortex and the iliacus muscle fibers are interposed between the tendon and the bony surface. And when he goes back to the neutral position, you get this typical falling of the tendon over the bony cortex, which results in this snapping sensation. This snapping sensation is so obvious that sometimes, like I said, it could be audible, and when you keep your probe there, you'll actually feel that cut sensation, okay? So this is another case of a 23-year-old kabaddi player. Like I said, in kabaddi, they have these typical movements in which they have to really abduct and externally rotate frequently. So this player had complaints of intermittent dull right groin pain after certain movements, and it had been going on since the past 1 or 2 years, and he had no known comorbidities. Radiograph of the pelvis and hips was normal. He had undergone 2 MRIs outside, which were reported as normal, but the pain was still there. So he was referred for a repeat MRI to look for the pain generator. So I took the history myself, and he said that he had pain especially with hip flexion, abduction and external rotation. And then he told me that I have never told this to any clinician before, but I'm telling you that I also feel this sudden snapping sensation when I do this. He didn't use the word snapping, but he said that I feel that something is slipping inside. I feel some cut like awaaz aa rahi hai andar se. So it was followed by the snapping sensation in the anterior hip, and it was associated with mild pain. So of course I proceeded with the MRI because that was advised to him by the clinician. But like the previous MRs had reported, we didn't find anything significant on the MRI. So I took him for an ultrasound, and the probe position that I'd showed earlier, I placed my probe in that region. And here we are seeing the iliopectineal eminence, the superior pubic ramus, and the anterior inferior iliac spine. Okay, so if you see this dynamic ultrasound, we are seeing the sudden movement of these structures, and then we see another sudden movement. I'm going to play this video a few times so that you appreciate it better. Okay, and I'll also zoom it up for you. So there is this movement, and then there is this movement. Okay, let's see it in slow motion. So are we seeing that there are some fibers that are moving from here medially, from underneath the tendon? So he actually had 2 snaps. One was more subtle and the second snap was louder. It was almost audible. So the first snap was related to the sudden movement of these muscle fibers underneath the tendon and between the bony cortex. And the second movement, it was this. So if you can see in the classic example that I showed you, our tendon was falling on medially, almost on the iliopectineal eminence and the superior pubic ramus. But here our tendon is falling laterally, almost over the AIIS, anterior inferior iliac spine. So what I want to highlight with this case is that it's not always the typical snapping that you will see in textbooks or in articles. Your snapping might be seen in different ways in different patients. So don't always go by textbook knowledge. You have to practically examine the patient, ask where exactly the snapping is, place your probe there, get the anatomy right first, and then you will know which structure is snapping over what. So this patient was referred for physiotherapy pertaining to, strengthening the hip flexors, etc. And we have not received the follow-up because it's still a recent case. There is another different mechanism of snapping iliopsoas, and this is a different mechanism pertaining to a bifid tendon. So sometimes the psoas tendon and the iliacus tendon can be separate from each other. A smaller iliacus tendon is present laterally and a larger psoas tendon will be present medially. And what happens is, in the neutral position, normally the psoas tendon is present medially. When the patient adopts a frog-like position, the larger psoas tendon travels over the iliacus tendon to lie lateral to the tendon. And when he goes back to the neutral position, this tendon snaps back into its place, leading to a snapping sensation. Okay, so if we see in this video, this is the large psoas tendon. We can see it going above the smaller iliacus tendon laterally in frog leg. And then when he returns back to the neutral position, it's snapping over the bony cortex. So it leads to a snapping sensation. So this is another mechanism of snapping iliopsoas. Now, like I said, in the hip, in the extra-articular causes, we have internal and external snapping. So the iliopsoas was an example of internal snapping. Now we're coming to the external snapping, which is mainly caused by the tensor fascia lata and the iliotibial band complex over the greater trochanter of femur. So the maneuver that is performed in this is hip flexion and extension. So you ask the patient to lie in a lateral decubitus position with the affected hip on the upper side, and you ask him to do an flexion and extension maneuver. So just a look at the anatomy. Anteriorly, over at the level of the greater trochanter of the femur, anteriorly we have the tensor fascia lata muscle, posteriorly we have the gluteus maximus muscle, and in between we have this condensation of tendon fibers. This is the iliotibial band. So the iliotibial band complex in normal conditions slides over the greater trochanter. This is the gluteus medius tendon insertion. So normally you will have the smooth gliding movement of the iliotibial band over the greater trochanter or the gluteus medius tendon. In snapping cases, when the hip is going back into extension, you will see the sudden movement of the iliotibial band over the greater trochanter, and that is the cause of external snapping of the hip. So normally you should have this smooth gliding movement, and especially patients with trochanteric bursitis or iliotibial band tendinopathy are prone to this kind of snapping. Okay, so moving on to snapping elbow. Similarly, as we saw in the hip, there are again intra-articular and extra-articular causes of snapping elbow. And again, the intra-articular causes are more of a mechanical locking or a catching sensation rather than the true snapping. And they're caused by hypertrophied synovial folds or plicae or intra-articular loose bodies again. The extra-articular causes are divided. We can see them on the medial side as well as the lateral aspect of the elbow. Medially, we have the ulnar nerve, the triceps muscle, and in very rare cases, the brachialis tendon. Laterally, we could have displacement of the triceps or a snapping annular ligament over the radial head. So coming to the medial aspect, so this is a classic example. This is the cubital tunnel. You can see the ulnar nerve in flexion. So we perform this ultrasound in a flexion extension. So when the patient flexes the elbow, you might see this is also seen in many asymptomatic patients. Around 16% of the patients have a snapping ulnar nerve and don't know about it. So a very few cases of these are actually having symptoms because of secondary neuritis. Okay, so in this video we can see the ulnar nerve is first present in the cubital tunnel, and on flexion it is jumping over the medial epicondyle of the humerus. And we also see that on flexion, the medial head of the triceps muscle is following the nerve, but it is not displacing over the medial epicondyle of the humerus. It is just occupying the cubital fossa as the ulnar nerve is going out of the fossa. So snapping ulnar nerve could be because of absence or laxity of the cubital tunnel retinaculum, or because of a cubitus valgus or varus, a hypertrophied or an anomalous triceps muscle and tendon. And like I said, recurrent subluxation could result in a tractional or frictional neuritis with classical symptoms of peripheral neuralgia. Now, we saw the ulnar nerve jumping. In addition to the ulnar nerve, some patients may again have a double snapping. So the first snap is related to the ulnar nerve dislocation, and the second snap is related to a dislocated triceps, medial head of triceps muscle. Okay, so in this video, in my case, it's going quite smoothly. We are not seeing that typical snapping sensation that we saw in the earlier video. But in some patients, this patient did not have a snapping sensation. Okay, I'm showing this video because I wanted to demonstrate how the medial head of triceps can also jump over the medial epicondyle. So in some patients, it goes ahead with a snap. So you have the first snap of the ulnar nerve and the second snap of the medial head of triceps. A very rare case is of a snapping brachialis. So the distal myotendinous junction of the brachialis normally lies medial to the medial border of the trochlea. Okay, in some cases, on flexion and extension, this tendon might jump over the medial border of the trochlea and produce this snapping sensation in the anteromedial aspect of the elbow. Coming to the peroneal tendons, the ankle. So let's look let's have a quick look at the anatomy. So normally we have the peroneus longus and the peroneus brevis tendons which lie posterior to the lateral malleolus. There is a groove in the retromalleolar region in which these tendons are housed, and they are supported by the superficial and the inferior peroneal retinacula. Okay, so the superior peroneal retinaculum holds these tendons in their place in all kinds of movements of the ankle. Now, there are two types of peroneal tendon subluxation or dislocation. One is the intrasheath or the retrofibular type, and this we can call only subluxation, we cannot label it as dislocation. And we have the prefibular type, that could be a subluxation or a dislocation. So what are these? Basically, the intrasheath or the retrofibular type, the tendons here, they move around each other, they subluxate around each other, but they are still situated within that retromalleolar groove. They are not dislocating over and anterior to the lateral malleolus, and the superior peroneal retinaculum is intact. So there is usually no history of trauma in these cases. The retinaculum is intact, the tendons are just switching positions within the groove, and the patient gets a subtle snapping sensation. In the prefibular subluxation or dislocation, usually the retinaculum is torn or avulsed, and the tendons tend to dislocate or subluxate over and anterior to the lateral malleolus. So the intrasheath subluxation is more important for us radiologists because it may be missed on a physical examination, as there is no tendon displacement over the lateral malleolus. So when the tendons are displacing over the lateral malleolus, you see this visible movement of the tendons because they are going over a bony prominence. But when they are subluxating behind the bone, you are not actually able to visibly make out the subluxation. Okay, so this is where dynamic ultrasound plays a very important role. So in normal situations, we have the superficial peroneal retinaculum inserting on the lateral malleolus. The peroneus longus tendon is located anteriorly, and posteriorly we have the peroneus brevis tendon. So Raikin et al. Have given a classification for intrasheath or the retrofibular subluxation. In type A cases, there is a reversal of the location of these tendons. So the peroneus brevis comes to lie anterior to the peroneus longus tendon, or it could also happen that the peroneus brevis completely subluxate and goes to lie above the peroneus longus tendon. And there is a type B intrasheath instability in which there is a longitudinal split in the peroneus brevis tendon, and the peroneus longus tendon snaps between these two tendons in the dorsiflexion maneuver and comes to lie in between these two or deeper to these two tendons. Then in the prefibular subluxation, we could have stripping of the periosteum, lateral malleolus periosteum, and like a pouch formation into which these tendons can subluxate anteriorly. Or there could be a complete tear or avulsion of the retinaculum and complete anterior dislocation of these tendons anterior to the lateral malleolus. Now, this is an example of intrasheath subluxation. This patient had a snapping sensation in the lateral ankle, not much associated pain, but she was quite concerned about the snapping sensation. It was not visible, but when I kept the ultrasound probe, we can see this is the peroneus longus tendon and the peroneus brevis tendon. You can identify the peroneus brevis tendon by the muscle belly associated with it, because the peroneus brevis muscle belly lies at a lower level. Okay, so here we can see on dorsiflexion, the peroneus brevis comes to lie anterior to the peroneus longus, and when the patient goes back into the plantar flexion or neutral position, the peroneus longus tendon falls upon the lateral malleolus. So this phenomenon generates kind of a snapping sensation in that region. So this is another example, a faster movement, the peroneus brevis moving anterior to the longus and coming back. So the longus is snapping onto the lateral malleolus. Now this is an example of prefibular subluxation or dislocation. We have this edematous retinaculum, and we can see these tendons subluxating into a pouch-like structure anterior to the lateral malleolus. So top five things to remember. Do not settle until you find the cause of the symptoms. Patient's symptoms are your roadmap. So you have to keep looking for the cause of the symptoms. Snapping sensations require dynamic imaging, especially ultrasound for evaluation, and the ultrasound should be guided by the patient's symptoms again. Stability of a probe is the prerequisite for performing a dynamic ultrasound, and it has a learning curve. So practice till you get your probe stable. And it's always best to take patient history yourself to prevent missing out on subtle clues hidden in the history that can guide you to use the optimal modality in an appropriate manner. Thank you.
Thank you, Dr. Neeti, for an excellent demonstration of this unusual complaint of the patient. Now I welcome Dr. Kumarpal Singh. He is a professor in the Department of Radiodiagnosis at Sri Guru Ramdas Institute of Medical Science and Research, Amritsar.
So, good morning everyone. I will be discussing the role of shear wave elastography of the upper trapezius muscle in patients with myofascial pain. So, why this topic? I have started the study in this less common pathology, but rather we can say it is underdiagnosed condition. So the trapezius muscle trigger points are there which can cause painful knots, referring to the pain in the neck region, the head, shoulder, often driven by the poor posture, stress or the muscle overuse. So it is very common in patients with cervical spondylosis, patient with poor posture. So patient presents with the pain and sometimes painful knots. So there is muscle spasm and patients or the therapist may feel some trigger points or the muscle knots. So what we can help in the diagnosis of these patients, because in patients with cervical spondylosis, the symptoms like radiculopathy, the other numbness, and they are treated by the orthopedicians. But sometimes the patient is more uncomfortable with the muscle spasm. So we can diagnose these conditions on ultrasound and shear wave elastography. So we have two trigger points in the neck, the upper trapezius apex and the lower neck. So upper trapezius apex is a midway between the upper shoulder border, refers pain to the side of neck, to the temple and the behind the eye, so causing tension headaches. And the lower part is where the neck meets the shoulder, it is referred to a deep aching pain locally up to the base of skull. So causes we all know in the present scenario, in addition to the cervical myofascial pain, we have poor ergonomics like holding a phone between the ear and the shoulder or slumping over a desk for long periods. So long hours of typing or carrying heavy bags on one shoulder, increased muscle tension due to underlying emotional stress. It can result in the muscle spasm. So the purpose of the study was that the shear wave velocity parameters, they reflect the trapezius muscle elasticity, and it may be valuable for the successful screening of these patients, especially with moderate and severe pain. Because in the mild pain, the values may be similar in patients who do not have any symptoms. So moderate and severe pain patient can have different values. So clinical applications, why this is useful, in addition to diagnosis, what else we can do in these patients. So we can identify active or latent myofascial trigger points and structural changes on the ultrasound, Second, we can use the elastography to measure tissue elasticity and shear wave velocity in detecting muscle stiffness with moderate to severe pain. So this was a diagnostic help, but we can help the patient after diagnosing this condition. So we can have real-time ultrasound needle guidance that is enhancing the accuracy of for the procedure like dry needling in these patients. So botulinum toxins injection and LA infiltration the trigger points. Patient can get relief from these procedures. So interfacial hydrodissection, it directs the fluid delivery to the separate tight facial planes. So we cannot inject blindly. We can guide the consultant, we can guide the intervention person that these are the trigger points. We can do hydrodissections. So they effectively minimizing the post-procedural soreness and optimize functional recovery. So after the procedure, we can have the follow-up for a therapeutic monitoring of these patients. Then why upper trapezius only? Why not other muscles? So it is most common muscle affected in cervical spondylosis, in the back pain, in other causes, but I have mentioned in the previous slides. So frequent site of myofascial trigger points and easily accessible for the USG examination. So fibers, they are more well aligned. We can do accurate elastography measurements. Even when there is change in the morphology, before that we can have increased stiffness on the elastography. And the studies say in patients with moderate and severe pain, the muscle stiffness parameters, they correlate with the VAS score and the treatment response also. So on the anatomy, we can see its origin from the external occipital protuberance, ligament nuclei and the spinous process of C7 vertebra, insertion on the lateral one-third of clavicle and the acromion process. So actions elevate the scapula, shrugging, upward rotation of scapula, extension of the neck and flex the neck laterally to same side. So this is anatomy of the muscle. This is the upper trapezius muscle. We can see the occipital protuberance. These are descending fibers. These are the horizontal fibers of the upper trapezius muscle or the transverse fibers. This is the area most accessible on the USG and the shear wave elastography. This is the upper trapezius. This is the middle and this is the lower part of the trapezius muscle. The typical USG appearance, starting from the skin and deep downwards, skin most superficial hyperechoic layer, fat is relatively hypoechoic. We can have some echogenic septae. So upper trapezius muscle is moderately hypoechoic like other muscles and have parallel hyperechogenic fibroadipose septae. So we have feather-like appearance. Then we have the deep fascia and the underlying muscles like splenius capitis, cervicis and the levator scapulae. This should be the position of the patient for the ultrasound. We can see this is a position of the elbow. Forearm should rest on the ipsilateral thigh. This is a position for the transverse examination and for the longitudinal examination of the trapezius muscle. We can see the occipital protuberance on the foramen and magnum. This is the end of acromion. So approximately in the mid part of this line, we can place the probe in both short as well as the long axis of the patient. So this is the trapezius muscle. We can see the feathery appearance. So this is the deep part. We can have scapula, the suprascapular nerve. We can apply Doppler. We can see this is the right position for the assessment of the muscle. We can have the thickness of the muscle for a baseline parameter. So for the technique for the shear wave elastography of the muscle, so preparation of the patient, so explain the procedure to the patient so that there should be no movement during the procedure because it can change the values. So ensure the patient has not performed any strenuous neck exercise or shoulder exercise immediately before the examination, so the muscles become more stiffer, though higher false positive values will be there. So the area should be exposed clearly. Seat the patient comfortably in chair without back support. Then keep the head in neutral position, no extension, no flexion, no lateral rotation. It can cause wrong values. So the arm should comfortably rest on the sides. Relax the shoulder completely, no shrugging and no muscle contraction during the examination. So this should be the probe, 10 to 18 megahertz probe. I have started with the 10 to 20 megahertz probe, linear probe. Select the MSK presets and go for the elastography mode. So probe the probe should be on the midpoint of the upper trapezius from halfway between C7 and the acromion, lateral part of the acromion and the C7. So align the probe parallel to the muscle fibers, and most reliable stiffness measurements are there. So do not apply excessive pressure. Again, it will increase the stiffness of the muscle, and higher values will be there. See the muscle pattern, thickness, ecotexture, fascicular pattern, any lesion, any edema. So any surgery, any trauma, any hematoma, any previous RT, the patients were excluded. So switch to elastography mode. Wait for 2 to 5 seconds for the color elastogram to stabilize. Smaller ROI within the center of the muscle belly and entirely within the muscle tissue. Avoid the superficial fascia, deep fascia, bone, and any major vessel. We took 3 measurements at the same site. So shear wave velocity we made in the kilopascals, and calculate and report the mean value. We can report the examination of the contralateral muscle, but it is prescribed in the literature that the right-handed person will have more problem with the right side trapezius muscle. So we have to ask the history. Many of the previous studies, but they excluded the left-handed person, so I have to ask the handedness of the person, so the values may change. Patient is more symptomatic on the same side. So we can see this is a skin, subcute fat, and this is a trapezius muscle. We can keep the probe over there. It generates shear waves within the tissue and calculate the propagation speed. Though measurements are usually reported as shear wave velocity in the report, the stiffer muscle transmit shear wave faster. So what is the appearance? Homogeneously hypoechoic muscle, the fascicular pattern on normal elastography, uniform color distribution, blue-green shades on most system on the relatively soft muscle. As the muscle stiffness increase, the color changes and the velocity also. So increased stiffness causes we have the muscle spasm, myofascial trigger points, chronic neck pain, fibrosis, fibromyalgia, and overuse injury. So decreased stiffness can seen in muscle atrophy, denervation, advanced muscular dystrophy, and post-treatment muscle relaxation. So first 3 causes were not included in the study. So muscle atrophy due to any cause, due to injury or underuse, denervation atrophy like brachial plexus injury, advanced muscular dystrophy, that is primary muscular disease of any cause, they were not included in the study. So post-treatment muscle relaxation, of course, we can follow up the patients after the therapy. So reporting should be the side examined, muscle thickness, elasticity, focal areas of any increased stiffness, and comparison with the opposite side if applicable, and if the patient is asymptomatic on the opposite side. So this was a visual analog scale what we get from the orthopedic patient with having a myofascial pain on the either side. So VAS scale is very important because no pain, mild pain, there was no change in the parameters. But moderate and severe pain patients, they were having higher stiffness of the muscle. So this is these are referral cases. I just started my study. So we can see the box is in the muscle only. This is only blue color. So this was a normal patient, 35-year-old female patient. There was no pain, no stiffness. This was a control case. So we can see the diameter. We can see the mean velocity 3.9. So this was patient with having mild pain. So there was again the velocities within the range. So there was no change. There was no increased stiffness, but patient was having mild pain. So this was the flaw of the study. So as we go more towards a higher parameter of the vascular moderate pain, we can see the color is changing. We can see the from blue, we can see the red and yellow colors there. We can have a focal areas of hot spots. We can see these are myofascial trigger points. We can target these points on hydrodissection. So mean velocity is now increased 4.9 average. After 3 values, this study showed the mean value of the velocity was 4.9 meter per second. So it is increased. So again we go for the severe pain, severe spasm. We can have multiple red and yellow points. So it is very stiffer muscles. So this study showed the mean value was 6.8 meters per second. So as we go from the normal to mild pain to moderate and severe pain, depending upon the score of the patient and the clinical history, we can see the muscle stiffness is increasing. And according to WHO, there are 4 vitals. What they have mentioned, the blood pressure, pulse, heart rate, and the respiration. So pain is the 5th vital according to WHO. So we should not ignore pain and the symptoms of the patient. We can treat the cervical causes, other causes, but patient is having symptoms. Patient can have limitation of the movement. These patients present with vertigo, and all scans they are normal. So this thing can cause various symptoms. It should be treated accordingly. So advantages of this studies, it is a quantitative study, non-invasive, real-time, reproducible, and we can monitor treatment response. So limitations, again, operator dependency, anisotropy, like the movement the patient is having, non-cooperative. Deep muscles, they are difficult to assess, so that is why we assess only the trapezius upper part, which is the most accessible area. So lack of universally accepted normal reference values. So we will be dealing with the control cases as well as the positive cases. So we may come up with some normal values in our population. So different US system may produce different stiffness value. For we will be using the single machine for the same. So conclusion: patients with cervical spondylosis or any cause may have increased stiffness, reduced elasticity of the upper trapezius muscle. So real-time elastography can objectively measure this increased muscle stiffness using the shear wave mean values. So, and the upper trapezius muscle shear wave velocity is a useful imaging biomarker for screening patients with cervical spondylosis, with poor posture, with neck pain, with muscle spasm, and particularly in patients with the moderate to severe neck pain. Thank you very much.
Thank you, doctor, for the nice presentation. Now I invite Dr. Kartikeya Nathia. He is a director and consultant at Shubhas Ultrasound Imaging Centers, Bhilwara.
If there are any questions, you can ask the questions, because we won't have time for questions after that, till the time we load the presentation.
Hello, good morning everyone. I'm Kartike, and I'm going to talk about a little bit of foreign bodies that I seen at our clinic day in and day out. It is not going to be academically inclined per se, but it is going to be more of a atlas of how we see different foreign bodies throughout the body. These are my disclosures. So the main learning objective of this particular presentation is going to be understand the anatomy and the foreign bodies, where they lies, how they appear, how do we see them, and various ultrasound techniques to see, to look forward to the foreign bodies and to manifest the various artifacts to perceive them, and the appearances of the various foreign bodies. And over the period of few slides, we are going to compare various modalities, how we make out of these modalities to localize the foreign bodies. So as far as the clinical relevance is concerned, most of the traumas and penetrating injuries which come to the emergency departments are connected with the various impacted foreign bodies. They could be radiolucent, they could be metallic, and we have to look forward to the various modalities to look forward to them. The primary complication with the radiolucent foreign bodies is that if you miss them on the initial diagnosis, they ultimately lead to impaction, chronic granuloma formation, abscess formation, or chronic pain syndrome. So to talk about foreign bodies per se, the definition of foreign body is, it refers to any body or particle of biologically inert origin introduced voluntarily or involuntarily into the part of the body to where it does not belong. Any patient presenting at the post-traumatic injuries should always raise a concern for the foreign body impaction. And I think X-ray and ultrasound are the primary modalities, initial modalities, so as to get an idea what we are looking forward to. To talk about the technique, we are in a congress of musculoskeletal ultrasound. Everybody is going to get equipped with 9 to 22 megahertz at their respective institutes. So we need a high linear transducers ranging from 10 to 18 megahertz. A good standoff jelly pad or a water bath technique is required to assess the foreign bodies. Usually the area that you are assessing, foreign bodies don't lie in a particular anatomical longitudinal or transverse plane. They can be in sagittal plane, they can be in transverse, they can be very much oblique, and they can be haywire. And once a foreign body is localized, the important thing where it is lying, you have to decide the plane, whether it is a subcutaneous, subdermal, deep subcutaneous, intramuscular or intraarticular, and you have to survey the adjacent neurovascular area so as to tell the surgeon, if you are going to take this particular foreign body out, you have to look forward to this particular artery, this particular vein or this nerve that you have to salvage during the course of surgery. So if we talk about types, they can be organic, thorns or wooden splinters, they can be metallic, glass, stones or gravels. As far as viewing is concerned on ultrasound, there can be gross acoustic shadowing, there can be dirty looking shadowing, and in organic foreign bodies we can get hypoechoic granuloma around. And the primary identification is on the basis of hyperechoic appearances, acoustic shadowing and artifact recognition. Certain artifacts that I'm going to show in the next few slides, where you can find everywhere. The only thing that I have marked in red, intravascular, I've seen one in the residency, but till date I have not seen those kind of foreign bodies which are intravascular per se, but from head to toe you can find them anywhere. So now let's sketch them. So this particular case is of an individual who had a injury with a glass bottle when he was very young, and presented to us with a kind of a pinchy sensation over his scalp. So there was a chronic fibrotic granuloma formation, and a very, very tiny subdermal foreign body was lying. It was, I think, 0.08 millimeter, which was chronically affecting him and causing pain syndrome while he was combing his hairs or putting his hand at that particular affected area. This particular individual was near to a firecracker bursting, so he presented with a discharging sinus on his upper lip. When we evaluated, what we find was that there are two echogenic foreign bodies were lying. I think marker. So one was lying subcutaneous and another was lying intramuscular, which is basically orbicularis oris. So we were able to tell the surgeon that there are going to be two foreign bodies. One is lying at this particular aspect and another at this particular aspect. Look forward to them. And they finally evacuated both the foreign bodies. To talk about intraorbital foreign bodies, the spectrum can start from your eyelids to the deep areas and periorbital areas. So this particular case, this guy fell down while driving, fell down on a hedge of a thorny bush. For 2 weeks, he just thought it's going to be a superficial scratch, but presented to the ophthalmic department with a kind of a problem of a diplopia, that is one of the eye is not properly moving and he started facing diplopia. On ultrasound evaluation, we were able to see that there is a elongated foreign body which he was not aware of, got inside to the periorbital aspect near to the bony ridge of nose, and it entered through it and impacted on the lateral rectus muscle of the orbit. To the astonishment, eye was completely safe. We make use of 3D ultrasound with the TVS transvaginal probe, and we were able to tell the surgeon that this is the globe and in this manner the foreign body is lying. So yes, you can go and evacuate it quite very safely. So the foreign body was evacuated. When the dissection was done, it was so tight space that it spontaneously came out. I'll just show you the video. So they just dissected the distal most edge, and foreign body spontaneously came out of that particular area. Yes, that's what I heard in Chile also. So that's how this thing came out spontaneously, and he was not aware. The important thing, if you can see that it was intraorbital periocular thorn, and the distance that the size of the foreign body I gave is 38 mm. It was exactly 38 mm. And if you use a meticulous use of probe, you can see that the distalmost edge is having a awkward serrations, and in this 3D also there are some serrations are there, and the foreign body is having exactly same things. So this is the level of transducers that we are using day in and day out, which gives us so fantastic results that we can tell them. And even if something is missing in the foreign body that has been already evacuated, we can tell them something you have lost, which might be lying already in the operative bed. So you just have to look forward to them back again. So this guy had he was just rushing through some dusty wind or something, and post to that he started feeling some concretions and the foreign body sensations. When we evaluated, this is with the 18 megahertz. When we evaluated, there was a very tiny impacted foreign body. Impacted why I'm using, I asked the patient to just move his eyeball with his lids closed, and this was moving along with the cornea. So this was very tiny foreign body impacted at the cornea, and the rest of the eye and lens and everything was clear. So it was just with a little bit of corneal aberration, it was just taken out, and his eye was saved like anything. This is a case 2 or 3 days back. A guy was just out of fun breaking the wood, just for fun, small wood or something, and out of that wood something just popped out from that broken and hit the eye. What in a normal sagittal and axial view, I was able to see focal cataractus, post-traumatic cataractus formation. But when I just tilted a probe a little bit oblique, there was a wood splinter which was hitting the cornea, entering the pupil, and partly the anterior capsular was breached, and a focal cataract was formed. So I didn't get the operative photographs, but yes, it was evacuated, and IOL implantation has been planned after a few days, because so as to avoid initial infective and panophthalmitic changes to be considered. It's an anterior segment wood splinter. Now this patient had, he is a glass industry worker, and there was a glass busting happened and something just entered in his eye. The ophthalmologist was not in mood to get an ultrasound done, because he was thinking that this might get lost from the anterior chamber to the posterior chamber. We just did a CT, and this was a large glass shard. I will show you. It's going to be a gruesome video. So this was a large glass shard which was inside the anterior chamber, and it was very, very big, very big. Yes, of course, it's I only see this video when I'm just working on this particular presentation. Otherwise, I also avoid. So it was a very, very large glass shard. Any foreign bodies can cause anything, let me tell you. It's an anterior segment glass shard. Neck is an exposed area. When we fell down or any kind of trauma is going to happen, so you might get foreign bodies impacted in the superficial aspect. So I'm going to talk about an organic foreign body. So you might get a impacted thorn in the subcutaneous plane with a hypoechoic granuloma. We usually see these things, but we have to differentiate it from what? Lymph nodes. If it's a severely adenitic lymph node, you can get a echogenic hilum with a hypoechoic cortex. But as soon as you put Doppler into it, you will see that there is a branching pattern of vascularity, which is more common with the lymph nodes rather than a foreign body. So this is an example. On the left side, it's foreign body, and that's a lymph node. So talking about the shoulder, these slides, I was not having modality available with the higher megahertz probe. So I did this particular scan with the 9 megahertz. A patient had a history of some sort of trauma. Post to that, he was having weakening in his right upper limb. So basically, there was a metallic splinter was there, which hit through the neck and reached up to the anterior aspect of the first rib. And as soon as we put the Doppler, there was a twinkling artifact because it being a metallic, and the brachial plexus was getting compressed by a large hematomatous collection, which is basically causing the limb weakness. So the important point is you don't require always 18, 19 or 15 megahertz. You can do the things with 8 or 9 megahertz also, linear probes. This child was bitten by his mom with a jhadu. So post to that, he came with that he's having abnormal sensation on his anterior arm, and there was a pinching sensation. So on high resolution ultrasound with 18 megahertz, we were able to perceive that there are 3 tiny splinters of wood which were from the broom got impacted. The important aspect, it was basically in close proximity to the lateral antebrachial cutaneous nerve, through which it is causing chronic impaction, chronic irritation, and neuropathic pain. So these foreign bodies were evacuated by a plastic surgeon, and the place where it was impinging, focal neuromatous thickening of the LACN was also perceived. And all the 3 foreign bodies independently and completely evacuated. And the size that we gave, they turned out to be exactly the same size. To talk about elbow, this guy is also, I think this also happened after a busting of a firecracker. The importance of this slide is that it is located intramuscularly with a good amount of high resolution evaluations. We can very well tell that how beautifully the muscles and the rest of the things can be demarcated. We can very well tell our surgeon that this is lying this much deep into the muscle. This particular muscle is, in this case, brachioradialis is affected. You have to plan your surgery accordingly. You can salvage the radial nerve adjacently, or you can, if it is posterior interosseous nerve, you can safeguard the posterior interosseous nerve. We can give them already inside prior to that their surgery. We can give them a good surgical planning. So on skygram images, there was a hypoechoic structure was seen post trauma. There was a very large foreign body. It was not taken into consideration into a single footprint of the probe. It's a lengthy echogenic intramuscular foreign body. Okay, I'll just take few more minutes, 2 more minutes. So this is going to be another video. It was a very long foreign body, very long foreign body. The important thing that we told them is that it nicked the artery posteriorly. To the plastic surgeon just took the artery, saw the posterior aspect of it. It turned out to be that it had intimal breach has been done. So they just did a arteriorrefy. I'm sorry. So to talk about this particular case is very important. We saw a foreign body. Of course, it is there. We put a localizer. And when we did the ultrasound, we were not able to see it very correctly. There was a very subtle echogenicity around median nerve. So when we did the color Doppler, we were able to find that there is a twinkling artifact. So we were confident enough that this is going to be foreign body, and definitely they evacuated. So I'll rush through the cases. They are quite very interesting cases. You can see the palmar foreign bodies with abscess formation, discharging sinuses. In digits, you can see small impacted foreign bodies with 18 megahertz. You see these beautifully, and with the 9 megahertz also you can make out with the flexor adjacent to the flexor tendons. This is this particular case, intrapatellar tendon foreign body. This particular case is important because that's how I report my foreign bodies. I give them a diagram that where the foreign body is lying. Then I make up a hand diagram that if it is a patellar tendon and it is intratendinous, so from the midline, how much distant it is laterally or the medially from the superficial surface how much deep it is lying and the obliquity of the foreign body. You can sometimes see intraosseous foreign bodies. There is nothing you're going to see on ultrasound, but we tell them that we were finding a little bit of echogenicity, intraosseous echogenicity. Just get an X-ray done, and it turned out to be intrametatarsal nail tip, broken nail tip within the area. You can get chronic impacted wood splinters in the body with collections. In the plantar surface, because sometimes we walk barefoot, there can be such kind of impacted foreign bodies. I'll just take one more minute, sir. Chronic impacted foreign body can cause toe injuries, post-toe injuries can be granulomas and everything. So this particular lady had white discharge and came to us with a brown discharge, and we asked what problem you are having. It was sent to us via gynecologist. So some Baba told her to keep something intravaginally, so it will change your WD problem. Yes, it did. It turned from WD, it turned out to be brown. So it was some odd looking plant thing which she kept intravaginally. I don't know for what reasons. This toddler used to run over the grass, so some wood splinter get into the tiny scrotum of a baby, turned out to be intratesticular foreign body. This guy came with a nodule for Peyronie's disease. We evaluated, we find that a tiny echogenicity in the cavernosum, I think right cavernosa, the right cavernosa was inhomogenic. In obliquity, there was some foreign body was lying intra-cavernosal foreign bodies. There can be some odd areas. There was an echogenicity we saw on a skygram. We evaluated. We thought it to be a stone, and we suspected whether it's a foreign body or obviously we will think of a urethral or prostatic urethral stone. What it was basically prostatic urethral impacted stone, and was some bodged up catheterization was done. It pierced the urethra, went into the perineal body. It was an impacted stone, not a foreign body. So you can see very tiny to multiple foreign bodies. You have to look forward to where they're lying, how much number they are having. And yes, of course, we can make best use of ultrasound on this basis. So all in all, thank you very much for listening to you. Thank you. I'm sorry for that extended time.
Thank you, Dr. Kartikeya, for wonderful presentation and few goosebump moments.
Thank you, ma'am. Thank you.
We can take up questions if there are any questions, and then we break for coffee. Yeah, I think we'll break for coffee then, and then next session starts at 10:45.
Thank you. Thank you. Please. We can mix up. Thank you very much. Thanks. Thank you very much.
हो गया लोड
I've
60
rushed off
percent
to do the presentation. I know, right? Yeah, see you around. Right, yeah, thanks. Like it's a 3D sorting of the whole
I would request everyone to take their seats. We are starting with the next session. I would like to call Dr. Anindita Sinha ma'am. She is Professor, Department of Radiodiagnosis, PGIM at Chandigarh. She has special interest in MSK imaging and interventions.
Thank you, and I would like to now invite Dr. Ravinder Kaur, Professor Ravinder Kaur and Dr. Naren Patel as chairpersons for this session.
Good morning, everyone. Thank you, Dr. Nandita, for calling us. There is slight change in the schedule. Dr. Pankaj Sharma will be speaking first on the vascular intervention for MSK tumors. So I would like to invite him because he has a flight, so he has to leave. So he will be the first speaker for this session.
Thank you, respected chairpersons and organizing committee. Thanks for accepting my request. I would like to congratulate the organizing committee for wonderfully organized this conference. So for next 15 minutes or so, I will be talking about vascular interventions in bone tumors. So these are my learning objectives which I will cover one by one. In MSK field, painful bone metastases are the most common target of intervention radiology palliative treatments. However, in selected cases of bone metastasis, intervention radiologists may play a curative role, also in combination with other techniques, be it surgery, be it radiotherapy and oncologic therapies. And the incidence of metastatic disease is approximately 280,000 new cases per year in India. And if you talk about approach to patient with bone metastasis, it is generally multidisciplinary approach with the involvement of all stakeholders, be it oncologists, radiotherapists, orthopedician, and pain therapist specialists, to offer the patient the best therapy available treatment. And IR procedures play an important primary or complementary role in the management of bone tumors, especially in terms of palliation of pain and treatment of fractures. And usually IR in this field is reserved to non-operable patients or as an adjuvant treatment, not as primary treatment, be it a preoperative transarterial embolization and for palliative cases. So what are the problems which can happen in these various bone tumors where we can offer a role as an adjunct treatment, be it cases where there is severe pain, hypervascularity, be it in cases of pathological fractures. If preoperative, we have to decrease surgical blood loss. If there is local recurrence or patient who are poor surgical candidates where we can offer a palliative care. So this is the prime question which I will try to address in this talk, what an intervention radiologist can offer for this. So if we talk about various intervention in bone tumors, it can be minimally invasive percutaneous interventions, which I will not cover in this talk, or it may be a minimal invasive endovascular intervention, which I will cover in this talk, be it preoperative transarterial embolization or palliative transarterial embolization. So, if we talk about preferred treatment modalities for benign bone lesions, so few of the benign bone lesions I have listed in this, and preferred treatment modalities based on available, based on published literature. So, what are the bone tumors which are suitable for endovascular therapies? If we talk about primary bone tumors, in benign category, these are hemangioma, aneurysmal bone cyst, and GCT, giant cell tumor. In malignant category, it is plasmacytoma, osteosarcoma, or chondrosarcoma. In bone metastasis, mainly where our role comes is hypervascular bone metastasis, be it renal mets, be it thyroid mets, be it HCC or other hypervascular lytic metastasis. So, our role comes as endovascular intervention radiologist is preoperative embolization, and for pain control for palliative embolization, as an adjuvant therapy with other percutaneous image guided procedure for symptomatic bone tumor metastasis, and also in some cases to control bleeding in hemorrhagic control in bleeding bone tumors. So, what are the embolic agents which we can use? If I talk about permanent embolic agents, the main armamentarium which is available is PVA particles and embospheres, which are ranging from 40 to 1000 micrometer. Then glue, cyanoacrylate glue mixed with lipiodol. Now all the intervention radiologists are so well versed with, and it's one of the preferred treatment embolic agents we use. Some cases now onyx is also we have started using the onyx also in some cases. Then coils and ethanol has less role. And if we talk about temporary, then gel foam. Specifically, if we are doing preoperative embolization, where our target is to do embolization only 48 to 72 hours prior to the surgery. There is no role of doing this preoperative embolization more than 72 hours prior to surgery. So we have to talk with our surgeon friends when you are going to operate, and we have to schedule our embolization. Just what we prefer is generally to do in 24 to 48, but guidelines says you can do in up to 72 hours. So what is the choice of embolic agents? It all depends on, first it depends on who the operator is. If I'm very well versed with using glue safely, then I will prefer it. So operator's experience and his comfortability with the embolic agent. Then second important is vessel size. Which vessel size I need to embolize? Whether I want distal most embolization, I want proximal embolization, and desired permanence of embolizing agent. And if I'm using glue, then flow velocity will be one, because my mixture of glue with lipiodol will all depend on where I want. I want only at that point, or I want some distal also. So I will change the combination. So preoperative embolization is one of the most common endovascular therapy for bone tumors. And idea is to embolize the safe artery with PVA particles, gel forms, or embosphere or glue. And common tumors requiring preoperative embolization are aggressive hemangiomas and vascular bone metastasis like RCC, follicular carcinoma, thyroid, and HCC. So what are the technical considerations? First point, I already covered that. Guidelines says up to 72 hours, but we generally in our practice we try to schedule it only 24 to 40 hours prior to the surgery. And many times we have also taken, if they are scheduling in afternoon, we take the case in the morning, we do the preoperative embolization, we use gel foam, and then they take it for surgery. Most important is with the armamentarium available, the hardware available, super selective embolization is now the key which we practice. And identifying critical anastomosic pathways is specifically helpful, specifically if you are talking about neuro cases. ECA, IC anastomoses in calvaire tumors is most important. I will show a case also. Avoid spinal arteries, vertebral lesions. You don't want your procedure to do harm to the patient. So whatever time you spend on pre-operatively on planning your case is most important. Doing the procedure is only 25%, 75% is your planning. And protect skin supply in periphery is very important. And also when you're using glue for very superficial, your experience counts. So what are the benefits is we are able to reduce 40 to 70% reduction in blood loss. Then the surgeon has better surgical field visualization and has reduced operative time and reduced blood transfusion. What complications can happen? Can have range from minor, commonly pain, fever, and post-embolization syndrome, which is common. And we have to tell the patient prior to doing this procedure that this is can happen, but we will take care and we can manage. Major can be if you are not planning well, you are not reading the images well, is osteonecrosis, non-target embolization, causing skin necrosis or neurological injury and infection. So if I start with the cases, this is a case of a 48-year male with metastatic RCC, had multiple metastases in pelvic and long moves, and had painful pathological fracture in right femur. So this patient was planned for intramedullary nailing, and we did, if we shall see the images, preoperative embolization shows hypervascular tumor in right proximal femur shaft and ischium. And these are the post-embolization. This is a preoperative. Post-embolization picture, you can see near complete stasis in post-embolization angiogram. And the post-surgery, the surgeon told us there was no significant blood loss. And post-operative pain was also reduced in this patient. Second case, this is a case of a 26-year-old calvary hemangioma in right frontal bone. And here, if you see, there's increased vascularity here. So preoperative embolization was done with 100 to 300 micron embospheres. And this patient has feeders from superficial temporal artery and dural branch of anterior ethmoidal artery. And the surgeon was able to do significant debugging, and surgery was uneventful. And we can see significant reduction in blood flow in this target area. Then third case is a preoperative embolization of osteosarcoma of the left femur, where the orthopedic oncologist asked us, requested us to do preoperative embolization. And if you see, this is the preoperative picture, and this is the post embolization, where you are literally seeing no blood in the territory which is going to. Then this patient was sent to us for preoperative embolization of vertebral hemangioma. If you see, this is the vertebral hemangioma, and you can see the increased vascularity. So this patient also we took for preoperative embolization. And if we compare this, this is the this is sorry, this is wrongly written. Preoperative is post embolization picture. This was the pre-embolization picture, and this is post-embolization picture. So, this another patient was sent to us. This patient has significant spinal cord compression, and before surgeon could take this for surgery, patient the operating surgeon wanted us to decrease the blood supply to this room. So here, if you see, there is increased vascularity, and this is the post embolization picture, where we are seeing literally no blood flow in this vertebral hemangioma. And this patient was successfully operated by the surgeon, and feedback we got was that he did not had any problem when operating this tumor, where it was causing spinal cord compression. Then another case, this was a case of myxofibroma of the right thigh, and this was the increased vascularity, and this is a post-embolization picture, where we are seeing very decreased supply. So another area where we can do is endovascular therapy in ABC. We have not experience in this, but there is ample literature available that in ABC also, as part of preoperative tumor embolization, even in primary embolization of ABC can be done, but we have not done till now. We have done for mandible, other things also, but not primary ABC. And embolization reduce this size of lesion and reduce progressive sclerosis and trabecular bone formation in ABC, and success rate is almost 70 to 90%. And it can be used in conjunction with the intralesional sclerotherapy, polydecnol or ethanol, and also useful in recurrent lesions or lesions in difficult surgical locations like pelvis and spine. So I will end my talk by saying that vascular interventions form one of the essential components of modern management of bone tumors. Preoperative embolization significantly reduce operative blood loss and surgical time, but the timing of doing preoperative embolization is most important. Plan your talk with the surgeons, do the preoperative embolization as close to the surgical time as possible, because the chances of success and the field, the operative field being literally no blood there is only possible if you do within 24 to 48 hours. Endovascular therapy forms adjuvant therapy for procedures like ablation and cementoplasty, improving patient outcomes. And vascular intervention radiologists form an essential part of multidisciplinary orthopedic oncology team, and it is a multidisciplinary approach which helps in this. What we are offering is a complementary and palliative care, so this is most important. And these are my references. Thank you all for patient listening. If there is any question, I am ready to answer.
Thank you, Dr. Pankaj. Thank you for the excellent talk.
Thank you. Thank you, ma'am.
So now I would like to invite Dr. Naveen Rajaduri. He is consultant musculoskeletal interventional radiologist at KPJ Damansara Specialist Hospital.
Okay, thank you for the kind introduction, and good morning, everybody, and thank you for the invitation to actually come and speak in your conference. You know, I thoroughly enjoyed my visit here to Ahmedabad, my first time, and we will just get along to our lecture for today. So I'll be talking about MSK radio frequency ablations, indications, techniques, and outcomes. I have no disclosures. So it's important before you embark on doing any MSK intervention, especially in ablations of your bone, you have to decide whether the indications of performing ablation. And usually when it's a primary MSK lesions, looking at some benign lesions such as osteodosteomas that actually respond quite well to radiofrequency ablations. And for secondary lesions, can involve things like metastasis or pathological fractures originating either from the breast, lung, prostate, and kidney. So it's important to also to interrogate the pre-procedural imaging, and I always perform an MRI, just a plain and contrast, to assess the margin of the lesion, the vascularity, also to differentiate necrotic from solid components, and to determine whether there's any nerve or vessel encasement. CT sometimes can be advantageous for staging of a patient whenever the bone tumor is, you'd like to just know whether the severity of the patient's disease, and to evaluate whether there's an osseous component of the lesion, to plan the track for the ablation, as well as access the root of lesion, either via a 2D or a 3D pathway. And in some instances, you may then need to also perform a PET, CT, or MR to enable therapeutic ablation of metabolically active lesions for baseline imaging, and to also follow up to evaluate success of treatments. So again, tumor biopsy is important for most lesions, whether it's benign or malignant. Sometimes you just need to just go ahead and do it. And especially for specific bone tumors which may have specific characteristics, thus omitting biopsies like osteodosteomas. For the rest, most of the time, you still need biopsies for confirmation. For secondary metastatic lesions, you may not need a biopsy when a known primary is already seen, unless patient has an unknown primary with multiple primaries, or doubt that the lesion is actually a secondary localization of the known primary tumor. So treatment strategy depends on the patient's histology of the tumor. The general condition of the patient is also important. Understanding the disease process, the degree of bone destruction, whether there is a need for additional consolidation, and also the precision of treatment goals. So again, treatment goals will depend primarily whether it's for palliative source or for curative. And in the instance of palliative, then you would like to do more of a tumor debulking sort of treatment, where the targeted ablation is for the painful lesions, i.e. whether it's a primary tumor or a metastatic lesion. And if the decision is made for curative purposes, then for benign lesions like osteodosteomas, osteoblastomas, chondroblastomas, and motoneuromas. And for malignant lesions, whether it's a multiple decision for slow glowing lesions with less than 3 proven locations and less than 3 centimeters in diameter, or for recurrent metastatic lesions at the tumor bed. Again, tissue monitoring is important, so you can embark on a passive monitoring where you use thermosensors for direct temperature measurements. In the treatment of vertebral lesions, sometimes you would administer a thermocouple, they are positioned in the epidural space to constantly monitor the temperature in the neural foramina and spinal canal, where ablation should be ceased when the temperature of 45 degrees is exceeded. That's what I usually practice. For procedural performed under GA, peripheral nerve function may be monitored during using electrophysiological monitoring, and for electrosimulators may be used in the periphery in contact with major nerves, and evidence of reduced responsivity during ablation should prompt cessation. Again, so now for active protection, usually active temperature modulation adjacent to the ablation zone and displacement technique should be utilized. So sometimes you can use a hydrodissection to just push the or to cool the area around the lesion, and for thermal monitorings are recommended. Continuous irrigation with epidural or periradicular infusion of normal saline is recommended when the target is less than 8 millimeters from the adjacent nerve roots, as displacement effects are limited in these settings. So you may also decide to do a consolidation. So you want to consolidate if the lesion is, if you have a lytic lesion within the bone, you may then complement your treatment with consolidation to prevent or stabilize the pathological fracture. When it's curative, then a percutaneous osteoplasty should always be preceded by a definitive ablative treatment. And thermal ablation can be combined in a single session with osseous consolidation using cement and or augmentations with metallic fixation or stabilization devices. And for probe-based technology, you can put polymethyl acrylate may be injected following ablation through the same trocar used to introduce the ablation device. If upon the same session, one of the heat-based modalities, cement injection should be delayed to allow the local temperature to reduce first in order to prevent too rapid cement consolidation during a procedure. Okay, so I usually try to stick to this guidelines that was proposed actually by Professor Ganji, my trainer, in 2010. And even then, the decision for your tumor management or ablation should decide whether you're at the beginning, whether it's for curative purposes and for palliative, right? And recently, there has been an update to this. There was a CERC practice of guidelines. I advise you all to please have a look at this paper that was actually published in 2022 by the CERC, and it really clearly defines the ways of how you're going to perform bone ablations. So even here, they even tell you the different modalities that you may and procedures that you may do for your thermal ablation, whether RFA, microwave, whether it's laser, cryoablation, or MR HIFU. So heat ablation in the bone. So it has a low conductivity and poor thermal conduction. So RF ablation range is sometimes limited, whereas microwave sometimes penetrates bone deeper and is less affected by tissue heating or desiccation, thus providing more effective ablation zones. RFA is, however, indicated for osteolytic or mixed osteolytic osteoblastic lesions with no or small extraosseous component. Where an extraosseous soft tissue component exists, ablation of the soft tissue bone interface can achieve pain palliation. So as compared to radiotherapy, which is expensive, repeated treatment limited by dose with delayed onset of effect, percutaneous therapy is actually easily available. You can easily repeat it with sort of immediate effects seen by the patient. So I'll just compare now what microwave and RF does. So in radiofrequency ablation, usually uses an alternating current producing ionic agitation that heats the tissue and causes coagulation. Whereas microwave uses electromagnetic field where water molecules that are natural dipoles are heated and they rotate within the change of the electromagnetic field at a very high frequency. So this produces dielectric heating. Okay, so these are some of the differences and advantages and disadvantages of radiofrequency ablation versus microwave. And the RFA probes are usually metallic needles with exposed cutting active tips with varying and adjustable lengths with insulated shafts. So you can use either straight probes or umbrella configuration probes, and RFA probes may be monopolar, requiring grounding pads, or bipolar, where the grounding pads are necessary. Okay, specifically for spine mats, sometimes bipolar radiofrequency electrodes are available with thermocouples that can be easily combined for tissue protection, ablation, and vertebral augmentation in a single treatment session. So this is the conventional targeted RF ablation system. So usually you have control access with a control energy delivery. So there's an RF generator, as you can see here on the left side, and this is the RF ablation instrument or the probe. Okay, so what you see here, that is the active navigation that actually enables site ablation zone throughout the vertebral body, and then there's also thermocouples there to monitor the temperature of the probe at the distal as well as the proximal end of the probe. Okay, so there's real-time monitoring, as you can see here. So this is what the picture that you see on the RF systems. So I'll just go to a few pathologies that I usually ablate. So osteoasteomas are benign bone neoplasms, about 2 to 3% incidence, classified into cortical or medullary. Okay, so this is the osteoid osteoma formation. Okay, and as you can see in extra-articular and intra-articular, they have very different clinical presentations. Usually extra-articular presents with nighttime pain, and in intra-articular osteostomas usually limited joint range of motion and joint effusion. They may have day or night pain, and that may respond to NSAIDs, and usually patients have some bone angulation with some joint contractures. Okay, so again, so the differences between the extra-articular and the intra-articular lesions. And the treatment historically was surgical excision. Now currently ablation has emerged as the gold standard, and you may either employ a radiofrequency, microwave, laser, or cryoablation. So this is a lesion that we did for the neck of femur, so in a pediatric patient. So sometimes approach is very important. So like the previous speaker said, planning is important. You'd like to plan your route of entry and the position of where you're going to place your needle before you embark on your ablation. And you can see here, you do not want, especially in pediatric patients, you want to avoid actually simulating a fracture. So this is a patient with an osteoma in the cervical region. So we put in a needle here, this with the patient ventilated, and then we did it with the patient prone, and we put in the radiofrequency needle into the, you need to position the needle right in the center of the nidus to ensure that you have the ablation of the entire nidus. This was a recent case done actually just 2 weeks ago for a patient with a thoracic osteoma, and then we put in a needle. So in this case, because the lesion was actually a bit far from the neural foramina, I did not put in a thermocouple to actually monitor the epidural space. Otherwise, usually I would have irrigated the epidural space with some cold saline prior to doing my ablations. So decision for metastatic lesion, whether the lesion is stable or unstable, sometimes it can be a conundrum. And then I usually follow this SIN score, which is the spine instability neoplastic score, to decide on the stability of a lesion prior to doing my ablation. So this is an example, a 75-year-old woman, right TCC with spine oligometastasis. And then what we did is actually we did a radiofrequency ablation. So you can see here, this is a steerable needle where you actually can steer the needle to the inferior pole of the lesion as well as the superior, and then you can deploy your radiofrequency needle and then simulate your ablation. And then after you remove your needle via the same trocar, you can actually perform vertebroplasty to actually make sure that you build some consolidation within the bone to prevent it from actually fracturing later. Okay, so these are the corresponding CT images. Okay, so currently, so there is this new study that I've been also involved with. It's called the SPARTA study for radiofrequency ablation for treatment of bone metastasis, with the initial results just published in CERCI journal and recently, and also in CVRR. And the results have been quite promising, with rapid and substantial pain relief within 1 month and improved QOL with supporting radiofrequency ablation in combination with vertebroplasty, with level 3 evidence and prospective cohort study. So we are, they are extending that study to our multi-center, and we are doing it in Malaysia as well. So this is the system that we are using. It's called the spinary system. So it has a monopolar and bipolar, and the advantage of this system, it has a thermocouple that you can, that has real-time monitoring for the lesion, and you're also able to see the temperature increase within the lesion throughout the ablation process. Right, so this is a case that we did just about a month ago. So this is a patient who presented with multiple metastases within the scapula and also within the spinal vertebrae. The patient actually complained of the painful lesions at the scapula and sacral lesion. Coincidentally, patient also had other lesions, but we did not attack that because the patient's prognosis was for palliative, and this was more for pain control. Okay, so what we did then, so this was the lesion that we did for the scapula. So we put the patient prone, introduced lesion. We did an ablation for the lesion, and after that, this is the lesions in the spine. So we first did an epidural injection first, just to reduce the inflammation around the surrounding nerves, and after that we put in the needle, did the ablation, And then after that, we did the cementoplasty, and these are the outcomes, and we can see the pictures. So disadvantages of thermal ablation: sometimes there's inability to visualize the ablation zone under CT or ultrasound, resulting in difficulty in achieving precise area of necrosis, hindering the ability to guarantee the safety of the temperature sensitive fractures. So sensitivity to heat sink effect is something you need to be aware about, and poor efficacy in osteoblastic lesions. So that's when RF doesn't work so well. And great care is required in placement of the probes in vicinity of metallic surgical fixation devices to avoid potential adverse heating and electrical effects. And sometimes bipolar probes are recommended in this setting, as it uses as the use of local tissue temperature monitoring and protection is less needed. So complications of thermal ablations: thermal injury to the spinal cord and nerve roots resulting in myelopathic or radicular symptoms. So mostly they are transient, can be managed by transforaminal or epidural steroid injections, like you saw just now. So I do that as a prophylactic measure just to prevent it from happening. Sometimes it can weaken bones with risk of fracture, which may be minimized by cementation. Cement leakage into the central canal or epidural space may worsen pain, and in severe cases can cause spinal cord compressions. And thermal injury can also be caused by exothermic polymerization of extruded cement. So this is something that you need to actually think about. And cement pulmonary embolism sometimes can be caused by cement leak into the caval or azygous venous system. Collateral soft tissue injuries such as bronchopleural fistulas are rare, but may be managed conservatively by thoracostomy and all. So in summary, so the treatment goal, we have to decide whether it's palliative or curative at the beginning. Please review your preliminary imaging. Choose your type of ablation, whether you prefer radiofrequency, microwave, cryo, or etc. And finally, you may decide to combine therapies if needed, if you want to ensure some amount of consolidation if it's a bony lesion. So with that, I conclude my presentation. So thank you very much for your attention.
Consultant interventional radiologist at Hyderabad, special interest in interventional radiology, MSc radiology. He was recipient of Young Radiologist in year 1999 and another recipient of Vaidya Sri Award in 2012. Authorized 4 chapters in comprehensive textbook of clinical radiology. Over to Dr. Salapati Rao.
Thank you, sir, for that nice introduction. Good morning, and at the outset, I would like to thank the scientific committee for giving me this opportunity of presenting this topic. So, majority of the population would have suffered from spine-related pain at some point in their life. So, it is a very common problem. And then spinal interventions play a very major important role in managing them. So selected patients can benefit significantly from the targeted treatments. So most of these patients will have multiple degenerative changes or multiple causes of pain. So identifying the real cause of pain and treating is the key to a satisfied patient. So the cause of pain can range from simple paraspinal muscle spasm to facet joint arthropathy, or intervertebral disc disease, ligament or nerve root diseases, or fractures of vertebrae, or even tumors or metastasis. So a large range of diseases can cause spine-related pain. So prior to intervention, all patients should be clinically evaluated. This is mandatory, and then this cannot be skipped. And this should include a history of the presenting complaint, physical examination, neurological examination, and a review of any available imaging of the spine. So imaging guidance significantly increases the accuracy and decreases complication rates. And minimally invasive procedures are less injurious for paravertebral muscles with substantially less complications when compared to any sort of open procedure. So imaging modalities commonly used for precision approach are fluoroscopy, computed tomography, CM or cath lab, and in few cases ultrasound imaging. So we'll discuss the indications, methods, complications, and results of some of these minimally invasive techniques in the management of spine-related pain. So these are all the interventions one can do: the facet joint injections, epidural injections, SI joint injections, and then percutaneous vertebroplasty and kyphoplasty, thermal ablation of spinal tumors, endovascular procedures for spine pathologies, and targeted disc decompression to treat symptomatic disc herniations. So coming to pre-procedure workup and patient preparation, routine blood work needs to be done, including virology markers, and then if the procedure is planned to be done under any other anesthesia other than local anesthesia, then it is very important to get a pre-anesthesia checkup done. Otherwise, it will be a surprise for anesthetist, and then case may get postponed. So coming to anesthesia, most of the procedures are done under local anesthesia. But if you are planning to use any ablative device, then it is better to do it under either conscious sedation, spinal or GA, as the case may be. And then IV sedation may be required in children and apprehensive patients. So the most important step in the whole process is symptom imaging physical examination correlation. This is we cannot emphasize it anymore, because this is the key to successful treatment, and this in turn will guide the procedure selection and then our planning for the procedure also. So we'll start off with facet joint injections. So facet joint syndrome is a common cause of chronic spine related pain, and then it may result from segmental instability, synovitis or degenerative spondyloarthritis. So facet joint injections are used for both diagnostic and therapeutic purposes. If you are in doubt, you just inject with a local anesthetic injection and then wait for a few days and then see the response, and then go ahead and inject the steroid. So these injections are usually guided by fluoroscopy or CT. I prefer to do it under CT guidance personally. So these injections can be intra-articular or pericapsular. Pericapsular injections block the medial branch of the spinal nerve, and then intra-articular corticosteroid injections can help reduce synovial inflammation. So the injected solution consists of local anesthetic injection, usually bupivacaine 1 to 1.5 ml with a corticosteroid, most of the time particulate corticosteroids, either methylprednisolone or triamcinolone. So these are few examples. Patient is put in prone position, and then under CT guidance, one can place the needle within the joint and then inject with either anesthetic or steroid or both. So if the lesions are there on both sides, injections can be given in the same go, thereby reducing radiation exposure to the patient. So possible complications include hemorrhage and infection. However, adverse events are exceedingly rare, and then pain relief from these injections may last for few weeks to a few months. We'll go on to SI joint injections. Up to 27% of the patients suffering from low backache may be suffering from SI joint related pain, and then pain may be caused by inflammatory arthritis, trauma, degenerative joint disease, obesity, pregnancy, spinal surgery, or joint asymmetry. SI joint injections are used for both diagnostic and therapeutic purposes, same thing as facet joints, facet joint injections. This can be either guided by fluoroscopy, CT or ultrasound. Again, I prefer CT guidance. And then injected solution consists of triamcinolone or methylprednisolone along with a few ml of local anesthetic. These therapeutic injections give prolonged pain relief. This is an example. Patient is put in prone position and then place the needle within the joint and then complete your injection. Patient gets excellent pain relief very soon. And then we'll go on to epidural injections. Indications include acute and chronic nerve root irritation. Etiology includes herniated discs, spinal canal stenosis, post-discectomy syndromes, and etc. So epidural injections can be transforaminal or interlaminar. A mixture of local anesthetic with steroid will be injected. These injections can give short to medium-term pain relief. These transforaminal injections are given when an involved nerve root can be specifically localized by history, physical examination, and imaging. Otherwise, an interlaminar approach is needed. It is less selective and may be used when a specific nerve root cannot be identified or if multiple nerve roots may be involved. I'll show a few examples. This is a transforaminal injection of S1 nerve root in a patient with post-discectomy status. A mixture of triamcinolone 20 milligrams with 2 ml of local anesthetic were injected. And then this is a case of epidural interlaminar injection, a case of lumbar stenosis. A solution of triamcinolone 40 milligrams with 3 ml of local anesthetic were injected. So we'll go on to percutaneous vertebroplasty. One of the most rewarding procedures in terms of patient pain relief and patient satisfaction, because those patients who are in severe pain, who are unable to move for weeks together, bedridden, will get almost instant pain relief within a few hours, and then they start sitting and then start walking within a few hours. So that way it is a very rewarding procedure. And then the indications are painful osteoporotic vertebral compression fractures, vertebral metastasis and myeloma, vertebral hemangioma, lymphoma, and sometimes as an adjuvant procedure after thermal ablation of painful metastasis. So vertebroplasty cement consists of 20 grams of polymethyl methacrylate powder with 9.2 grams of liquid monomer solvent. This also contains barium, tantalum or tungsten to increase its radio opacity. So the viscosity of this mixture progressively increases due to polymerization of the methyl methacrylate. During this polymerization, this mixture becomes cytotoxic because of its both chemical and thermal effects, and then patient gets good pain relief, and this pain relief can be obtained even with very, very small amount of injection also. Even 1.5 to 2 ml of this injectate will give excellent pain relief to the patient. It need not have to be a large quantity. So coming to the contraindications, cord compression is a definite contraindication. Any sort of infection, either localized or generalized, localized like osteomyelitis or discitis, or active systemic infection are definite contraindications. Any uncorrectable coagulopathy or allergy to any of the components used in vertebroplasty is also a contraindication. So coming to relative contraindications, coagulation disorders which can be corrected, and then we can do the procedure afterwards. And then fracture of the posterior vertebral body wall or vertebral collapse more than 70% of the body height. One needs to be extremely careful while giving the injection. So vertebroplasty is usually performed under fluoroscopic guidance or CT guidance. I usually do this procedure under local anesthesia. And then needle progression and cement injection are best assessed with both anteroposterior and lateral fluoroscopic guidance without moving the patient. All the time I do this procedure in a cath lab, in a good cath lab, where you can see the needle very well during the procedure. And then one advantage with doing it in cath lab is you can have a continuous monitoring of the bone cement when you are injecting it, where it is going, so that if it is going elsewhere, you can just stop the procedure and then restart it again. So a transpedicular or posterolateral route can be used for the lumbar spine, and then use of the transpedicular route avoids spinal segmental nerve injury and decreases the risk of leakage of bone cement into the paravertebral tissues. So coming to the complications, epidural or foraminal leakage may give rise to neurological symptoms. One needs to be extremely careful. And then highly vascular lesions and liquid consistency of cement may cause leakage of bone cement into perivertebral veins. And then if one is not careful, this may lead to pulmonary embolism. So leakage of cement into adjacent discs or paravertebral tissue may also occur, but usually patient remains asymptomatic for these minor complications. And then risk of infection should be avoided by following meticulous aseptic precautions. So few examples: 67 years male came with a complaint of backache following a fall 7 weeks ago. And then on examination, pain is localized to lower dorsal vertebral level. On this radiograph, you can see that one of the lower vertebral bodies are showing wedge compression fracture. and then patient was put in prone position, and then initially the needle was placed via left pedicle into the vertebral body. You can notice the tip of the needle was placed at the junction of anterior 1/3 with the middle 1/3 of the vertebral body, the ideal location for injecting the bone cement. And then bone cement was injected, which got distributed very well, and then afterwards the same thing was performed on the right side, and then finally the result was excellent. Patient got excellent pain relief. So one more example, this patient was bedridden for almost 2 months, 2 to 3 months, 3 months, and then on clinical examination, pain was localized to L1 and L2 vertebral bodies, no neurological deficits, and then again radiograph showing L1 and L2 vertebral bodies showing wedge compression fractures, and then bone cement was injected. This patient developed 2 minor complications. One is leakage of bone cement into paravertebral vein on left side. We watched it in time, and then we stopped injection there, and then fortunately patient did not develop any pulmonary embolism, and then there is intradiscal extravasation also. So patient got excellent pain relief. By evening he started sitting and then started walking, and then on follow-up patient never developed any sort of symptoms for these minor complications. So we will go on to percutaneous ablation of spine tumors. So these can be benign tumors or malignant tumors. And then ablative techniques, all these ablative techniques are used. Most frequently it is RF and laser, sometimes cryo. And then I'll give a few examples. 12-year-old female child, backache for 6 months, more in the nights, relieved with non-steroid anti-inflammatory drugs. And then child also developed scoliosis. So initial imaging showed a osteoid osteoma involving the right lamina of D9 vertebra with a very, very thin anterior cortex. So we decided to do a CT-guided laser ablation with a thermal protection technique. And then 5% dextrose was infused through the epidural needle at a rate of 1 to 2 ml per minute during thermal ablation to protect the spinal cord. And then, yeah, so 2 more minutes, I'll conclude. Laser energy delivered was calculated based on the formula nidus size into 10 joules plus 200 joules. And then the nidus was measuring 10 millimeters, so 1200 joules of energy was delivered. And then initially the needle was placed into the epidural space via transforaminal interlaminar approach, and then checked with the injection of few ml of air. And then infusion was started with 5% dextrose, and then the needle was placed within the nidus, and then ablation was completed, and then child got excellent pain relief, and then parents were extremely happy. So I'll conclude my talk here because the angioembolization of tumors was covered by the previous speaker, so I'll skip that. So to take home message is first approach to painful spinal lesions is always through a thorough clinical examination and diagnostic evaluation. One should not be treating images, and then imaging guided injections and treatments for spine related pain are safe and effective, and then serious complications from these procedures are extremely rare. And I thank you all for your kind attention.
Thank you, Dr.
And then I
Chalapati
see you all in Calcutta. Thank you.
Thank you very much, Dr. Chalapati Rao, sir. You have delivered excellent cases. And now our new speaker is Dr. Raghav Agarwal, sir. He is presently director at ML Agarwal Imaging Center, New Delhi. His area of interest is MSK ultrasound. He presently is National Coordinator in Preventive Radiology Committee of IRI 2026. He is co-organizing chairman at 79th annual conference will be held at Delhi. Over to Dr. Raghav Agarwal, sir.
Thank you so much, sir. At the outset, I congratulate Drushi and Ankur for this excellent conference, and our president and secretary who are there, and MSS for being such a close body. And it is more like homecoming, and I think We are all here, we gel so much, and then we love each other and we fight and then we reunite. So that is the concept how we have evolved in MSK interventions also. So you make mistakes, you learn, then you don't make the mistakes again. So having said that, we all know, I'll try to just go through things. I really don't know what to do. So I had a chat with DK, what should I do in the talk? He said, do this. Then I realized that I'll try to just have a chat. So we know what is in plane, what is out of plane. The important thing is, when I started, you should not panic when you don't see the needle, right? It is okay to make mistakes. It is not okay to make them every time, right? So you should know where your needle tip is. You should know where the path of the needle is. Just scan previously, make a diagnosis. Whatever the MRCT has done, sometimes by the time the patient comes to you, the pathology is already healed. Make a diagnosis, see the path of the needle trajectory, plan your technique. Sometimes we do a dynamic planning technique, sometimes you make a trajectory and do it. So in plane, you see the needle throughout. Out of plane is a walk down technique. And the third technique which we now regularly use is through the sterile jelly, we try to make the needle parallel so that we can create the out of the plane into an in-plane technique, and we can actually see the needle throughout the course. This is an in-plane technique. So I'll rush through this. Sir wasted so much time in introduction. So really, so we have the target, a needle and the hand. So out of the, unless you are dealing with a foreign body, your target is not moving. So at one time, either the needle moves or your probe moves. Once you get lost, don't worry. There is rotation, compression, translation, heel toe and toggle. And you can do a jelly standoff. There are 6 maneuvers or a partial compression. So you have to just remember your maneuvers. You don't find the needle, go back. And if you have to take out the needle, you have to take out till the subcutaneous tissue because the muscle will anchor it. So don't worry, and some once in a while, don't show too much of panic. And if you have the orthopedic with you and you are not able to see the needle, they'll tell you to show the needle, and then they'll sort of, once in a while the clinician will bully you, so it's okay. So you'll get used to it. So this is about the technique. We'll move forward. Just try to show you a few things. This is the out of the plane technique. We walk down, we keep on coming down at an acute angle between the probe and the target, and then we keep on coming down until we hit the target. I think this all has been covered in workshops and everything. This is the jelly standoff technique. So over the years, I've seen masters do it. I was so fascinated. How will I do it? Then I came back, I tried, I failed. I practiced. Then I could do it. And then there were phases of frustration when our colleagues would send you their relatives, their patients who they did not want to treat, or some VIP, right? Or where they have messed up. And then they used to tell me that this is the procedure you have to do. We had no opinion. And then we had to re-inject. Believe me, nobody questions an orthopedic or a clinician if they are re-injecting multiple times. And the pain consultants are injecting. We have had one patient getting multiple injections from different doctors. So you just see what has been done with the patient. Then I also started injecting everybody, as everybody was doing. Then over the time, it is very difficult to say no. Like you go to a party and somebody offers you a drink. So it's very difficult to say no to a drink. So you have to learn to say no sometimes. So, and over the last about 10 to 15 years, you sort of develop your own personality and your own protocols and techniques. So I'll show you a few cases, but my main aim is that don't get worried, start injecting, you will succeed. And don't be too enthusiastic. Maintain a low profile, but be confident, right? So I'll discuss my experience in the last 10-15 years. So what do you mean by needle mastery? I asked Dr. Dharmender the other day. So he also had a query. So because I still am learning. So the art of choosing the correct patient for the correct procedure and when to say no, that is what I feel is needle mastery. So, and what over the years we have understood is sometimes injecting a larger volume of a chemical, of a PRP or a steroid, we use smaller volumes at multiple sites. We use a combination of a steroid in one part and PRP in one part, or a steroid in one part, anesthetic in one part, and fenestration in one part. And then you have to be very careful who you are treating. If you're treating an in-plane, a player who is in competition, you should be knowing what doping is, right? You should know what a TUE, temporary utility exemption form is. Then there are specialized injection techniques where you create a jelly standoff by injecting an anesthetic in the subcutaneous tissue. And then we have these newer techniques which we are developing. We already have a lecture on elastography, but this time we have been able to, we have sent it for publication, hope it publishes. So we know that tennis elbow can be diagnosed, we inject. So we thought it was tennis elbow tendinosis, but when we injected, there was a full thickness tear. So we do the procedure, but report on injection, we saw a full thickness tear. Just document what you see. Then we have calcific tendinosis, which can be fenestrated. So these techniques, I am seeing the target and the needle, so I know where I'm doing it. So many times you're doing the best thing, but it doesn't work. It's okay. A very important thing about doing your interventions, if you are doing sports injuries and rehabilitation, is that degenerative diseases, that rehabilitation has to be so many times planned by you. Please examine your patient. There is a book called Bruce Reader. It costs about 1,200 rupees. It's a clinical orthopedic examination. I think everybody should have it. And don't expect your clinician friend to teach you, because so many times they have worked up cases, they have not seen the patient. I'm not criticizing. So this is like you have a swimmer in competition, just needs a steroid. He has a competition after 10 days. I do intra-articulate 20 mg Medrol, in bursal 20 mg Medrol, and I'm out. So and then you be prepared for the TUE form also, because the music you will face. So then we have, this is a out of plane fenestration of the gluteus medius tendinosis in a weightlifter. You can see that, I can just see the needle tip here. And in all these videos, we can, my aim is not to show you the techniques. My aim is that whether we do it, have I been doing it and it has been successful. This was a common, this is a grade 2 tear of the conjoint tendon of the thigh. We can see there is a healing tear, small tear with granulation tissue. So we thought of doing a platelet-rich plasma. We fenestrated, and when I injected, again a huge tear. I could see a huge tear. It's okay. So you can use a fibrin-rich. There are different kinds of injectates which you have to be aware of, and you have to use the correct injection. The tear, doing fenestration, doing a PRP, doing a GFC, or doing a plasma injection. Then you're doing chondromalacia patellae. What we do is, we do the injectate, and we also sort of touch the chondral bone. We sort of create a trauma. Calcium chloride was used previously, but we just create a trauma because already trauma is there. Plantar fasciitis, important thing, do the tibial nerve block. The only thing is that don't get afraid when you have your first vasovagal, have your crash tray in place, have your team in place, have your anesthetist in place, at least in range. So you do your fenestrations, you can do a plantar fascia if you're doing a steroid. It has to be over the plantar fascia and below the fat pad. What I use is, if you're doing a PRP, you can do the nerve block and do the PRP. And if you're using, I think I just have 6 minutes, I'll quickly go through. Calcific tendinosis of a conjoint tendon, fenestration with calcium. Pubalgia, injection, guided procedure, go to the correct place. ATFL, out of plane fenestration of the ATFL for fibrosis. Tennis player with a ganglion cyst, really didn't know. It's a very old slide, but nobody saw his other hand, similar signs. So the MRI showed a ganglion cyst, reported by a colleague. And then we saw there was an adductor digitorum manus brevis tendon which was impinging. The MR saw the ganglion, and this tendon was not reported. But when we saw this was a tendon was impinging on the ganglion cyst, so your diagnosis will dynamically change. So I saw this tendon because after the extensor retinaculum we will not see it. Here you can see we fenestrated the cyst, injected the steroid here, and then withdrew and injected between the tendon, accessory tendon and the cyst. So you modify your technique and you form a protocol in your mind once you're doing it dynamically. Specific injection, shoulder, short head of the biceps, we started like this. Out of plane to the biceps tendon, in plane in injection, right? Subacromial bursa, we started doing the injections mediolaterally. Then DK said, do the anterolateral approach. So I started doing the anterolateral. You keep on learning, you know, your friends will correct you. The people who don't like will also correct you. So you have to regard both. So it is important. Believe me, critics are your best friends. AC joint, in plane corneal injection, right? So this is a rotatory interval injection doing a hydrodilatation. This was a simple steroid, not a hydrodilatation. So this the technique, mastery, PRP in a footprint tear, calcific tendinosis, diagnosis on ultrasound, injection. So multiple injections, suprascapular nerve blocks. We use it for practically everything in the shoulder now, right? Identify the artery nerve, inject. This was a supraspinatus tendinosis with a tear here. Patient had acute pain. So we injected a PRP, and then we saw the patient after about 2 months. You can see the difference here. So we practically don't see the area of tendinosis is almost gone. The footprint bone irregularity remains, but the tear, interstitial tear, has almost reduced to nil, and the tendinosis is gone. The biceps tendon technique we changed over the year, just using the so you learn, keep on moving the probe and the injection. You go behind the tendon when you're injecting in the posterior tendon sheath, especially in the superficial tissue, because the lady will not remember the pain of the common extensor tendon. She will remember the decoloration of the skin. So if you are behind the tendon, the decoloration will be less. Hydrodissection, hydrodilatation, doing combined techniques, suprascapular nerve block, subacromial bursa injection, and hydrodilatation or hydrodissection of the rotatory interval. Then we added doing the hydrodilatation in the intra-articular part, and also a little bit of injection in the extra-articular, extra-capsule portion of the CFL. You can actually break the CFL also, but I really don't believe. I think the CFL is there for a purpose. So these are all different injections. I just have 3 minutes. I'll just go through. Post hydrodilatation. So we'll go through these techniques. Elbow, the PIN, so many times these nerves irritate. So you do the PIN injection in plane, out of the plane to the plane between the two heads of the supinator. Again PIN, diagnose the PIN on the ultrasound. Make sure it is impinging there and do your injection. So these are where it is used, really useful. In GI, using the ultrasound guided injection in children, it is quite useful because synovitis can sometimes you will just inject in the synovium and not in the joint. Knee joint, effusion, superior lateral approach with slight medial tilt. Dry joint, medial approach, right? Pes-anserine tendon injections, we all know, above the tendon you inject. Baker's cyst is very tricky. If somebody else is injected 2-3 times, it will be so, you have to just almost as if you're stabbing somebody. You have to go and stab and aspirate. But nowadays they do a scopy. So they will, in UK it's a very trend thing to get a Baker's cyst aspirated every year, right? So in India we don't really do too much of it. Pes-anserine, then this is a popliteal tendon cyst. It was a slightly difficult injection, I thought, but when you have your mind, you make up your mind. So this was the artery, this was the cyst. When you just aspirate, it just disappears, right? So if you are specific, don't worry if you puncture the artery also. Don't play around on the needle inside, just come out. ITB, tenotomy, xylocaine injected and tenotomy done in the complete plane. So I'll just go through, I'll finish my moral level, you do it the standing, lower part. I couldn't download these, so DK will cover, this is the carpal tunnel and this thing. Shear wave elastography, our favorite, we started using it. So my point is that do use shear wave elastography except cirrhosis and fatty liver also, there are uses. And the trigger points do form, and we have a supraspinatus, we have a shoulder tendinosis, we have triggers. Just inject 5% dextrose at multiple sites, it works. Inject xylocaine, it works. Inject steroid, you have to just dissipate or do a needling without anything. Multiple trigger points, I think most of us have them. If you don't have it, that means you have not done the ultrasound. So these points will tell us that we need the correct posture. Footprint and common extensor tendinosis, trigger points in the muscle. Inject this over and also fenestrate these. So then we do multiple injections, a cadet going to the arm. So this is ultrasound guided injections of the trigger, elastography guided injection. So you can see real time how the elastogram would change, and you actually hit the target where there is no lesion, there is no Dopplers, there is no hypoechogenicity. This is something which I have started using. We have used it for elite players. It really works. So I'll just finish 21 seconds. And this is again a very common technique. And I have my friend who did this with me because I had a lot of shoulder pain. So, you know, my wife took me to Dr. Dharminder and he did the needful. You know, he was telling my wife, showing, see, look how the needle goes, and I was under anesthesia. So what we do is, 2 slides. So we identify the nerve, identify the trigger points, and we would identify the artery, the dorsal scapular artery, the nerve is along there, the levator scapulae. So this is me, this is the injection through the plane where you have the spinal accessory nerve between the trapezius and the rhomboids. Inject here, change the plane, same injection come down along the dorsal scapular nerve, and then inject the trigger points. The patient is practically pain-free. They can start the rehab there and then. Last slide. Be a clinician first. I have started examining my patients. Make your own opinion. If your opinion differs, just write your clinical opinion. Don't need to just, a soft word to the clinician is always good. They will not fight with you. You know, you have to just learn to be soft. Let them, and they will agree with you after a few times, you know. You sometimes get married to a clinician. They will start liking you, they send to you. So you treat it like a marriage, take the criticism and do your own will. So take history, see all records, do your mechanical exam, treat and assess the kinetic chain. If I have a tennis elbow, I have a shoulder which is impinging, I have a hip disbalance. Just see how the player is. Get a kinetic chain analysis or do it yourself. Go back to the referring doctor, do your OPDs. I think Dr. Nishit is here. I think we should start having some clinical sessions where you should, the MSK people have to start clinical examination and teach clinical examination to us. If they can do the turf erosion, I think we can do the turf expansion. Do your clinical examination. I think I request you in the next session, have a clinical examination. No, have it in with this. So, you know, then new protocols and procedures have been devised over years. You keep on revising yourself. And it has to be patient-centric and tailor-made procedures. Combinations work. We form new combinations. We stop them. And over the years, you know, newer techniques come. We are trying out elastography. Hopefully it will work. Ethics and ethical-based practice. Believe me, in private practice, it is very difficult to say no. And don't get carried away. If you do the wrong injectable, it will come back to you. So MSK interventions are ever evolving. Be aware of doping. Ask the player if they are in competition or out of competition. Know what things are in the doping list, the NADA list and the WADA list. What is correct and ethical today will become obsolete and unethical because the WADA list every year changes. Growth factor injections are now in the prohibited list. So when I do a GFC, you can just write as a fenestration. That's a very tricky thing. Have your own opinion. Learn from your mistakes, but don't repeat them. Safety first. So thank you, Dr. DK. नहीं नहीं.
Interesting, very interesting talk. Anybody, any comments or any questions? So now I would like to invite Dr. Nandita Sinha. She needs no introduction. She is the professor in the prestigious Department of Radiodiagnosis at PGIMER Chandigarh. Over to you, Dr. Nandita.
Again, thank you to all the organizers and the Dr. Ankur and Dr. Drushi who are available at 1 o'clock, 2 o'clock at night and message back within 5 minutes when you have a problem. So I don't know when they slept for the last 1 or 2 months, including Dr. DK and Dr. Nishit also, Dr. Jalapati Rao sir. So the broad overview was techniques and pitfalls. We'll discuss the pitfalls first, which are not only the pitfalls but the advantages, the guiding principles and the precautions that we all should do, the indications and contraindications, and then we'll go on to the modalities and the hardware and a few words about the refined approach. So why do you want to do an image guided biopsy and take on more load on yourself? Because it is easy to say clinician को दे दो, उसका time जाएगा ना, हमारा free हो जाएगा, हम लोग ज़्यादा कुछ करने के लिए. We will do the hi-fi things like RFA and cryos. So, but the important thing is image guided ablation, image guided biopsies are have a very good yield. They are almost as accurate as open biopsies at a lesser cost because it has minimal tissue damage, including soft tissue, including bone damage to the patient. Not only that, the rate of seeding, which is the primary concern of the tumor seeding the tract of the biopsy tract and that not being excised, is much less if you do it in a proper manner. So the patient also is freer to go or freer to mobilize earlier than if you do an open biopsy. And as a result, you don't need general anesthesia anyway for the soft tissues. You do it as an OPD procedure. You can do it under a local or a minimal conscious sedation if it is a pediatric patient or a difficult to access area. And as a result of this, no extensive hospitalization. It is done as an outpatient procedure and fewer complication and costs. So all the more reason to do it. But what are the pitfalls? The only lesson you should take from this talk, if at all, is that tumor seeding is still a concern, is a primary cause of concern even with open biopsies, even with your image guided biopsies, because we don't use the narrow gauge biopsies of the body people. We, even for soft tissue biopsies, we use a 14 gauge needle. 14 gauge 10 centimeter needle is the standard of practice. Okay, so there again the chance of seeding is much more. And if the biopsy scar is not removed, then there is an overall 5-fold increase in this tumor seeding when you're using these bigger gauge needles when the patient goes for a tumor resection. All this does not apply if the patient has a multiple unresectable tumor. You can do biopsy from wherever you want to. But if you have a single operable, possibly operable lesion, then bear in mind that you yourself will be the cause of mortality and morbidity of the patient to an extent that the 5-year survival rate, you will be affecting it too much if you don't do it in a knowledgeable manner. So it's not like body imaging and body interventions. So it has to be done by an MSK radiologist. That is one point that you should take in mind. And it has to be done in a center where there is a tumor surgeon or there is a sarcoma or a multidisciplinary team. If you are working in a standalone center, you have even been trained, even don't do it over there because you don't know the surgeon preference, right? If the surgeon is not on calling terms with you and you are not on calling terms with the surgeon, don't do it. So the guiding principle, again, I'm emphasizing is that the track has to be removed. If you are doing the biopsy, call the surgeon, plan it out before or at the time of procedure. The surgeon has not marked out. This is my own attempt to mark out the area. But also, it's important to create a scar. So it's very easy just to go in with the needle. And we oftentimes, in our hurry, we forget that we need to create a scar. Because the surgeon, by the time he operates, maybe 15 days, 1 month down the line, the scar would have gone. So this is what happens when you do it without creating a track which is appreciable by the surgeon. The surgeon brings you up later, ki aapne kahan se biopsy kiya, you don't know. So write it down when you're doing the biopsy notes that this is where you have done the operation from, and create an artificial scar where by either stabbing or giving even a dirty stab will create a scar, a dirty scar. That is what you want. So the important take-home message is stay within the Lakshman Rekha of the incision site that is planned with the surgeon. Okay. So precautions. Take a detailed history. Examine yourself. Again, Dr. Raghav just said you need to examine the patient, see the patient yourself. Don't give a date on the basis of just seeing the image. Please beware, you need to see how the patient is, how sick or how obese the patient is, whether the patient can lie down in a particular position that you want to, and look at the prior imaging. For instance, this patient came with this last X-ray, and you have to know whether it requires sampling at all. If you've seen the last X-ray, I don't know if it's projecting well, it was just an amorphous sclerotic lesion. When we ask for the priors, and sometimes patient does not bring it along with you, just ask for the priors. This is what the first 2 X-rays was, what the lesion looked like. So this is actually an NOF which had non-ossifying fibroma, which has actually ossified and looks a bit more abnormal or not like a classic ossified lesion. So once you've decided that you need to biopsy, identify the nearby neurovascular structures and the compartments, again, which a musculoskeletal radiologist only can do. A normal general radiologist will not be able to do. Because you are afraid of contaminating the surgical field, and once you contaminate it, a patient who would have a limb salvage surgery would be doomed to an amputation. Okay, so always look at prior imaging, examine the patient yourself. Be aware that biopsy planning and guidelines are different. Again, I'm emphasizing this point. Consult before putting your needle in. So this is an image from the classic article by P.T. Liu et al. In Radiographics. Anybody who is doing should at least go through this article because this is like the Bible or Gita for us. And see, this is the normal point of view. Like you would see a lesion like this, you would like to go in from the midline. There's no, in abdomen there's a midline incision. In musculoskeletal there's no midline incision generally. Okay. So easiest path is not always the right path. So what are the indications? Of course, primary lesions, secondary bone lesions, infections, arthritis, discitis, anything is a indication. Beware of pseudotumors, beware of no-touch lesions. Okay, because you can do a worsening. If you biopsy and heterotopic ossification, you are worsening it. If you are going into a hemophilic pseudotumor, again you will have huge amount of bleeding. So be aware of these pseudo lesions. Again, contraindication, bleeding diathesis, be aware that patient may need to be done under cover. If you have soft tissue infections in the tract of your biopsy planning, you need to defer the procedure before that infection subsides. And if it is a very, very inaccessible site, you don't have anesthesia cover, you expect some, these are relative contraindications. There's nothing really inaccessible, but C1, C2 lesions are difficult. Transoral approach under anesthesia cover needs to be done. So these are relative. You have all the modalities at your disposal depending upon which lesion you're going to biopsy. You can do it under CT guidance for bone lesions. But again, wherever it is, even if there's a permeative cortical destruction, and you're tempted to go in through that because you don't need to go through normal cortex, remember that it has to be along the incision plane. USG is very important, and even on CT you should know the neurovascular anatomy, and even on an NCCT. So you have to know anatomy very well. For specific situations like humeral head, especially femoral head, you need fluoroscopy, which makes your life easier. Otherwise, CT does it or ultrasound does it. And even for vertebral body lesions, you can do it both CT and with fluoroscopy. But look before you leave. So this is a soft tissue lesion. It is indenting the vessel. Looks very, garden variety biopsy kar denge easily. The vessels are actually draping over this. Even if you puncture it, you'll be okay, but you need to know that you need to do some gel form while you're taking the needle out, and you can prepare gel form beforehand. So this is pre-planning. It does not mean that the lesion is not biopsiable. Okay. So here again, look at this. What is this? This is a lesion. This is a normal structure, which is the soft tissue mass of this permeative lighted destruction is encompassing, and this was actually a case of lymphoma. But I'm sure a general radiologist would not identify as the normal ulnar nerve. So if you're penetrating through this and you think this is normal, and the patient would end up with a claw hand, ulnar claw hand. So as Dr. Raghav said, we sometimes use shear wave in soft tissue lesions before biopsy to understand which is the hardest part and which is not the necrosed and soft part. So you can use it, but we rarely use it except for in research settings. This came out to be a malignant peripheral nerve sheath tumor. We had done the shear wave beforehand. So what are the hardware requirements? Even for biopsy, first of all, the teaching is culture and biopsy go together. Even if you think it's a soft tissue tumor, we generally send for culture, and if there's a culture, you send for biopsy. And for hard lesions also, like a bone lesion, we generally use a long soft tissue biopsy needle to get samples sometimes when bone tumor access the coaxial needle fails. So keep all these hardware in mind. Start with a scalpel, start with LA, give subcutaneous or intradermal injections to make it pain-free. Then use coaxial needles. Please use coaxial needles because you can get in, change the direction through a single site. If you have a single biopsy needle, you need to do it multiple times. It makes life much more cumbersome and it increases the time. For bone tumors, keep a hammer ready at least before you start, because even if it's an intact cortex, sometimes you're not able to penetrate by your hard clockwise to and fro movement to get into the lesion. You can use just a hammer to penetrate it. Nowadays we are using this battery operated driver, which again really decreases the time of intervention drastically and rapidly, and yeah, but this actually increases the cost to the patient. That is the only drawback of this. So in soft tissue masses, what are the challenges? The clinician often sends you a lipomatous lesion. Where do you biopsy from? So take the help of imaging. If it's a large lesion, see which area has at least a soft tissue mass, or which has a restriction diffusion, or which is enhancing, and you need to target it specifically. Also for myxoid lesions or cystic lesions, look for the soft tissue component. If there is none, at least target the wall of the lesion which is looking a bit thick. Hemorrhagic lesions, again you have to look for a non-hemorrhagic area which has a soft tissue like area. Hard calcified lesions, you may need to penetrate through with a bone tumor biopsy needle, and if the lesion is slipping away, you need a colleague to hold it in place. These are just the practical guidelines which you need to go in. Again, I told you that we need these coaxial needles, which makes our life easier. And even for bone biopsy, do keep the soft tissue biopsy needle, the 16 gauge, 16 centimeter needle at hand, so that if that yield is not there, and believe me, in bone tumors, sometimes you don't get anything in your coaxial needle when you're doing the biopsy, especially for hard sclerotic small lesions, that the difficult lesions that the orthopedic surgeon cannot biopsy and sends to you. You will need to modify your technique, either do a strong negative aspiration suction or get a soft tissue biopsy tumor needle through your coaxial needle, through your stilette, introduce a needle and get a soft tissue, your core. Okay. So again, a technique I'm not going through. This is what we use. This is the longer gauge needle. Sorry, I didn't mean to give advertisement for any company. But positioning is also important. Again, these are just basics. Putting the needle is the easiest part. But thinking it out, positioning, if you have a wrong position, especially in the CT guided procedures, where the patient is under minimal conscious sedation or GA, the positioning is the key to a smooth and short procedure. So here, if the lesion is in the femoral medial cortex, you need to externally rotate so that your biopsy needle is vertical. That is the easiest way to manipulate the device, and not only positioning the patient, but we often neglect the lead shielding and the radiation protection, and it makes life, no problem for us, but we are doing it for a long time. An incidence of cataract, even brain tumors, all these things, please remember that, please save yourselves also by positioning these devices between you and the patient. Okay, so for prone patients, again, vertebral biopsy, we generally do prone, again, analyze the patients, assess the patient, cardiovascular, pulmonary complications, very, very obese patients, may not be able to lie down, assess it, and then decide whether the patient is biopsiable or not. Again, approach is transpedicular, it can be parapedicular or extrapedicular, but that is not important, but analyzing is very important. Again, you need to hammer it through. If you have a thin cortex, you use a hammer to put your needle in. If it is a very dense cortex, we previously used a battery operated small form factor drill, and you can use even cannulated drills through this, but again, this requires much more time. So this is the drilling for biopsy. Approach to flat bones, again, you need oblique approach for the ribs and pelvic girdle, and generally for operable lesions, please don't go through the soft tissue or the gluteal muscles, go through bone. Even if the normal bone is there, you go through the normal bone to reach the osseous lesion, so that compartment is not breached. In bone tumor, the bone cortex is the compartment. If you breach through the soft tissue, that means that you already made it extra compartmental. So this is the article that I was mentioning to refine your approach. Do not venture into at least bone biopsies before reading this article. And for extraosseous lesions, may I have just a few more slides? I think I'll just
finish it.
Just remember that you might get a soft tissue core from this, but sometimes you need to get in core from the bone as well, and it's a very good practice not to just go through the extraosseous area, but through the bone also to get these. Okay, subarticular lesions. This is a rookie mistake. This was a clear cell chondrosarcoma, and this has gone intra-articularly. Okay, so I'm showing my own mistake. This is what we started out with when I was not doing musculoskeletal, and this is not how you should approach. This is how you should approach, and this is where fluoroscopy is very, very helpful. So this is a small lesion, and you cannot approach it with CT because you have to go obliquely, and fluoroscopy comes to your, it's your savior. Beware that all lesions may not be the pain generator. Here, this is a small enchondroma, and the pain generator over here is the supraspinatus interstitial tear and the tendinopathy, and you can give an injection and see if the pain has gone instead of biopsying this, because this would definitely not cause pain. Okay, so last case, this is an 18-year-old boy with severe back pain. See all imaging modalities. We already had decided that we will biopsy this lesion. It's very easy to do, but somehow we just stopped and said, let's get an MRI done and see what the MRI has shown us. There is a large lesion over here, and it's very, very vascular, and even this intrasacral lesion is very, very vascular. So ultimately, because of this vascularity, it was decided the patient will go angioembolization. Look at how vascular this lesion is. So this was embolized, and then we did the biopsy, and this was an angiosarcoma. So patient would have had a huge amount of bleeding if we had not done this before. So always have a checklist. This is the checklist we have. My fellow is here. All of my residents are here. So they all know about the checklist, and we modify this checklist. I'm not very good at Hindi, but make it in the patient's language as well, and sit down with the patient and explain the procedure. So we have a checklist from what the patient is going to do before the biopsy is done, the material list, and what is going to happen on the day of the procedure. So all this is explained in details. It takes at least 15 to 20 minutes to explain to the patient, because it's not easy to have a needle stuck inside you, and it's not a thin needle. What Dr. Raghav said, you have to see the needle when you get a biopsy. You cannot do it blind. I don't believe in that. So take home messages, review all imaging modalities, and image guidance is better. But what is more important is correct selection and screening with prior planning. And please take time out to talk to the patient and discuss the procedure. And thank you all, and welcome to Calcutta next time. And also, anybody willing from the back benches, we also have a DM program, 3 years. I welcome you to avail of that procedure. And my ex-fellow is here. He will attest to the fact that we do a lot of interventions, all the interventions shown in this session, as well as the diagnostics. So it's a well-balanced program. Thank you.
Thank you, Nandita madam. You deliver excellent lecture. Your tips and tricks will be useful to all of us. Now, next speaker is Dr. Rajesh Bhatt. He is consultant musculoskeletal radiologist at University Hospital, Lancashire, UK. And area of interest is MSK imaging, image-guided MSK intervention, and sports medicine imaging. Dr. Rajesh Bhatt, sir.
Good morning. First of all, I would like to thank Asian Musculoskeletal Society for inviting me. It's always a pleasure to come back home, particularly when the host city is from your in-laws city. So I'm on my best behavior this morning. We had an excellent workshop day before yesterday about the musculoskeletal intervention under the ultrasound guidance. And this morning we're having a good session on the intervention. So my aim is to talk to you about how do I avoid the complications and pitfalls when I'm doing the ultrasound guided interventions in musculoskeletal problems. So the good news is that the complication rates are extremely low, but the bad news is that the pitfalls are very common. So my aim this morning is to minimize the complication. You can't avoid it completely, but you can avoid the pitfalls. So let's go through the complications. So as you know, all complications are infection, damage to the neurovascular structures. It may be a allergic reaction or toxicity to the drugs you're injecting, vasovagal reactions, and needle injuries. The pitfalls are usually due to the technical factors or poor procedure protocols. As you can see in the bold letters over there, wrong side, wrong structure. This is a never event. It should never ever happen. If it happens in my hospital, it's like a headline news everywhere, okay? So it should never ever happen. Poor preparation prior to the procedure, which leads to the pitfalls and complications. Failure to assess the target anatomy with the ultrasound. You need to select the correct probe so you can see the target clearly. You can assess the neurovascular bundle clearly so you can choose the right path. Air bubbles in the needles or the syringe, because my residents sometimes they hurry up and set up the trolley. They haven't flushed the needle. They get to the target, inject the injected, and all the bubbles there. And it's all echogenic. It's all cloudy. They can't see the target. So make sure you're obsessive about removing the air bubbles in your needles and syringes. If you approach the target at a very steep angle, it makes it difficult. We had a mastery session on how to track the needle and everything. So the horizontal approach is best, so you can see the shaft of the needle, and you can also track the tip of the needle as well to when you approach the target. When you approach the target, you give a local anesthetic injection, so you can see the spread of the local anesthetic. So that means it feels it shows you how it's flowing into the target. And if you don't do that, it may not anesthetize the area, and when you actually try to inject the injectate, it may be painful for the patient. So let's go through each and every complications and the pitfalls we just discussed. So the infection, how do you minimize it? How do you reduce it? So you assess the patient whether there is any risk factors for the increased risk of infection. The patient is immunocompromised due to diabetes, renal failure, patient is on chemotherapy or taking long-term steroids. Use the strict aseptic protocol when you're doing the procedure. Avoid multiple passes. So if you plan it correctly, single pass, get to the target, inject, come out. That will have a minimal complications. Avoid trying to get to the approach through the cellulitis or an infected skin. Damage to the neurovascular structures. This is important. That's why it has been emphasized in the previous talks. Always review the previous imaging so you know when you're trying to reach to the target what are the neurovascular structures around it. It may be a cross-sectional imaging in the form of CT or MRI. You do the ultrasound and make sure how you're going to approach the area. Have a correct probe, because if you're using, say, for ultrasound of the finger, doing injection of the interphalangeal joint, you don't want to use a big linear probe. You need to use a hockey stick probe so you can hold it correctly. But if you're doing the injection of the hip joint, a deep structure, you need an abdominal probe, a curvilinear probe, maybe a 5 megahertz or something, so you can actually see the target clearly. So make sure that you select the right probe. Make sure you use the color Doppler prior to deciding, so you know what the vascularity of the structure is, tenosynovitis, extreme inflammation, neovascularity, or are there any neurovascular structures sitting around the area. And avoid traversing through the neurovascular structure to avoid any complications due to bleeding or any nerve damage. You can get the complications due to the injection, so patient can have allergic reaction to the local anesthetic or injected in the form of a levobupivacaine or a steroid, or you're using hyaluronic acid, or sometimes some other agents as well being used. So just make sure that if they get any reaction, you are prepared to deal with that. Most common complications I see after the injection of a local anesthetic into the joint, they get a limping sensation. As soon as they stood up, they feel like that. Okay, so tell the patient, look, you need to be careful. It's going to be weak or numb. We avoid, ask them not to drive if we're doing the lower limb injections. Local anesthetic toxicity can occur. It can cause serious cardiac arrhythmia or something like that. So you need to be prepared for that. That's why we all have annual mandatory training. We all have to be prepared for any CRP process, and we all have a defibrillator in every room we do the procedures. Post steroid injection flare is extremely common, so you always warn the patient it will get worse before it starts to get better. So what happens when you give the local anesthetic? Patient can't feel, oh, feels much better now. After a few hours when they go home, they'll start cursing you because the steroid flare, we say, look, it was fine, what happened now? Doctor's done something wrong. They'll pick up the phone and ring, oh, my pain is now worse. So always make them aware beforehand that it's going to get worse before it starts to get better. Steroid can also make you feel hot, or you can have menstrual changes as well. So all these things needs to be made aware of. And then also we normally give them like a sort of a leaflet. So while you're consenting the patient, we tell about these things. So in our hospital, we have like a written consent for every interventional procedures we perform. We also give the leaflet because it's too much to take in at the time of procedure, because the patient is nervous, very anxious, they cannot take everything in. So we give them a leaflet beforehand when the appointment is made, so they have read about it, and also we emphasize, look, read the leaflet in case if you haven't remembered that. Vasovagal reaction is the most common complication. It can be very frightening for the patient, not only for the patient, also for the operator and for your assistant as well. The vasovagal can be in the form of patient may feel cold, clammy, sweaty, they go really pale, they can have like a little epileptic fit, they can be incontinent. So when these sort of things happen, suddenly my residents will say, oh my God, what have I done to the patient? So you need to be prepared for that. You have to be extremely calm, reassure the patient. All my patients having interventional procedures, they all are lying down. Even if I'm doing injection of a finger, they're lying down. They're never sitting up. If they're sitting up, then it will be very difficult to catch the patient. If they're lying down, nothing to worry. Head down, elevate the leg, put the pulse oximeter on, just check the blood pressure and everything. Most patients will recover within 5 minutes, and just need to reassure the patient. Cold sponging, make sure that it's not too hot or stuffy in your ultrasound room. So these are the things you have to do, but yes, be prepared for the vasovagal. It can happen anytime, and mostly it's during the procedure, immediately after the procedure. What happens is the young patient, they are normally say, oh, I'm fine, nothing to worry. Just before I took the flight, come to Ahmedabad, and 2 days ago, and then there's a young guy and had an injection just around the Alias Bursa. He said, I'm feeling fine. He was accompanied by his father who was driving him home. So the father and the son, they go into the car park. The father is opening the door, and then he sees the son is not seen. He's on the floor because he had a vasovagal. I asked him to say, look, wait in the department for at least 5-10 minutes. But typical young 20-year-old, he doesn't want to wait. I'm feeling fine. Nothing has happened. I'm absolutely fine. I need to go now. Because he had a fall in the car park, head injury, so he had another 2 hours of stay in the department. And if you had an injury on your hospital premises, and head injury particularly, we have to send him to the accident and emergency department, make sure that he hasn't got any intracranial injury. So these things can happen. So always make sure that after the procedure, patient is staying in the department so you can observe and they don't get any complications after the vasovagal and injury to any other areas. Needle injuries can occur to the patient, it can occur to you, or it can happen to your patients as well, particularly when the needle has been used in a patient. And if you get a needle stick injury or to your assistant, there's lots of things. You have to take the blood sample of the patient, blood sample from me, from my assistant, and then you have lots of forms to fill in and everything. So make sure that you always keep your needles covered with the cap before the procedure. Once you finish the procedure, there's a tray, or you can have like a gel form where you can put all the needles in there, so you know where it is. It's all meticulously planned, so you need to make sure that these are the sort of things we don't want to encounter while you're doing the MSK procedures. Pitfalls, this is where I'm most interested to give you an emphasis, because these things are avoidable. If you plan it well, then your list runs smoothly, and you can have a minimum amount of stress related to your ultrasound guided procedures when you do the MSK procedures. So first of all, make sure that you're doing the right side or correct side procedure. If you're doing the correct area, need to know which area you're injecting it. Say for example hip, so it says ultrasound guided injection of the hip. It could be the hip joint injection, it could be alias psoas tendon sheath, it could be trochanteric bursa, it could be the hamstring origin of the ischial tuberosity. You don't know, so you need to read the request form correctly, look at the previous imaging, that makes sure it all matches. You take a verbal or written consent depending on your hospital policy, and then also check with the patient, mark the site, so then patient know which side you're going to do the injection. And then also you need to know what is the target, tendon, bursa, joint, whatever. And then once you decided that, okay, we are doing this area, you scan and you confirm. Does it match with the previous imaging or not? Then you know what you're going to do, okay? So this is very, very important. Wrong side, wrong structure, okay? You don't need to do that, because he said if this happens in our institute, it will be a never event. It will be on the hospital newsletter that, okay, no names, but they said these are the things you should be avoiding. Poor preparation prior to the procedure. This is the things where I'm obsessed about it. When the resident come to me, I say, look, I'm not going to teach you any rocket science, okay? Nothing groundbreaking over here. You guys know how to do an ultrasound guided injection of the hip joint or a shoulder subarachnoid bursa injection. What I'm going to teach you is how to make your life easier. This is my experience of last 10-15 years, and this is what I've been doing. I made mistakes, and I'm going to teach you about my mistakes. So if you are a clever or smart, you learn from others' mistake and don't repeat it. Okay, that's the message. And you will, if you learn a good techniques now, if you develop a good habits, it will stay with you forever, and you will remember me forever. So whenever you do the injection of the hip joint, this is how Dr. Butt does. This is how I'm going to do it now. So you will remember. You won't remember this is how he did it. Okay, so it's best to make a good habit and then make sure that you got the correct protocol in place. So what I do normally, so when I get a request, we get a half an hour slot for each intervention procedures. So when the patient doesn't come in the room, I get the request form, it's all electronic. Then I say, okay, this is the patient. I check with my assistant, so she has selected the correct patient on the ultrasound list on the machine. Then I say, okay, let me look at the previous imaging. So you go into the PECs, and then you got all previous imaging available because all digital. And then you decide which way you're going to do it. You prepare the trolley, everything is ready. Once you are happy and satisfied that everything is there, patient name is there, this is what you're going to do. You confirmed on the previous imaging. Then and then you call the patient. So this is what I do. On the left-hand side, you got the trolley, which is ready for me. And I cover the trolley before the patient comes in, because patients are extremely nervous and anxious. They don't want to see the needles or anything. So if you don't show anything there, when the patient comes in the room, you're talking to the patient, you got a good rapport. Then you will have a less complications. Just patient comes in the room, you do the scan, inject out. The minimum amount of time in the ultrasound room, minimum interaction there in the intervention room, and then you have less complications. So if you fail to assess the normal anatomy, you may get into trouble. So make sure that you choose the color Doppler to make sure that you're not causing any damage to the neurovascular structures. I already talked about the air bubbles. So you need to be obsessed. Every time you put a needle, you flush it with the local anesthetic to make sure there's no air in the system, or there's no air in the syringes. Avoid steep approach, because if you're using the steep approach, you will be finding it difficult as it goes deeper into the structure, because you lose a needle tip. As we already discussed about the in-plane and out-plane approach, so if you're using a small joints like finger or foot, you use out-of-plane approach. Fail to track the needle, again you may lose the target and you may not be able to see it. Always give a local anesthetic to the target, then you know that it's going smoothly, and you also numb the area, so when you inject the actual injection, it doesn't cause much pain. So in summary, MSK intervention procedures under ultrasound is very safe and accurate. Make sure you have a local anesthetic on board, and then it's all prepared very well. Confirm the site and target before you start to inject, and make sure your tip is continuously visualized, and give a local anesthetic to the area so it numbs the area, and so when you inject, it doesn't cause any harm. And be prepared for the vasovagal symptoms, and don't panic, and just reassure the patient and to yourself as well. Thank you very much for your time on Sunday morning. Wish you all a happy MSK intervention. Thank you.
Thank you very much for that excellent talk and the harping on the points which we are all harping on, and the complication of the vasovagal, which happens all the time. The time. So it's very, very important, even for the OPD procedure, when you're doing an injection, to ask the patient to get a, we are a public hospital. It's the patient's responsibility to bring a trolley. So we tell them, get it from the gate and then come in. So they are very anxious at that point of time that what is going to happen to me? But we have to assure them that they need it just to rest for some time.
So in my experience, the vasovagal is more common in the young patients. So a little old lady come in, 18-year-old, you can do whatever, they will work out nicely. It's the young people with a strong pain stimulus, the rugby players, classic. They feel macho, you give the injection, they say, fine. The next minute, he's on the floor. And you know, like they become so embarrassed as well. Oh, nothing happened to me. They become incontinent as well, and they're so embarrassed. This is like a high-profile rugby player and got a vasovagal and the incontinent in front of the doctor and the assistants. So yeah, okay. Thank you very much.
Thank you very much. It is my privilege to invite Dr. D.K. Singh, who does not need an introduction, is one of the biggest stars in MSS, to give his talk. Thank you, Doctor.
Right. Good morning. Thank you, ma'am, for your kind introduction. And this topic is an interesting one because it has changed many scenarios. So ultrasound guided interventions for nerve and tendon entrapment in the fingers and hand. We work in a specialized hand and finger unit in a sports center. So I will share our personal experience. I have no conflicts of interest and nothing to disclose. The objectives are very clear. The pathomechanism of nerve and tendon entrapment, ultrasound guided interventions, and its assessment, and what is the advantage over surgery. Now now the hand surgeons are preferring this one as compared to doing the surgery, despite there the financial loss to them. But in our hospital, Modi ji gives the salary, so obviously, so we don't have any financial loss. So nerve entrapment, the classical example is carpal tunnel syndrome. The pathomechanism, I am not going to the detail, but here is the nerve and various structures that you can see. And what will happen if there is the external compression? When the nerve is compressed, the first compression is the vasa nervorum. It leads to vasogenic edema, and that leads to nerve anoxia. And when there is nerve anoxia, there is a perineural hypoglycemia and persistent opening of the capsicum receptors. You know what is this capsicum receptor? Okay, this capsicum receptor, this capsicum has come from these capsicum receptors. So have you noticed when you are eating some capsicum and what your mother or grandmother has used to give? The sugar. Because you know, the sugar is the antagonist of this capsicum receptor, and this capsicum receptor, you know, it causes pain, it does not cause the taste. So what we get from the capsicum is not a taste, it's a pain we are getting. And sometimes the pain is very good, that's why I enjoy the capsicum. And sodium potassium ATPase pump, and that leads to the neuropathic pain, sensory dysfunction and motor dysfunction. And the symptoms occurs in this way: first neuropathic pain, then sensory, then motor. So how to know the nerve entrapment? Clinical examination, yes, sensory symptoms and motor symptoms, numbness, tingling and paresthesia, weakness and atrophy. Nerve conduction study, yes, sensory nerve conduction velocity and distal motor latency. And imaging, yes, it's qualitative as well as the quantitative also. Like here, qualitative, because we are seeing here the thickened flexor retinaculum and compressing the median nerve. Okay, here obviously the diagnosis like the thrombosed persistent median artery, and quantitative in the terms we are calculating the cross-sectional area of the nerve, and when it is coming to 18 millimeter square in this case, that means it's a qualitative as well as the quantitative. So role of ultrasound or role of imaging is not only for the diagnosis, qualitative and quantitative assessment also. So what is the remedy? So what you know what a clinician does? Okay, when the artery gets blocked, what does they do? Only one thing. First thing, they give you aspirin and clopidogrel so that the content becomes thinner. Or when the stenosis is much more, they put a stent. Okay, the similar thing is applied on the nerve also. Okay, either target the nerve or target on the causative agent. So this is the remedy. So nerve hydrodissection is the one thing. And what is the indication? The indication is clinical, nerve conduction study and radiological, both three signs at a similar platform, signs of nerve entrapment not responding to conservative management, predominantly if the patient has the sensory symptoms, no motor symptoms, and on the CSA obviously the sensory symptoms, then the nerve hydrodissection is preferred in the held conservative management. And what is the thing? The separation of the epineurium from the fascia or retinaculum is you know, it acts very fast, it acts very nicely, like here. And what is the step? Reach at the margin of the nerve first, then Then in the short axis, the needle below the deeper surface of the nerve with the bevel up. What I mean to say means the bevel is up. We first see the under surface of the nerve. Why bevel up? I will tell you. This is the law of physics. And second, why on the deeper surface of the nerve? Because when you are injecting here, the nerve will be pushed up, and this will act as a tamponade. So the upper part of the nerve is easy to go. And second thing, by mistake, if you suppose you have started from the upper one, superficial part, and by mistake you have injected the air, then you are not able to undergo the deeper part. So what is the physics behind this one? Okay, the physics behind this one is have you read the 12th class H.C. Burma, and if you read the chapter of this projectile motion, you can understand the bevel up is that means the direction of the fluid will be like this. Okay, when the bevel is down, okay, so when you're going in the second sitting, you go above. Where is above? Yes, above. Okay, and at this point the bevels will be down. It follows the law of physics. Everything what is happening in the planet, it follows the law of physics. So obviously it will follow the law of physics. Again, it minimizes the injury to the nerve if inadvertently you have pierced the epineurium. Why? Because the needle tip is always away, and this follows this rule. Fine. So if you are injecting the bevel down, the injectant will go like this one, and it will also it will not injure the nerve because needle tip is away from the nerve. So, and one thing very important that I have written here, there are two types of dissection. One is called sharp dissection, cutting the needle. One is called blunt dissection. And you know what is the best blunt dissection? Is the water. Even the diamond is cut by the water. So so blunt dissection is done by the water, and this does not the carpenter hydro dissection does not stops here. This is one of the most important steps. Must go through the needle along the superficial surface of the nerve in the long axis. Why? Because the maximum compression of the carpal tunnel does not occur at the proximal or inlet, it occurs at the outlet. Why? We see the effect of the nerve distension in the proximal or proximal part of inlet. The maximum compression occurs at the outlet. So if you have injected the nerve at the inlet only, the patient will recur. But if you have done the hydro dissection in the long axis, it will involve the inlet as well as outlet, and that will lead to the things. And what is the agent to be used? We don't read some Radiopedia or some red source or the, but you know, if you go to the Harrison's textbook of internal medicine 20th edition, it's written 5% dextrose is considered the choice of agent as compared to the steroid and normal saline. And you know, this was the PG question. What is the investment choice? So the medicine person knows that 5% dextrose should be compared to the steroid. And what is the rationale? The rationale is that this 5% dextrose is isomosmolar to normal saline. So it's not irritant, no neurotoxicity, because whatever steroid you use, it comes with the preservative methyl paraben. And methyl paraben is neurotoxic. No atrophy of the fat, no atrophy of the muscle, no depigmentation, no pro-inflammatory also. So where does the 5% dextrose acts? 5% dextrose we use the 10 ml. So it has a mechanical effect. It releases a nerve compression. It has a biochemical effect like the sugar. It's a sugar. So it acts on the capsaicin receptors. It reduces hyperineural hypoglycemia, and it also acts in sodium potassium ATPase. So, and if you see the if you see the literature, as compared to the steroid, we may act for the 6 months. The dextrose acts for the longer duration, and it's combined with the conservative therapy. Yes, the patient gets the permanent treatment in case of mild to moderate CTS. Release procedures, releasing the fascia or retinaculum, or like you can putting the stent in the artery, in the blocked artery. This is synonymous to the releasing the pressure. Once it is not released and severe, patient has the severe carpal tunnel syndrome, means the patient is getting the signs and symptoms of the motor atrophy or thenar atrophy. In that cases, the release is done. The partial release is the needle release. What is called partial release? Means we go through the needle here between the superficial palmar arch and here the transverse carpal or flexor retinaculum. We scrap the undersurface. We make it thin and this causes the partial release of the flexor retinaculum, like here in the video you can see. Okay, here, fine. What I'm going down below the flexor retinaculum, coming out, and the needle is curved. So when you curve the needle, you convert this needle into a knife, okay, and you scrap the surface, until it becomes thin, and always cross check in the cross section also. So in the cross section, if you see, you can see here the flexor retinaculum is half cut, and it relieves the symptoms. It relieves the symptoms in severe CTS in 70 to 80% of cases. And combine this one combine this one with 5% hydrodistension. Many patients, almost 70 to 80% patients got relieved. We have published the 3 papers in British Journal of Radiology. This one, and this has changed the the thinking of our hand surgeon, the thinking of our neurologist. Complete release or thread release is reserved for not responding to anyone. Some patients symptoms are so stubborn, whatever you do, it does not give. In that cases, go for the thread release. Used in a severe Carter syndrome, not responding. So in that case, we cut the needle, we go below the flexor retinaculum, we pass a tiger wire or fire wire in India we call, or the surgeons use this tiger wire for ligament suturing. Okay, so ligament. So we pass through this one from back to head side. We release this one. Then the second pass, we curve this needle above the flexor retinaculum. From back and forth, we pass the suture. We book a loop around the flexor retinaculum and we cut it. Okay, so these are publications in the TCTR in British Journal of Radiology. So what we do, yes, first we have passed the needle beneath the flexor retinaculum. We have passed this tiger wire through the needle. Third one, yes, we have taken out the needle and leaving the thread there. Fourth time, yes. So we can see this is TCL, this is flexor retinaculum, and the thread has passed beneath the flexor retinaculum. Second time, again from the same entry point and same exit point. Here the radiologist accuracy matters. So same entry point and same exit point, we go the needle superficial to flexor retinaculum. We pass the things, and we can see here, and in the short axis, we see the two ends of the threads are looped around the flexor retinaculum, just in midway between the median nerve and the ulnar artery. And this is very important because this is called TSJ, transverse safe zone. Your thread should be in the transverse thread zone, because if your thread is this side, this will injure median nerve. If this thread will be this side, this will injure the ulnar nerve. And we cut the thread. We cut the flexor retinaculum. Fine, it will be cut and it will come out. Yes, it come out. Fine. And what you find, yes, you will find a complete release of the flexor retinaculum. And this is the TCTR. What is the advantage of TCTR over surgery? Minimally invasive OPD procedure. Even I don't want to name the name, but Delhi's most famous plastic surgeon, who the carpet only the bread and butter, came for his TCTR to our hospital. I asked, sir, why you are not operating on yourself? He said, I have two sons, and I have one son and one daughter, and I have taken loan. So if I have got this scar entrapment of the nerve, I don't know who will pay the loan. So this is one of the advantage. Okay, limitations of TCTR. Yes, there is a pillar pain. Yeah. So okay, fine. There is a pillar pain. What is called pillar pain? If the pain at the thenar or hypothenar eminence, and here in some patients there is a RCA, reticuloanastomosis. Okay, and this is called nerve of Berrettini. This nerve can be ruptured, can be injured, but this nerve is not visible on ultrasound and MRI. Even the surgeon can rupture this one, and so there are the chances of the Berrettini nerve, but this is self-resolving. Some the rare of the rarest that you got a neuroma of this Berrettini nerve. So my time is up. Otherwise there is a tendon entrapment, but I'm not going to take more time, so I'm finishing this here. Thank you. Thank you.
Thank you very much. I think we'll keep the questions for at the end of the session.
Thank you. Yeah. Oh. Oh. Oh.
Oh, great.
Thank you. Thank you.
I now invite another star, and our organizing secretary, Dr. Nishit Kumar, Professor Nishit Kumar, who also works along with Dr. DK in Safdarjung and is doing extensive, excellent work. Thank you.
Thank you, ma'am, for your kind words. So, if you are not able to see the foreign body, the problem, it is not that there is no problem. The problem is that we are not able to see that. So, before taking out the foreign body, we need to see those foreign bodies, and that is very, very important. So, today I am going to talk about the removal of the foreign body. We have seen the needles, we have seen the guns, we have seen the thread. So, now we'll move to the forceps. So, I wish I had something to disclose. I have no conflict of interest. So, before I go to my talk, there was an amateur cricketer who has presented with monoarticular painful swelling in the ankle. There is no history of trauma, and it is there for about 2 months. So, this is for the audience, and this is the X-ray and the MRI. If you are sitting in India, where tuberculosis is known to cause anything and everything except pregnancy, so this was the patient who was referred to us for a synovial biopsy. Okay, we'll see what it was. So there was no problem. We could see there's joint destruction, and there's a lot of edema, periarticular muscle edema, and we can also see the subarticular destruction of the bone. Okay, so before that, now we see what is the problem. So that is the clinical problem of foreign body. About 38% of times we are not seen on the radiographs. 70% of the organic material is radiolucent, and if the foreign body stays in the body for more than 24 hours, there is a higher chance of the complications. And if it is a metallic or a glass foreign body, it is easier seen, but if it is an organic matter, plastics, they are difficult to visualize on the X-rays. So they may be missed. These are the easier ones. You can see the metallic foreign body, and that gets removed with the forceps. It can be done under fluoroscopy, CT, or ultrasound. The challenge lies when we do not see them on the radiograph. So here we see just the widening of the space in the first intermetatarsal space, and when the patient already had these MRs. So most of these MRI and the radiographs the patient is bringing with us done outside or in the institute at some other time. And here we can see there is the dark area, and there is a good capsule that is forming around the foreign body, and this was the splinter of the plastic chappal that he was wearing, and it has gone into the foot. So and this is the monoarticular arthritis that we had seen. This patient was posted for synovial biopsy, but fortunately we did the ultrasound of the patient before taking for the biopsy, and here we can see this is the foreign body that is lying there, causing the lot of foreign body inflammatory response that it was there. Another interesting case, and this is a young patient who has this scar over there, and there is a discharge over there, and we could see there is a soft tissue thickening. Outside it was reported as an osteomyelitis, and then when we did the ultrasound, so we could see this was the thread that was lying deep to the median nerve. It has already caused an neuroma in continuity of the median nerve, and this was removed intraoperatively. So as Dr. Bhatt told, so you should be very careful when not to do the intervention, and you have to refer the patient to the surgeon. It's not always that. So this was a Dhaga syndrome. It happens with the growing skeleton, so the ceremonial thread remains there for the longer time, and then it causes anything and everything. So mapping the foreign body before doing the ultrasound is very, very important. Identify it, anticipate for the granulomas and the surrounding fibrosis. We'll see how we remove it. Localization both in the long axis and the short axis. The fragments of the foreign body is equally important. Always put the Doppler to delineate the neurovascular bundle along the tract of the removal. So this is one foreign body we can see in the short and the long axis as well. But the problem is that when we sweep the scan, we can see there are multiple fragments to this, and here it is. These are the different particles of the wooden board that was there. So sonographic appearance, we know metallic ones are easily seen on the radiographs and the CT. So usually we do not do the ultrasound. If we do the ultrasound, there will be limited amount of the foreign body reaction. Glass also will appear as a sharp edge, and then it's the wooden and the organic material that will produce most of the foreign body reaction, and that why we get these good halo around it. So knowing the forceps is equally important. The sterile field I'm not going to talk about. So this is the cut down tray that we usually use. The two most common forceps that we are going to use is the Hartmann's alligator forceps and the Halstead mosquito. Mosquito comes both curved and the straight. So it's the curved one for the blunt dissection and the straight one for the extraction of the and we can also use the Kelly's forceps. So these are a few of the common ones you should always have in tray, so that you're not looking for the different forceps while you are into the procedure. The ergonomics is very important. You should be comfortable, because I must accept to the house that out of the 10 cases that we do, it is only in 7 to 8 times that we are able to extract the foreign body successfully. So you have to be very careful and make the patient aware of the rate of the success, though the science says that you can do it more than 90% of times. So the first thing is that you have to detach the foreign body from the surrounding capsule. So you inject local anesthesia, and then you put the forceps. So here we can see we have put in a hydrodissection, and we can remove the capsule, and capsule is lifted out there. Also create a plane above and below the foreign body. So again, that we do with the blunt dissection, and then we go and extract the needle. So whenever we are doing the blunt dissection, it is always done with the closed forceps, never with the open forceps. And you should be aware of the different artifacts that we can get. So one is the volume average artifact, and that is because if it is not in the true plane of the ultrasound beam, then we are only seeing the part of the forceps. We should be able to see the entire forceps along the length, and that holds true for the foreign body as well. So otherwise there would be a foreshortening of that. What is the fourth dimension? The fourth dimension of the different modalities or for the different scans are different. Here it is the tactile sensation. So you should always feel the foreign body for the forceps before you are trying to remove it. Otherwise it will lead to a volume averaging artifact. So always go to the edge of the foreign body, feel it above, feel it from the below the forceps before you are trying to extract it. So that is the fourth dimension of the ultrasound guided removal. And usually we do the blunt dissection to reach up to the edge of the foreign body, feel it, and then we remove it. But sometimes there may be significant amount of the soft tissues which will not allow the forceps to negotiate. There may be an interposing fascia, or there could be the capsule. So in such cases, what we do is that we do the sharp dissection. It can be done with the 11 gauge blade. It can also be done with the needle stillet of the soft tissue biopsy gun. And some cases you can use the bone biopsy introducer kit to puncture the needle. So basically you are doing an arthrotomy or the fasciotomy to pass the forceps. So now coming on to the removal, it can be a vertical alignment of the forceps. So the vertical means the edges are like this. So we are going there, we again feel the foreign body, and then we are opening the forceps and we extract the foreign body. Horizontal alignment, we go and feel the foreign body, and then what we do, we feel from the above edge, we feel from the below edge, and then we have oriented the forceps like this, and in the horizontal alignment we have done the removal of the foreign body. So now I'll show you 3 interesting cases. Most of the time we are doing it for the sports people, the ultrasound, so in the OPD, and they came and fortunately or unfortunately they were all the sports people, they were amateur sports persons. So the cricketer had a suspected ACL injury, and what we could see was there was a lytic area on the lateral femoral condyle. The surgeon was suspecting there is some tumor that is sitting over there, and he already had an MR done, so there was an erosion as well, so looking in terms of some pigmented villonodular synovitis as well. But fortunately we did the ultrasound. So you should use all the modalities. You have to be multimodal imaging, not just restrict yourself to one modality. And what we could see here was the foreign body, and this is how it was removed, and it turned out to be thorn. So the cricketer did not had the history of any trauma, but what he used to do was that in the village he used to climb the trees. So one of the trees where we take out the toddy, so he got the stuck with the thorn, and that was what was lying there for long time, chronic. Another patient, runner, and he had an IT band friction syndrome, and maybe he had a tear of the IT band, and the fashion of the day is the growth factors and the PRP. So already he had 3 shots of PRP injections before he was referred to us for the ultrasound. So what we could see was this was the foreign body out there, and this is how it was removed. And he was working, he was running in the field, and there was a carpenter who was working around that same place, and in the hills of the Uttarakhand, and there was the wooden particles from the plywood that was stuck into it. Third, this case I have already shown, and again a patient with swelling cricketer. There was no history of trauma, and there was a dark area out here. Maybe I would have also missed it on the MRI if I had not used the ultrasound. And what we did was that we went there. So all of this synovitis was a foreign body reaction, most of it, and we have taken this out. And there was not just one, there was 2 of them inside the ankle joint. So very important is that you should also look for the tetanus prophylaxis. Okay, so that is one thing that you should be careful about, and the asepsis role of the antibiotics post procedure. And you should not be very enthusiastic. You should be enthusiastic, but not to the extent that it harms the patient. So if it is near to the major neurovascular bundle, attendant sheath, carpal tunnel, we have seen all of this, and we have referred these patients. And if there is a failed attempt for more than 2 times, you just refer it to the escalate to surgery. Pediatric patients usually need the sedation and general anesthesia, so it is better to do the surgical exploration. And if there is an extensive foreign body burden, like in a military setup, there's multiple pellets, shattered glass, so on all such conditions also you do it under surgical. The evidence says yes, 87%. Our success rate is about 7 out of 10, so that is 70%. And complication rate is about, it reduces 3 times. That is very important. It reduces the chances of surgery in about 15%. The CSER 2023 recommendation is that it should be recommended for all soft tissue foreign bodies, except that in the close to the neurovascular bundle structures. So what are the key takeaways? Ultrasound guided foreign body removal, believe me, it is technically challenging. Yeah, just 2 slides. So you should learn it before you perform it, and always use the ultrasound before you inject the local anesthesia, because if you inject and there is air around it, you will just lose the sight of the foreign body. Map the foreign body number, depth, use the Doppler. Tactile sensation, you should be very important. Hydrodissection is your friend. And know your limits. It is close to the neurovascular bundle, more than 2 attempts failed, you should refer to surgery. So always learn, then perform, and then the best way to keep improving yourself is to teach. So come with us, join for the next conference, the 15th annual conference. I invite you at the MSS 2027 in Kolkata. Thank you so much for your patience.
Thank you, Dr. Nishit. And this is the last talk. So
any questions? You're welcome.
For all the speakers, some of them have left because of the early flight, but
that's the challenge. They don't give usually they don't have the history, so that is the challenge. You should keep using all the modalities, and that is the reason why they would have missed it in the early time, because it is very important. Raghav sir was also telling, Dr. Bhatt was also telling that you should interact with the patient, because half of your problem will get solved when you interact with the patient. Yeah. Yeah, and there was no history.
On asking the patient their history, that she had some treatment 2 months back, in which in a village, some practitioner inserted both chips to heal her shoulder.
Poor lady. Yeah. Thank you. Any more questions? Thank you.
Any other question for any of the other speakers? Yes, please. Go ahead. Somebody at the back was trying to ask a question, or you can get up first. Thank you very much. It was a very interesting session. And seeing that it was a full house on Sunday, very, very encouraging for us. Thank you very much.
areas of interest are trauma radiology and oncoradiology. He'll be taking over this session. Over to you.
Hello. Yeah. Thank you, everyone. I hope everyone had a nice lunch. Siesta after this just last session for the day. So we'll begin with Dr. Nivedita Chakraborty. She's from Tata Memorial Hospital. She was my consultant when I was a resident over there. She manages the bone and soft tissue DMG over there. Multiple publications in national, international peer-reviewed journals, multiple talks, and we're honored to have ma'am today. Ma'am, please.
Thank you for the introduction. Good afternoon, everyone. I hope you all remain awake till the end of the session in this first postprandial session. Okay, so I'll be speaking on the MRI of soft tissue tumors. Okay, so we follow the 2020 WHO classification for soft tissue tumors. You all can read this up. So, which are the various roles that MRI plays for soft tissue imaging? To provide information on the content, if at all this is evaluable, like fat, myxoid, chondroid or hemorrhage, which will provide the suggestive diagnosis. To identify lesions which do not require biopsy. So, which are the three key lesions, like lipoma, if you're 100% sure about it, a vascular neoplasm, and elastofibroma. We'll look at the cases. For pre-therapy planning, to provide information on surrounding structures, relation to the nerve, vessels, bone, and also for biopsy planning in consultation with the treating surgeon. To differentiate benign from malignant soft tissue tumors. So in majority of the cases, you all can differentiate, but sometimes it might become difficult. No worries, you all anyways have to put in a needle and biopsy these tumors. And for post-treatment assessment, so to evaluate post-treatment change and differentiate it from residual or a recurrent disease. So this is the MRI protocol that we follow for local evaluation of the soft tissue tumors. Now this paper on Ewing sarcoma has come up with a conclusion that MRI has a higher sensitivity and specificity for detecting bone metastasis compared to the FDG PET-CT. And also there's this fact that myxoid liposarcoma and synovial sarcoma metastasis, they have low FDG avidity, which results in more false negative examination for FDG PET-CT. So the current recommendation is whole body MRI for detecting bone metastasis. And this paper provides all the imaging recommendations, guidelines and indications for evaluating a case of soft tissue sarcoma. And these are the various imaging recommendations beyond the local staging. So, maximum metastasis is seen in lungs, right? So non-contrast CT chest is essential in case of high-grade sarcoma. Then 4% cases of tumors show lymph node metastasis. And which are they? Rhabdomyosarcoma, clear cell sarcoma, angio and epithelioid sarcomas. So if these tumors are present in the lower extremity, then contrast and CT abdomen plus chest should be performed. If these tumors are present in the upper extremity, CT neck plus chest should be performed. And what is the role of FDG PET-CT? They may be performed in case of rhabdomyosarcoma and all PET-avid sarcomas with lymph node mets. Now 10% of the soft tissue sarcomas can show bone metastasis. So which are they? If it's a myxoid or round cell liposarcoma, alveolar soft part sarcoma, angiosarcoma, leiomyosarcoma, undifferentiated pleomorphic sarcoma, dedifferentiated liposarcoma, extraskeletal Ewing's and synovial sarcoma. So these are all the indications for whole body MRI or MRI spine, because spine is the commonest site of bone metastasis. Now brain metastasis is very rare, but these tumors like alveolar soft part sarcoma, angiosarcoma, clear cell sarcoma, they have a propensity for brain metastasis, and so MRI brain should be performed in such cases. Okay, so for whole body MRI, what is the protocol? T1, STIR and diffusion and ADC. These are the imaging sequences. Now this table enlists the various MRI patterns and the suggestive diagnosis or the content of the tumor. So we'll look at the cases, but let's concentrate on the theory part first. So cases, you all can give the answer when I show you the cases. So if a tumor contains T1 and T2 hypointense component, that means it has fibrosis, right? And with or without, if there's some intermediate enhancing areas, then if large chunks of fibrosis present, then you know it's a fibromatosis, right? But remember, malignant tumors also show fibrous content, that is fibrosarcoma and undifferentiated pleomorphic sarcoma. Then if it's a T1, T2 hyperintense and completely suppressed on fat, then you know it's lipoma for sure. But liposarcoma can show some areas of fat, if not the entire tumor. But remember one thing, not all liposarcomas, they contain fat. So if you find a soft tissue sarcoma which does not contain fat, that doesn't mean you can rule out liposarcoma. But if it's present, then you can suggest a diagnosis that it could be a liposarcoma. Then if you see serpentine vessels, fat, hemosiderin, phleboliths, T2 hyperintense, then you know it's a venous malformation, right? So now this is a very classic location for elastofibroma. Infrascapular location, fat as well as fibrous tissue content. Then it's classical elastofibroma. I'll show you a case, and no biopsy is required in such cases. If it's a T2 hyperintense myxoid, peripheral septal rings arcs pattern of enhancement. Now, if you find in a soft tissue tumor, there's intensely bright T2 areas. So, what are the content? It could be myxoid, it could be chondroid, right? It's very bright. How will you differentiate? A pure myxoid content will not enhance. But if a myxoid content has some amount of tumor within some variable elements, then it will show variable degree of enhancement. Whereas chondroid shows a peripheral and septal pattern of enhancement. So if both are present, then you know it's extraskeletal myxoid chondrosarcoma. And if this myxoid component along with fat is present, you know it's a myxoid liposarcoma. If a tumor is in relation to tendon, T2 hypointense, intermediate, blooming on GRE, then you know you're dealing with giant cell tumor of the tendon sheath. Then again, relation to nerve, you know it's a nerve sheath tumor. Periarticular location, triple sign on T2. What is this triple sign on T2? T2 hyperintense cystic component, then T2 intermediate soft tissue, and T2 hypointense fibrosis or dystrophic calcification. Around the joints, then you're dealing with synovial sarcoma. If it's a painful swelling, subungual location, and T2 bright intensely enhancing area, then that's a glomus tumor. With the history itself, you can come to know. And multiplicity, so lipomas and vascular anomalies can be multiple. You should look for them, and you should be aware of these syndromic associations. So rule of thumb, all soft tissue tumors should undergo biopsy except lipoma, elastofibroma, and vascular malformations. Now, what are the features which suggest malignant etiology? Size more than 5 cm, peritumoral edema, necrosis, deep location, lack of fat rim. And how will you differentiate a lipoma from a atypical lipoma? So an atypical lipoma and well-differentiated liposarcoma, one and the same thing. So if a lipocytic tumor is situated in deep location, size more than 11 cm, septa more than 2 mm, septal enhancement, nodular areas located in the lower extremity, you have to put in your report that it's highly likely to be an atypical lipomatous tumor. And if an adipocytic tumor is located in the retroperitoneum, or if the tumor cannot be completely excised, then again you have to give this suggestion that it could be an atypical lipomatous tumor or a well-differentiated liposarcoma. This is the MRI reporting checklist that we follow in our institute with the location, compartment, relation to structures, content, and type of enhancement. We do not give staging because the AJCC staging is inadequate for treatment. Now let's look at the cases. You all are going to answer. So this is T2. You have intensely bright areas. You have some T1 hyperintense areas also. This is STIR, which shows some dark areas, right? So some bright areas which has been suppressed, and post contrast intensely enhancing. What is the content of this? So it's homogeneously enhancing, right? So there is myxoid component. It's very bright. It's not showing peripheral septal pattern of enhancement. And there is fat also. So it's a myxoid liposarcoma, okay? So then again, T2 bright areas, some T1 bright areas, but this is GRE. There's some blooming within. And this area is not enhancing at all, but the superior part, it's showing some peripheral septal pattern of enhancement. So it has myxoid and chondroid, right? So it's an extraskeletal myxoid chondrosarcoma. Now we have this on T1, it's isointense with hypointense areas, T2 intermediate and hypointense, and the non-enhancing the hypointense part, whereas the rest of the tumor intermediate areas are showing homogeneous enhancement. This is classical fibromatosis, okay? Now what is this? You have T2 bright areas, you have post-contrast enhancement centrally, STIR shows excessive edema, and you also have this a CT image, so you also have some peripheral calcifications. So what is this? Myositis ossificans, and stage is intermediate because you have edema as well as the ossification, right? So what are the various stages? In early stage, you will find the striate or checkerboard pattern of enhancement. In the intermediate stage, the edema will be less. Of course, in the early stage, you have lots of edema. The edema will be less in the intermediate stage, and there will be subtle peripheral ossification. And mature stage, there won't be any edema. There will be prominent peripheral ossifications. Okay, what is this? This is located around the joint. It has triple sign, right? So T2 intermediate, dark areas and bright areas. blood fluid levels, heterogeneous contrast enhancement, some patchy areas of diffusion restriction. So synovial sarcoma. Okay. What about this? T2 hyperintense, some vessels dilated. Then you have some bright areas also fat, no edema on stir, post contrast enhancement, venous malformation. Venous because it's bright on T2. Then this is T1 bright, T2 bright, completely suppressed on stir, lipoma. So no further biopsy required. This is toe in relation to the extensor tendon, intermediate signal dark areas also in midden, and homogeneous enhancement. What do you say? What is this? Giant cell tumor of the tendon sheath. Okay. So then this in relation to the nerves, right? This is the tail sign and some cystic areas with no diffusion restriction. Definitely this is nerve sheath tumor. What are the differentiating features? So usually this tail sign, split flat sign, target sign seen in both. Neurofibromas usually centrally located, schwannomas eccentric. Neurofibromas are homogeneous, schwannomas heterogeneous with cystic areas, calcification rare in neurofibromas, and in schwannomas it can be seen particularly in the ancient schwannomas. ATC value is more than in schwannomas, whereas lower in schwannomas. And what about the malignant peripheral nerve sheath tumor? If a tumor is more than 5 cm, ill-defined margin, associated edema, no target sign, early enhancement on the arterial phase and rapid washout, and lower ATC values. And these are all the findings which are suspicion for malignant transformation on follow-up of a previously benign nerve sheath tumor. Now, what is this? This is subungual location, right? Post-contrast intensely enhancing T2 intermediate, painful swelling. Even if I don't show you the images, MRI images, you know with the history that you're dealing with a glomus tumor, right? So this is a typical elastofibroma taken from rat source. So it has got, T1 and T2 hypointense fibrous component as well as T1 and T2 bright areas, no enhancement. So this is typical elastofibroma, no biopsy required in such cases. So now you should be aware of this nodular fasciitis. So this comes under the fibroblastic or myofibroblastic soft tissue tumor as per WHO classification. So there are 3 varieties. It can be subcutaneous location, facial type, or intramuscular. So this article beautifully describes the various signs for each of these subsites. So here you can see one of this nodular fasciitis, it's enhancing, and you can see the tail along the, enhancing tail along the fascia. And in another case, non-enhancing central portion, peripherally enhancing fascia. So this is solar halo sign. So these are seen in facial type of nodular fasciitis. So this is intramuscular type, it's T2 hyperintense, and there's enhancement within with ill-defined or indistinct margin, known as a cloud sign. So this is seen in case of intramuscular type. This is reverse target sign. So target sign is what? Central T2 dark and peripheral bright. So this is the reverse target sign over here in the subcutaneous plane, peripheral and nodular and heterogeneous enhancement along with the facial tail sign. So this is a type of subcutaneous type of nodular fasciitis. So you should be aware of this because this might look ominous, but it's a benign entity. Okay, so now also for post-treatment evaluation. Now this is fibromatosis. We've seen a case T2 intermediate, hypointense areas within homogeneously enhancing, the intermediate part is homogeneously enhancing. And post RFA, how will you evaluate? The intermediate enhancing part is the active component of the fibromatosis. So after RFA, you are looking for the increase in the inactive component. T1 and T2 hypointense part, if it goes up, the enhancing component reduces. That's what then you will say that there is some response to the RFA, to treatment. So you can see the size has reduced. Along with that, there is qualitative response as well. The inactive part has gone up, the enhancing part has reduced. But however, the sciatic nerve is still encased. You can see this, the sciatic nerve is still encased. Over here, to again differentiation of residual versus post-treatment chain. This was operated outside, and you can see that in the gluteal region, subcutaneous plane, you can see there's a T2 intermediate lesion which is showing heterogeneous enhancement and also diffusion restriction. So definitely this is a Whoops lesion, and there's a definite residual tumor over here. So what is the take-home message? So all soft tissue tumors, you need to put in a needle and biopsy, whether you are able to give information on the content and diagnose it or not, except lipoma, elastofibroma, and vascular malformations, you should be able to identify them. And the MRI reporting checklist should contain all the necessary information for treatment planning. So this brings me to the end of the talk. Thank you. Any questions?
Thank you so much. much, ma'am. Such an amazing, informative lecture. We'll take Q&As for all the sessions at the end for all those. Amazing.
Yeah, 40. No, I was keeping an eye on the timer. I shouldn't overshoot.
Anyone, any questions, please?
Is there any role for ADC, specific ADC values, especially the
So we don't take specific ADC values. But yeah, the studies have mentioned cutoffs. But as I said, even if we are able to give certain, tumor histopathology, even then we'll have to put in a needle and biopsy. So there we won't gain much by, putting the differentiating features for nerve sheath tumors. There it is of value where you want to know it's a malignant nerve sheath tumor you're dealing with or a benign one. There the ADC value that I provided the cutoff. So that is important. But in rest of the cases, it will not have much value because anyways you have to biopsy and they will need a biopsy before treatment. Yes.
How much weightage do you give to diffusion? Like if you were to look at only the premature and would suggest probably a clean-looking lesion with dark margins might be the soft tissue edema. And if diffusion pops up with those diffusion restriction, how much weightage would you give to consider an aggressive lesion?
Yes, definitely diffusion, but in not all the cases, because if there's hemorrhage, then also diffusion will show up. But the solid part, if it is showing some diffusion restriction, definitely I'll err more in favor of a malignant etiology. But for soft tissue tumors, all the sequences are taken in total. Like schwannomas can sometimes show diffusion restriction. So there can be benign tumors also which are showing patchy diffusion restriction. But if I have, definitely we take qualitatively, we assess the diffusion restriction. If it is there, then that is definitely going more in favor of a malignant etiology. And of course, I would expect those BCOR and Ewing sarcomas to have a, very low ADC values. So, but they will look ominous even on the routine sequences. So that's how. Yes, we do dynamic post contrast for especially for so we do for bone tumors as well as for soft tissue tumors. But this is of value, particularly in case of post treatment imaging, where you are unsure whether it's an indeterminate lesion, which if there is any residual tumor remaining, or it's just a post treatment change. Many a times you may not find a very stark difference, like okay, this is showing diffusion restriction, this is T2 intermediate showing heterogeneous, and many times it's in between. So at that time, the dynamic sequences, they are of value. If you see that typical graph where it's arterial, rapid washout, arterial enhancing, rapid washout, then you can say definitely with confidence that yeah, this is a malignant tumor, but not if there are other kinds of curves. So that's why for soft tissue tumors, dynamic imaging is of value. So we routinely do. We do upfront also. So for all tumors, for in our case, like for bone tumors as well as for soft tissue tumors, we do dynamic imaging. Yes. So we don't take the K-trans value, we just draw curves. So ours, everything is qualitative. We really don't have so much of time to take ADC values, to take K-trans values. So we have like so much of patients pending. But yeah, for a study purpose we take, but I really don't have any experience with the, no, we don't use on a routine. Yes. Post contrast, no. Whole body MRI post contrast is not required. It's only T1 and the diffusion ADC and the stir sequence. Post contrast is not required for.
Thank you so very much, Dr. Nivedita. May I have the pleasure to call our next speaker, Dr. Drushi. She needs no introduction. She's a very well orator with so many of achievements, and I'm anyways privileged to be working with her since so long. So over to you, Drushi. She'll be talking on TM joint.
Okay, thank you very much. I am overwhelmed with a full hall in the noon session on the second day. So before we start, I would just like to know how many of you do routinely TM joint imaging? Few hands, okay. And how many of you find TM joint imaging difficult? Still only few people, okay. All right, so TM joint, All right, so what we will do is we will take this talk in 4 parts: protocols, MR anatomy, what is TM joint dysfunction, have a look at few cases, and reports. What I want you to know that this is a small joint, probably where if you have a difficulty in reporting TM joint is because you don't have as many referrals. There is only few set of things that you need to learn and understand in TM joint, and once you know, you know. So that's the aim of my talk, that you see the spectrum and it just becomes easy for henceforth for TM joint imaging reporting. First things first, MR protocol. So you need a surface coil for TM joint. The sections have to be thin because it's a very small joint. You need to keep your FOV small, of about 130 millimeters. You cannot have the entire mandible in your frame. And the sequences are taken in 2 sets, the closed mouth position and the open mouth position. As you can understand, these TM joint patients, they come with pain complaints and you can't keep the mouth open for long. They will be having discomfort. So we try to take most of the sequences in closed mouth, and only the PD sagittal oblique image is taken in the open mouth. That is good enough to evaluate the function. Another word for while planning the sequences. So if you have a look, the TM joint, the mandibular condyle, is obliquely oriented in the coronal plane. So a routine coronal is not suffice. And you need to obtain coronals for each joint obliquely. So that is, on each side you have to take 2 coronals, and then the oblique sagittals are planned perpendicular to these coronals. Coming to MR anatomy. So this is how a typical TM joint looks like. Yes. Okay. So this is the mandibular condyle, mandibular fossa, articular eminence. Now you look at the schematic here, and we'll see all the small parts here first and then on the MR image. So this is a disc, and it has an anterior band, a thin intermediate zone, and a posterior band. These are the attachments. These are the superior and inferior capsular attachments which attach the disc to the articular eminence and the mandibular condyle respectively. Posteriorly, there is the superior and the inferior retrodiscal layers, and then there are these muscles which are responsible for the movement of the TM joint, that is the superior head and the inferior head of the lateral pterygoid muscles. And then there are the neurovascular structures in the loose connective tissue at the posterior aspect. So now have a look at the MR image. So a typical disc, articular disc, is a fibrocartilaginous disc, biconcave in shape, with an anterior band, intermediate zone, and a posterior band. If you look at this, these are the fibers of the superior head of the lateral pterygoid muscle which are attached to the disc, and this is the inferior head of the lateral pterygoid muscle attached to the mandibular condyle. So when this contracts, the mandibular condyle, it moves forward, the disc moves along with it because the superior fibers contract along with them. So in an initial closed position, that is how a mandibular condyle is in relation to the articular eminence. At the beginning of mouth opening, there will be digastric muscle which acts first, and it will tend to pull the condyle, and that's how the condyle starts rotating. When the mouth opening is about 20 to 25 millimeters, it is the pterygoids which start acting, and so with the contraction of the inferior pterygoid muscle, the mandibular condyle is pulled forward, and with the fibers of the superior lateral pterygoid muscles, the disc moves along with it, and it slides with the mandibular condyle over the articular eminence. And this is how the maximum clenching position is. And then the superior and the inferior retrodiscal layers, they are like a check crane which hold the articular disc in place, and it does not subluxate further. So this is how a typical dynamic BTFE sequence looks like, and you can see how the disc moves in open and closed mouth position. So this is a typical closed mouth, and this is an open mouth when the disc slides forward over the articular eminence. And in this place, I mean in the open mouth position, we can identify the superior and the inferior retrodiscal tissues better. And then this bright area is the loose connective tissue which has the neurovascular bundle. So what is TM joint dysfunction? It is an internal derangement, abnormal relationship of the disc to the condyle. So precise localization of the articular disc is most important in the diagnosis of TM joint internal derangement. In TM joint dysfunction, a continuum of finding occurs. That is, first there is anterior disc displacement. That is, the disc starts malfunctioning. It starts displacing. Because of that abnormal position, there will be changes in the disc. It starts thinning, or there may be crumpling, irregularities. Subsequently, those reinforced mechanism at the posterior aspect, the superior retrodiscal layers, they thin out, and the disc fails to reduce on open mouth image. We'll see all this. And subsequently, there'll be changes in the joint with osseous changes or secondary degenerative osteoarthritis. So these are the continuum of changes that can occur, and that's what you are supposed to look for. So when you report a TM joint, your report should include the following things, of which the disc shape, the position, and whether there is any displacement or not is evaluated. The condylar shape and the joint status, all this is evaluated on the closed mouth images. And whether the disc reduces or not, or whether the disc mobility is normal or not, is evaluated on the open mouth images. So we'll see what all you are supposed to see. So this is a normal disc, as we saw, biconcave disc shape. It can become thin, it can become irregular, crumpled, or there may be perforation. So these are the spectrum of findings that occur in the articular disc. About next is disc position. So where it is considered as normal. So if you draw a vertical at the junction of the posterior band and the bilaminar zone, then it should be at the 12 o'clock position of the mandibular condyle. This posterior band bilaminar zone, usually it falls in 10 degrees from this vertical. That is considered as normal. Okay. But it is found that 33% of the asymptomatic volunteers, they can also have up to 10% disc displacement. So to label as pathological, we take the 30 degree as the cutoff. That when it is more than 30 degrees, we say it's definitely disc displacement. Between 10 to 30 degrees, you need to correlate with the clinical findings and all. Okay. And the other features, how the disc is, how the joint is, and everything else. So disc mobility. Disc mobility you evaluate on the open mouth images. So that is what all you see on open mouth images. If there was a disc displacement in the closed mouth, whether it reduced or not, meaning whether it went back to its original position. Second, it did not reduce. And third, this is stuck disc. So these are the only findings that you will find in a TM joint. Okay. So case 1, 14-year-old with pain during jaw movement on either side. I would suggest that before even you start evaluating, you should have your screen right. Have the coronal first, second have the sagittal closed mouth, and third have the sagittal open mouth to evaluate together of the same side. So coronal is in place. You can see the so you can see these are the closed mouth images, and this disc is anteriorly displaced, and this is the open mouth images, and you can see that the disc, the center intermediate zone, is now centered back in the between the mandibular condyle and the articular eminence. So this is how it looks like, and so this is anterior disc displacement with reduction. Okay. And this gives a double disc sign because the inferior lateral pterygoid muscle and the displaced disc, they give a double disc appearance. It's just a sign you're supposed to look in a continuum. On the opposite side, coronal, this is the, let's just straight away go to this image. So here this is anteriorly displaced disc on closed mouth image, and on open mouth you can see that the condyle protracted anteriorly, but the disc failed to reduce between the mandibular condyle and the articular eminence. So this is anterior disc displacement without reduction. Okay, and this is how we put it in our report. I'll show you the report at the end. Case 2, where a 55-year-old female with pain during jaw movement on left side. So if you look at this, in the coronal plane, there is more bulk of the articular disc at the medial aspect. On the closed mouth image, the disc is anteriorly displaced. On open mouth images, it failed to go and reduce between the articular eminence and the mandibular condyle. So this is anterior medial, enteromedial disc displacement without reduction. Okay. So the anterior and the posterior component you evaluate on the sagittal plane, and the medial and the lateral component of disc displacement you evaluate on the coronal plane. And that is how you put it in the report, that how the disc morphology was, how the position was on plane, correlating the sagittals and the coronals, plane meaning closed mouth, and then on disc position in the open mouth mobility, whether it got reduced or not. Okay. So the observation of medial versus lateral component is done on the coronal images, and anterior and posterior is done on the sagittal closed mouth images. Now a 28-year-old with recent onset of limited jaw opening with intermittent pain in left TM joint. Both are running together. I think we'll just go here. So here you can see that it is the disc is in normal position. It's almost within 10 to 15 degrees of the on the closed mouth images, the junction between the posterior band and the bilaminar zone. And in the open mouth images, the condyle protracted. The history was that there was restricted movement, but the disc, the posterior band is still there in the mandibular fossa. It was supposed to glide further on the articular eminence. So this is stuck disc. So if you don't obtain the open mouth images, and if you evaluate TM joint with just the closed mouth images, here you see that you will report it as normal. So you have to do the closed and open mouth images both. Okay. So that is stuck disc or anchored disc phenomenon, and the gist of this is that you should do both of it, and just don't do just the open mouth, say that there is no disc displacement and leave the case there. Okay. Next case, where they presented with jaw locking. This is a very unusual case, rare case, because most of the times we have anterior disc displacement with a medial or lateral component. Here you can see that the junction is, there is a large discal dark component which goes behind the vertical of the mandibular condyle. So this is posterior disc displacement, and on open mouth images it got reduced. So this is posterior disc displacement with reduction. Okay. And this is the same findings on the opposite side. And the posterior disc displacement is not that common. It may present with jaw locking, and you have to differentiate it from fibrotic changes that occur in the retrodiscal layer, which is associated with the anterior disc displacement. How do you differentiate? You look at the color of the tissue that goes behind. If it is iso to the disc, then it is more likely that it is the disc component and not the degenerated or fibrotic retrodiscal layer, because it will be intermediate signal. Okay. So this, when there is anterior disc displacement, the retrodiscal tissue gets degenerated and thinned out. That can also look like that. And that portion is usually, does not go beyond the 12 o'clock. It's usually in the superior portion. So that is the differential. That's everything I said. Besides this, we also report the condylar shapes. They are not of much importance, but then when something like a bifid condyle is there, then there will be changes in the disc, and it will still might have normal mobility. There can be excavated condyle, flattened condyle, pointed condyle. You make a note. I'll wind it up. And it has to be differentiated from the pathological changes like erosions and sclerosis. The last point is to evaluate the joint, and joint for presence of joint effusion, marrow edema, erosions, marginal osteophytes, synovitis. So all these things you have to make a note when you make your report. I think we can skip the other cases like synovial chondromatosis and ganglionosis that can occur with the TM joint. There were examples. The recap is more important. That is, for TM joint, closed mouth, evaluate how the disc looks like, whether it's crumpled, irregular, perforated, right? Look at the position, anterior and posterior component, you look on the sagittal plane. Medial or lateral component, you look on the coronal plane and decide it's enteromedial displacement or enterolateral displacement. Then open mouth, look at the mobility, whether it got reduced, it did not get reduced, or was it stuck. And then you look at the associated features, whether joint diffusion, how's the shape of the condyle, how is the joint, are there any arthritic changes, and joint diffusion or synovitis. So that's all about the report, and everything what we saw, we put it in a tabular format in the same pattern that we evaluate. Shape of the condyle, closed mouth, morphology, position, what was the angle. Now I look at the open mouth, in open mouth whether it reduced or not, any associated features, and put the impression. That's exactly how your mind reads. The same thing you put in a tabular format, you can't go wrong. And the referring who understands it, he also can understand this clearly. So that's how we draw it also. That's a schematic that we use, and exactly in the same form that we evaluate, same we give to the patient for better understanding. Thank you. I already used 2 more minutes. So no questions for me.
We have a Q&A session.
Q&A session is there at the end of the session for everyone.
Just making sure you stay here for the entire session.
So may I now invite our next speaker, Dr. Devendra Goyal. He's working in Bombay.
Yeah. So housekeeping done. If the PPT is working fine, the arrow is visualized. So good afternoon, everyone. Today we'll be talking about AC joint injuries and what we can understand beyond Rockwood. Rockwood as a radiographic classification is indispensable as a shared common language between radiologists and orthopedicians. It helps us classify AC joint injuries and type them, not grade them. It is not a sequential grade 1 to 6. It is a type 1 to 6 because there are multiple axes of trauma and not one severity axis propagating through it. But the reality to treatment is something different, and we'll try and see if we can match all of them together. So we'll start with the anatomy, the entire Rockwood classification, where radiographs win, where they fall short, how we can close the gap with additional views, what is the use of MRI in closing the gap, and how we can all integrate it into practice. So what is the stake of the radiologist in the entire discussion? 9% of shoulder girdle injuries are acromioclavicular joint injuries. 5:1 male is to female preponderance, and most of them are low type. Again, not grade, low type. The type you assign on radiographs determines whether a patient gets a cast or the patient goes for surgery. For the minority who are reported or scheduled for surgery, it is important because you have to determine whether it is acute or chronic, because acute repair has much better prognosis than compared to chronic graft reconstruction. So the discussion is not academic. It is actual bearing upon the patient's management and prognosis. So we'll start with the anatomy, basic housekeeping anatomy, shoulder AP radiograph. We can see the clavicle, the lateral end of the clavicle, the medial clavicle, the medially placed conoid, the laterally placed trapezoid ridge. This is the body of scapula. This is the spine of scapula with the acromion process. We'll zoom this up a bit. So this is the acromioclavicular joint space, and this is the coracoclavicular space. These are the 2 most important measurements which you will see across Rockwood classification and will help in typing of the injuries. In addition, we have to know the soft tissue of the trapezius muscle and the soft tissue of the deltoid muscle. Now, this is a SVG schematic of the anteroposterior radiograph of the shoulder. The blues indicate the superior and inferior acromioclavicular ligaments, which are bearer of horizontal stability. The conoid and trapezoid parts of the coracoclavicular ligament, which are bearers of vertical stability. The trapezius muscle joining the lateral third of clavicle. The deltoid arising from the acromion, and this fascia, the yellow one. So the superficial trapezius fascia merges with the superior acromioclavicular ligament, which itself is continuous with the superior deltoid fascia. It is one continuous aponeurotic sleeve providing dynamic restraint to the acromioclavicular joint. The coracoclavicular ligament is not connected to either the deep trapezius or the deep deltoid fascia. It is connected. There's a small muscle over here known as the subclavius muscle. It is actually continuous with the subclavius and the clavipectoral fascia, but not to the trapezius or deltoid fascia. So on an MR coronal image, you can see this is the deltoid, this is the trapezius, and the aponeurotic sleeve is continuous across the trapezius muscle and the deltoid. So in a normal patient, the horizontal stability is maintained by the AC capsule, which thickens to form the superior and inferior acromioclavicular ligaments. The vertical stability is by the conoid and trapezoid parts of the coracoclavicular ligament, and the muscles along with their fascia form a dynamic restraint for the entire stability. Normally, the normal acromioclavicular joint space varies by person. 1 to 7 is the normal cutoff taken. The coracoclavicular distance, again, not one ballpark figure, rather a range, 10 to 13, and the clavicle is nicely aligned with the inferior border of the clavicle, continuous with the inferior border of the acromion, no offset, the joint not displaced. Now in type 1, what is the mechanism? It is a blow to superior acromion, the lowest type, again not grade, the lowest type, the least severity of trauma. The joint, there is sprain of the superior and inferior acromioclavicular ligaments, but nothing is torn. So the distance is normal. The joint is still holding, but there is sprain. The CC distance is normal, the clavicle is not displaced, and the fascia is normal. In this case, we always try get a contralateral radiograph, and we do it for all suspected patients of Rockwood injuries. Here you can see there is asymmetric widening of the right acromioclavicular joint space compared to the left, which in a patient with trauma and suspected Rockwood injury would be typed as Rockwood type 1 injury. In this, in Rockwood type 2, the mechanism is same, but there's increasing severity of trauma. So there's tear of the superior and inferior acromioclavicular ligaments, so there'll be widening of the acromioclavicular joint space. The measurement goes beyond 7 mm. There is sprain of the superior and inferior acromioclavicular ligaments, so there might be some elevation of the clavicle, but the lower border of the clavicle will not cross the superior border of the acromion. They will not be complete offset, and there will be sprain of the fascia itself, but the fascia remains intact. In this patient, we can see the joint space is widened, the CC distance is normal, so this will be a Rockwood type 2 injury. In Rockwood type 3, again, same axis, increasing severity of trauma, tear of the acromioclavicular ligaments, complete tear of the both conoid and trapezoid parts of the coracoclavicular ligament. The fascia still holding the entire intact mechanism. So increase AC width, increase distance, but less than twice of normal. It has to be less than twice of normal, but the lower border of clavicle has already crossed the superior border of the acromion. So AC tone, CC tone, sprain of the DT fascia. In this case, we can see the clavicle is above the level of the acromion with increased CC distance and AC distances. This is Rockwood type 3 injury. Let's skip type 4. Let's go to type 5 because that is the continuum. The severe most superior force trauma. Complete disruption of AC, complete disruption of CC, the fascia gets torn, the clavicle is already above the level of the acromion, and the CC distance is more than twice of normal. This becomes Rockwood type 5 injury. Self-evident, superiorly displaced clavicle with twice the normal of the CC space, Rockwood type 5 injury. Type 4 is a completely different axis of trauma. It is a blow to posterior acromion. So the AC joint space normal, can be normal. CC distance can be normal, but this tear of the fascia. The clavicle is displaced posteriorly. It might even be buttonholed, and we cannot diagnose this on an AP radiograph. This is an AP radiograph. Trust me, this patient has type 4 Rockwood injury, even if we cannot diagnose it. We cannot see these. The CC space is normal, the AC space is normal, the joint looks congruent. This is where we get stuck. We'll see a solution to this later. And type 6, extremely rare, inferior displacement of the clavicle. This is the only instance when the CC space becomes negative, the measurement becomes negative. It can be subacromial or subcoracoid. So remember, it is not one axis of trauma. There are two axes, not a single chain. In the superior one, we have 1, 2, 3, and 5. Then 4 and 6 types for posterior and inferior directions of trauma. So where radiographs win? First line triage, cheap. High grade injuries are obvious. You can see a Rockwood type 5 very easily on a radiograph. You can see additional fractures, either whichever classification system you use, either the Edinburgh classification or the Neer classification for distal clavicular fractures. You can type it on a radiograph itself and it is reproducible. There is superior inter and intra-observer reliability for coracoclavicular distance on a radiograph itself. Even a chest radiograph, if you measure the CC distance, it is 96% sensitive. So that is how a radiograph is there. But where do they fall short? The problem is we are doing a 2D typing for a 3D injury. There are three structures holding it together. First, horizontal stability was maintained by acromioclavicular ligaments. Vertical stability, coracoclavicular. And the dynamic restraint was the muscles and the fascia, the DT fascia, the one continuous aponeurotic sleeve continuing from trapezius AC joint towards deltoid. We are taking a 3D injury, giving a 2D type, and then determining treatment. And the thing is, it does not progress. It is not a grade. It is not a type. It is not like if you have taken type 2, agla uska superior trauma 3 aayega. Nahin. It can be completely different altogether. So if there is a sequence of injury, to oversimplify, the horizontal restraint, the AC joint can be injured even before the vertical restraints of the CC ligament or the deltoid fascia, or even if there is buttonholing of the clavicle. So there can be meaningful horizontal injury even before the vertical distances increase. And this cannot be captured on a 2D AP radiograph alone. Now again, we are measuring the vertical axis. We are doing it on chest radiographs, shoulder AP radiographs, even Zenka views. Because in a Zenka view, you do a 10 to 15% tilt. But that metric, you are just improving the measurement of the CC distance. You are not doing for anything for the horizontal axis. It is still invisible on the AP radiograph. That axis having meaningful trauma before the vertical distance increase is being completely lost. The geometry is not visualized. Then Rockwood type 3 has actually become a junk category. It is being defined by what it is not. It is not Rockwood 2. It is not Rockwood 5. 3 hoga fir. It is not like that. It is a single category, a single type harboring both stable and unstable injuries. And a type harboring both types of injury leads to confabulation of the treatment decisions. And a single AP view cannot split that decision into stable type 3 or an unstable type 3. And the last, the most contentious, the disagreement between radiographs and MR. 50%, almost 50% of the times they disagree. Radiographs label it something, MR decreases it down, and sometimes MR increases the grade. So radiographs overcall more often than they undercall. So how can we close the gap? First, the right views. Zenka view, a very nice view because you can actually compare the joint along its own axis, but again for the vertical distance, always get bilateral views, otherwise you will miss a lot of Rockwood type 1 injuries. Always know what the symptomatic side of the patient is. To fix the horizontal plane, we can take two views, and the best is a crossbody Alexander. So basically you take the symptomatic side and you put it below the axilla and becomes a stress view for the injured shoulder. We do it for both the shoulders separately. So we take a big panoramic AP view of the shoulder covering both of them in AP, and then Alexander crossbody views for each individual joint. Sometimes some of my orthopedicians prefer a weighted AP view for dynamic vertical instability to see if a Rockwood type 3 moves to Rockwood type 5 on increasing the distance or weight bearing of the joint. This is what an Alexander view looks like. This is the clavicle. This is the acromion. The joint is nice and centered. But if there is injury, we can already see there is posterior displacement of the clavicle. A type 4 Rockwood becomes clear and simple on a radiograph itself. If this was the AP view, no one can say in this was a Rockwood type 4. There is no posterior displacement on this because we are completely missing the axis on this. So this was the radiograph for type 4 which we started with. Add a crossbody Alexander and you have your answer. This is Rockwood type 4 injury. So closing the gap again. Type 3, junk category, harboring stable and unstable both, defined by what it is not. So Isocos decided to split it into two, 2A and 2B. So 2A is a stable injury in the clavicle stays put and scapula moves normally, and 3B becomes an unstable injury. So you can do it two ways. You take a radiographic view. If there is clavicular overriding, radiographically you can say it is 3A, or they can do a clinical stress test for the same. So 3A stable, 3B unstable, 3A goes conservative, 3B gets a trial of conservative before going to surgery. So This was all qualitative. If quantitative, you can draw circles in the distal clavicle, the distal acromion, and take the distances between the two centers. And this is how you take it. You can screenshot it, apply in your daily life practices so that you remember where to touch the cortices of the circle you're using. Then how to measure it? You do it on both sides. You take the injured side and you minus the distance on the normal side. Less than 7, stable. 7 to 14, moderately displaced. You can give a trial of conservative, keep a low threshold for surgery, and more than 14, it becomes unstable. How do we close the gap with MR? MR is actually tissue mapping the entire thing. The AC ligaments, are they full thickness tone? Are they injured, sprained, DT fascia, toned, buttoned hold? Is there bone marrow edema? Is the injury acute, chronic? Is there fatty infiltration, scar tissue, fibrotic tissue? What are the associated injuries? And yet, we are not giving a grade on MR. That has not been proven yet. The deltoid fascia was proposed by Rockwood, but seen on MR, and MR contributes in ways: edema, stripping, buttonholing. Because a buttonhole clavicle needs to be reduced, it won't come back on its own. So this was a Rockwood type 3 injury. We've already seen this radiograph. But here on MR, we can see full thickness tear of the acromioclavicular ligaments, high grade injury of the CC ligaments, and low grade sprain of the DT fascia. This was a Rockwood type 5 injury with complete thickness tear of the ligament and stripping of the entire fascia from the bone. And people like their own company, right? आप कहीं से आपको अपने same लोग पसंद है. High grade injuries have high grade injuries of the other structures. Always remember that. This patient of Rockwood type 3 had a posterior labral tear with a paralabral cyst. This patient, he had a Rockwood type 3 injury, underwent repair, cortical button fixation, acute repair, and the patient came back to us with distal clavicular osteolysis. No one knows what happens. The radiographs never made the radiology department, treated from the orthopedics OPD. Sab hone ke baad it comes to us, what can we do? So the problem was, this fragment of bone was assumed to be from the acromion. After reduction, it was actually, no one paid notice, it was from the clavicle. You fixed the vertical axis, but the clavicle is already injured. Once you fix the vertical axis, the horizontal transmission is through the clavicle. The clavicle is getting more weight bearing now, and the osteoclastic activity exceeds the osteoblastic activity, contributing to distal clavicular osteolysis. So a practical solution is, take a Zenka bilateral AP, type the Rockwood. 1 and 2, non-operative. High grades goes to surgery. If 3, take a crossbody Alexander. 3A stable, go for rehab. 3B unstable, plan for surgery. Take the MR, do an acute versus chronic, acute button fixation, chronic graft, and in high grade injury, look for additional injuries. This is what we practically use. This is what our orthopedicians are happy with, and we've had very less complications rate with it. So AC capsule, conoid, CC distance, DT fascia, bone marrow edema, and associated injuries. So the take home message is, the reality is a bit away from Rockwood. We are the gatekeepers of the type, and we need to close the gap. Remember, types not grades. We are seeing only one axis, close the gap for the second, recommend further imaging, say we need to get an MR done, and that is our value. Thank you.
Thank you very much, Dr. Devendra Goyal. That was a nice, yeah, we have to take the questions at the end only. We need to start the quiz on time. Yes. May I invite the next speaker, Dr. Hiten Panchal. He'll be talking on imaging in Erb's palsy.
So good afternoon. So let's talk about the unstable shoulder in brachial plexus birth palsy. So as we all aware that in brachial plexus palsy, because there is a muscle imbalance with strong internal rotators with weak external rotators, and the child is rapidly growing, so glenohumeral joint is more prone to having a dysplastic changes. So what are the bony changes that we are expecting? So the first is glenoid retroversion, then glenohumeral subluxation, dislocation, and lastly the humeral rotation. So we have 3 imaging modalities available to quantify the abnormality. First is ultrasound, MRI, and CT. We rarely use CT. So most of the cases we do an ultrasound and MR. When to use ultrasound? So we prefer using the ultrasound in infantile dislocation in less than 1 year of age. If it is more than 1 year of age, we usually do MR. So what is the techniques? We as a radiologist, we all aware how to scan the shoulder. So from the posterior axial approach, we scan the shoulder, and we also do the dynamic evaluation whether the head is relocating in external position or not. So on ultrasound, you just have to identify the ideal ultrasound image. So what is the ideal ultrasound image? So when you can see the dorsal scapular line straight, then you can see the capitate humeral epiphysis as well as the posterior cortex of the humerus. So on this ideal image, we'll try to draw a measurement which is called alpha angle. So what is alpha angle? So it is an angle between the dorsal scapular line and one line tangential from the posterior cortex of the humerus transecting the dorsal scapular line through labrum. So the angle between these two lines is alpha angle. So what is the importance of the alpha angle? So for the surgeons to call it the infantile dislocation, they needs to fulfill this criteria. First is alpha angle should be more than 30 degree. Capital humeral epiphysis should be posterior to the dorsal scapular line. So if these two criteria are meeting on imaging, they call it as an infantile dislocation. And if on brachial plexus imaging C5 and C6 nerve roots are involved, then they prefer to having a Botox surgery. If the C7 nerve root is involved, then Botox is contraindicated and they do open reduction or minimal invasive subscapularis release surgeries. So this is how the shoulder imaging is important for the treating surgeon. When the patient is more than 1 year of age, we usually do MR, and we all know the technical details about the MR, how to perform. So this is how we place the child within the MR gantry, and we do cartilage weighted sequence. So what are we looking in the MR? So we'll try to identify the glenoid morphology, its types, and we'll again measure two angles on MR. First is a percentage of humeral head anterior to the transscapular line or dorsal scapular line, glenoid version, and lastly the humeral version. So this is how we will do the measurement of percentage of humeral head anterior to the scapular line. I will show you on next image. So again, when we get the stacks of axial imaging, we have to identify the single particular image on which we will try to draw these measurements. So what is that ideal image? So this is disappearing coracoid. When the coracoid is about to disappear, you just have to select the that particular axial section. So here there is a disappearing coracoid, and we'll take this section as an ideal axial image. And why we are selecting disappearing coracoid image? Because it exactly correlating with the center of the glenohumeral joint. So again, disappearing coracoid. Then this is one line which is connecting anterior to posterior glenoid. This is dorsal scapular line, and the angle between these two lines is a glenoid version. Now the percentage of humeral head anterior to the transscapular line. So these two lines will be drawn, and one more line which is connecting from anterior most convex point of the humeral head to the posterior most convex. And when the dorsal scapular line is bisecting this line, that if we put the point B, then BC upon AC would be the percentage of humeral head anterior to the transscapular line. So based on these two measurements, surgeons follows the Waters classification, and based on that they will classify the glenohumeral joint instability in type 1, type 2, type 4, type 5. So type 1, 2, 3 are the congruent joint, and type 4 and 5 will be non-congruent joints. So I will show you the example. This is Waters type 1, when the difference between the glenoid version is less than 5 degree. In type 2 it will be more than 5 degree. In type 3 there is associated posterior humeral subluxation, and in type 4 subluxation with there is a pseudoglenoid formation, and in type 5 it's a complete dislocation. So based on that, surgeon will decide their treatment plan. So if type 1 and type 1 to type 3, these are congruent joints, so they do the physiotherapies and some Botox injections to the internal rotators, and soft tissue minimal invasive subscapularis release, and And if 4 to 5, then these are non-congruent joint, then they have to perform the bony procedures like glenoid osteotomies, or in some cases humeral derotational osteotomies. So this is the outcome of the patient. The pre-op MR shows there is a pseudoglenoid formation, and in post-op MR the joint has become congruent. So still after doing all this rebalancing surgery, still some patient have a residual internal rotation contracture. So the probable cause of these persistent internal rotation posture could be because of the residual internal rotation contracture, or there is inadequate remodeling of the glenohumeral joint, or there might be the internal rotation arising from the humerus. So for addressing the internal rotation of the humerus, we do concomitant axial elbow imaging along with the shoulder imaging to evaluate the humeral shaft rotation in relation to the joint. So to do the concomitant imaging, we again identify two images. First, as we seen in the MR, axial image disappearing coracoid, and here the transepicondylar axis, and we impose both the images on both side and will do the measurement. So angle between these two line is arm internal rotation angle. So here the difference is 45 degree, and when we examine patient clinically, this is exactly matching with the clinical scenario. So in conclusion, use the ultrasound for in less than 1 year of age, in identify the infantile dislocation is there or not. If it is more than 1 year of age, do MR, remember the landmarks, do proper measurements, and what we are looking is glenoid dysplasia, dislocation, graded according to the Waters classification, and do concomitant elbow imaging for humeral torsion. Thank you.
Thank you so much, sir. Anyone has any question for Sir Joshi ma'am?
So the disc has to be centered in between the condyle and the mandibular fossa on coronal plane. When it becomes eccentric, and it is not one image that we see, it is a continuum that we see, and if there is an eccentricity, then we add a medial or a lateral component. So there is no objective differentiation like we have in anterior and posterior displacement for the medial and lateral component and coronal. It is just an add-on to my confidence, yes.
So we start with very less. We start with a pound or two because the patient is already in pain, and as soon as it starts complaining of pain, we stop it. We try and avoid it as far as possible. For obvious type 5s, we stop it. So the problem is initially they got only an AP radiograph of the shoulder. So that led to only a type 3 classification. They wanted a vertical stress bearing to see if it went to type 5. Now we have moved them, instead of doing a weight bearing one, we get an Alexander view and we try to take the distance between the two centers. And if it is already coming more than 7 or more than 14, we try avoiding the weight bearing ones, or try directing the patient for an MR rather than putting him through more pain. But again, some oldies, they just want it, so we try with the least possible ones, and as soon as the patient starts complaining of more pain than at baseline, we just stop. There's no fixed weight which we always give. Yeah.
But then we had a case of a patient complaining of a typical clicking sound, not a bony clicking, but a typical clicking sound involving the TM joint. And there was a pocket of joint fluid. only in the dynamic scan would we see that globule of fluid in the joint, it tend to move from interior to posterior and was responsible for that typical pat pat sound that the patient felt. So it could explain it much better. So then there are a set of cases where it actually explains and adds to the function.
We have some clinicians who are doing scoping for the hip joint, and they're asking for ambulance for the physiotherapy, and they ask for thickness of the retrodigital tissue. What exactly do you mean? Like the whole side band, or what exactly would be there?
I actually don't have experience with this because I don't have many surgeons who tissue. So why do they need the thickness of the retrodiscal tissue? Yeah, so we don't have many surgeons doing that. And whatever surgeries that I've seen in TM joint, they have done discectomies. The repairs, I doubt they do.
So if it is more than 13, once the inferior border of the clavicle goes above the superior border of the acromion, it is already more than 30. And if it is twice of that, 25 is the ballpark figure, more than 25 becomes type 5 automatically. So that is the problem. The entire thing between 2 and 5 gets automatically categorized as 3, and it includes both stable and unstable. That is why everyone is trying to sort it out to find ways how to convert them from just one big junk category to more manageable, clinically relevant things that can guide treatment decisions.